Can you hear me?
Yeah, Darshan.
Okay. I'll just see if the slides visible, ma'am?
Yeah.
Okay. So sorry guys. I don't know why today we are having a lot of technical glitches. It was never like this. Okay, coming to the approach of management. So initially, I told you severity. It is usually based on two techniques. That is the total body surface area in percentage, and then the other one is the depth of injury. So in total body surface area by percentage, I told you the three commonest things which we are using is Wallace's rule of nine, the Palmer rule, and the London Brado chart. And the accuracy wise, if you see, the London Browder chart seems to be the most accurate. And the depth of injury, when we are looking, usually it is classified based on whether it is superficial, epidermal, dermal, or deep injuries. Okay. So all most of the times whenever we are looking at this, usually we look at the timeline also. Okay, whether it is less than 24 to 48 hours or more than 48 hours. Why do we have to know? Because most of the signs and symptoms associated with burns are based on the involvement of the tissues, okay, especially the depth of the burn. Okay, so as the depth increases, the changes in signs and symptoms also changes. So if you remember this particular table, it will be really good. Okay, so if you see on the left hand side, I have made the layers of the skin. Okay, so it's the epidermal layer, superficial dermal, mid dermal, deep dermal, and the full thickness type of burn, depending on the involvement. Again, I will categorize various signs and symptoms based on color, presence of blisters, what happens to capillary refill, what happens to sensation, and what is the healing process, or how long would it take. Okay, and whether it requires surgery or not. Okay, usually blistering would be seen when the superficial or the mid-dermal involvement present. Okay, and it may or may not be present in deep dermal. So what you need to understand is whenever someone asks you where is blistering seen, it is usually when dermis is involved. It is not seen when epidermal type of burn or full thickness type of burn. Okay, whenever dermis is involved, only then we see blistering. Okay, and then capillary refill is usually not seen in deeper types of burns. Okay, so it will be brisk in superficial dermal to epidermal, and as it becomes deeper down, you will lose capillary refill. You cannot assess that. Okay, similarly, it is extremely painful type of a burn on palpation when it is epidermal and superficial dermal. Okay, usually because the pain receptors are present in this particular area, and as it goes deeper down, it will be pain insensitive. Okay, again, superficial by normal by understanding, we know that if it is a superficial type of burn, usually it requires very less time. Okay, less than 7 days probably would be enough. Usually if it is a deeper type of an injury, it will take prolonged time to healing, and probably even surgery would be required. Okay, so this is about the clinical presentation and assessment of severity of burn. If I ask you, okay, these two, if you write this slide and this slide should be enough in your exam. Okay, so London Browder, remember, it is the most accurate tool for assessment. Okay, why is it the most accurate? If you see this diagram, you'll understand. What happens is in younger age group, the weightage given for head and neck area is highest because that is the major part of the body. Okay, that body surface area. As age progresses, it starts reducing, and that's the reason over a period of timeline of age, they have reduced the weightage for this. Okay, so this is one of the reasons why they say that it is more accurate, because it changes dynamically the weightage for that particular body part as the patient ages. Okay, so that is one of the reasons London Browder chart is a more accurate, or it's the most accurate tool as compared to Palmer techniques or your Wallace's rule of nine. Okay, simply where the simplest one is rule of Wallace's rule of nine. Okay, the most accurate is London Browder. Okay, so Palmer technique, when you're using, no, usually it is for patients with lesser amount of burn, less than 15% of total body surface if it's involved, then probably you can use a Palmer technique. So the most important point take home here is usually patient's palm is the one which is taken. The second most important thing is patient's palm corresponds to 1% of total body surface area of involvement of burn. So this is one thing that you have to remember. It's the patient's palm, and the palmar surface is 1%. Okay. So this is about assessment of severity, clinical symptoms of burns patient. Now coming to categorization between minor and major burn. Minor burn usually will kill superficial type of burns and less than 10% of the total body surface area which will be involved. Usually they can be managed in an OPD patient basis, and maximum what you require is probably symptomatic care and wound care. Okay. Coming to major burns, okay, lot of societies define it differently. Okay, but one accepted thing is based on age group and based on the depth of involvement. Okay, so if you say it is more than 10% total body surface in elderly, 20% in adults, and more than 10% in children less than 14 years. Okay, so whenever we categorize major burn, there is no ambiguity that these patient needs hospitalization and probably intensive care therapy. Okay, so what does American Burn Association tell about major burns? Major burns are those patients who have a full thickness burn injury of more than 10% body surface area. If it is a partial thickness burn, it should be at least more than 20% of the total body surface area, especially in extremes of age. That is your pediatric patient and your geriatric patient. If it is only adults, roughly between the age of 16 and above or less than 60 years, then more than 25% of total body surface area involvement categorizes as major burn. Along with these things, if the patient has burns to the face, extreme a lot of burns on the hands, genitalia, perineum, and major joints, if they are involved, they also get categorized as major burns. Burns like inhalational injuries, chemical burns, electrical burns. Okay, and patients having even a minor burn with major coexisting medical disease, okay, be it uncontrolled chronic kidney disease, IHD, etc., they also can get categorized as major burns, because probably the resuscitation in these patients would be a little difficult and they might be dicey. Okay, that is one of the reasons they have categorized this as major burns. And burns associated with trauma is always categorized as major burns. Okay, so you can take a screenshot of this page. This is ABA's classification or categorization for major burns. Okay, 10% total body surface area, full thickness, 25% in adults, partial thickness, or 20% in extremes of age. Major joint involvement, face and perineum, genitalia, inhalational, chemical, electrical burns, or patient with uncontrolled chronic illnesses. All of them get categorized with major burns, and patients with trauma. So, what are the predictors of outcome? So, if they ask you this, probably if you write it in your theory papers, good enough. But remember two scores, okay? That is your box score or modified box score. This is something which helps you understand whether the patient has higher risk of mortality. Okay, box score of more than 40 to 50% usually has a higher risk of mortality. Okay, how does it get calculated? It is a combination of patient's age in years into burn size based on the total body surface area. Okay, so one example, if you say just taken a 50-year-old with a 40%, so remember 40% itself in a 50-year-old becomes 90, right? So that is a very high risk. Okay, so remember predictors of outcome. If they ask you this question in your practicals, so this is one thing. In theory also you can write this as one of the things. So write about assessment, after assessment, you can in the end you can write about predictors, and predictors box score or modified box score. Okay, remember that. Remember, a larger burn sign always correlates with worst outcomes. So how do we go about the further part of assessments? That is your primary survey. It's similar to what you do in trauma. Okay, so you have primary survey and secondary survey, and then further on your tertiary survey. Okay, so in primary survey, as we do it in trauma itself, we have the ABCDE approach which we do here. In airway, you have to look for potential inhalational injury, whether there is signs of any soot collected there. Okay, carbon monoxide poisoning, all of this you have to think about it. Okay, and then you have to look for signs of respiratory distress, if at all it is there. So if you find that this patient has some amount of potential inhalational injury risk, patient is drowsy, patient is having signs of respiratory distress, probably it's better to intubate this patient. Always have a low threshold for intubation. Coming to breathing and ventilation, I told you, if it's a closed space burns, okay, patient is having chemical burns, okay, probably a firecracker or a textile type of burns, etc., these patients are highly prone to develop carbon monoxide type of poisoning. Okay, look for signs of carbon monoxide poisoning. In such patients, probably it is better to start oxygen therapy, especially high flow oxygen. And if you feel there is some amount of respiratory distress, go ahead and intubate this patient. If your patient is unable to breathe because of some mechanical restriction, okay, that is because of a circumferential burn, probably these patients require escherotomy. Okay, that is about B. C, circulation. Always get two wide bore IV accesses. Check all peripheral pulses. Start this patient on crystalloids. Okay, and with all of this, start also looking at what is the uh, arterial blood gas analysis of this patient. Okay, so all of this should be important. What do you have to do in circulation? First, look for any impaired pulses. Okay, whether there is some problem with limb perfusion. If that is not there, then probably you can take your time, assess all the other issues. Okay, the major thing is there should not be any hampering or obstruction to flow, especially in the peripheral tissues. Okay, after all of this, obviously you have to look into the pcs of the patients, and then you have to remove all the exposure. Okay, so any textile or any clothing which is adherent to the tissues, or probably all those things have to be kept in mind. If the patient is having trauma or without trauma, you don't know what was the mode of injury whenever you have picked up the patient, always better to do log rolling for this patient with stabilization of the spine, with resuscitative measures, especially in your primary survey. When you have started your crystalloid resuscitation, keep the patient warm. Okay, hypothermia is one of the lethal triads of death, so try and avoid this as much as possible. Okay, along with this, you can already start your assessment of body surface area, all of that, how much burns, depth is there, all of this in exposure. So this is about the primary survey. In secondary survey, you make sure that you have resuscitated the patient, stabilized the patient, and after that you will look into all your coagulation profile, CBC, CBG, etc. Probably if the patient is having carbon monoxide poisoning, probably you might have to give 100% oxygen. You might have to look at all the other risks which will be ensuing in a case of carbon monoxide toxicity. Okay, look at coagulopathy if it is setting in. Okay, and also do your complete examination with POCUS, etc., which you routinely do for any other patient. Along with this, very important, make sure that this patient has received a tetanus prophylaxis. Okay, because most of the patients have an exposed wound, we do not know what would have entered there. So better, as any case of trauma, these patients also necessitate the requirement of tetanus prophylaxis. Coming to systemic effects, what happens in burns? You can categorize the systemic effects into metabolic, immunological, respiratory, or cardiovascular. Okay, so majorly it is because of the immune dysregulation which is happening, and the uh, hypometabolic followed by hypermetabolic phase of burns. Okay, so what will happen in the metabolic systemic effect? Usually there will be muscle breakdown. Okay, there will be suppression of growth hormone. Okay, and issues with respiratory system. Primarily it's hypoxic injury which could have happened because of inflammation. There might be bronchoconstriction. In severe cases, the patient can also develop ARDS. In cardiovascular, I told you initial phase would be cardiodepressant. At that particular time there will be a hyperdynamic circulation, and because in the later phases, due to resuscitation or otherwise because of immune dysregulation and capillary leak, the patient can have large volume fluid sequestration leading to edema. Okay, all of this would have a direct bearing on the cardiovascular system. So remember, initial phase in cardiovascular system is a depressive phase, and then probably the patient will start getting towards normalcy. Remember, there will be increased systemic vascular resistance earlier, and then it will start normalizing. So this is about cardiovascular system. Coming to immunological, I told you altered immunological state. Okay, so there will be issues with the release of stress hormones. Immunity would be altered. Okay, then there will be issues with gut barrier. Okay, the patient can develop something like a Curling's ulcer, etc. And because of all of this, there can also be gut translocation causing sepsis, like systemic sepsis, etc. So all of this is issues which is associated with burns. Okay, that is your systemic effects. If you are remembering it in a head to toe format, this picture actually gives you a very good idea. So cardiovascular effects: hypovolemia, myocardial depression, Okay, decreased cardiac output. Okay, burn shock lasting up to 48 hours. Capillary permeability would be increased. Dyselectrolytemia would be there. Tissue edema. In respiratory system, bronchoconstriction, ARDS. Peripheral perfusion, I told you, because of any SR which is being present. Okay, check for pulses. Because of hypovolemia, cardiac depression, decreased intravascular volume, AKI can be there. Poor perfusion, ileus would be there. Increased stress, GI ulceration can be there. Okay. Along with this, remember the hip bend flow phase. Okay. So if you can remember these systemic effects, it's more than enough. Okay. Either remember the earlier slide or this slide for systemic effects and burns. Coming to burn management. Okay. So management phases are roughly into 5 phases, but what in critical care we look at is the first 3 to 4 phases. Okay. The first phase is usually rehabilitation, and phase one, what we look into is a first aid. The basic first aid is to remove the patient from the site of burn, prevent hypothermia. At the same time, try and do some initial first aid with resuscitation, especially cooling whenever it's required. And the first primary survey and the secondary survey is what is usually firstly to cool the patient when there is risk of hyperthermia. Okay, at the same time, to prevent development of hypothermia, wrap and okay, especially when you have done your initial resuscitation, remove all the clothing and jewelry which can be causing any sort of further damage. Okay, especially in thermal burns and chemical burns, no, people tend to use homemade remedies. Okay, that should be looked into, documented if they have given it, because they themselves would have worsened the type of burn. Okay, the only thing which can be done is copious flushing, especially in terms of chemical burns. Do not use any neutralizing agent as much as possible. Okay, electrical burns, whenever you're looking at, please address the patient in the primary place of injury with an insulator, but most of the times we would not be the people in ICUs per se. What needs to be looked into is electrical burn, the entry wound, exit wound, and all such things, right, which will be very small. Okay, the type of injury also would be less, but systemic effects because of electrical burns will be very high. So these patients are more prone to develop rhabdomyolysis, acute kidney injury, hyperkalemia, etc. Okay, all these things should be looked into in phase one. Phase two usually revolves around fluid resuscitation in burns. Okay, this is one place where everyone is interested. So what do we do? What are the goals of fluid resuscitation? Restoration of intravascular volume, preservation of tissue perfusion, minimization of tissue edema. So this, if you write it in these headings, probably the examiner will understand that you know what you are dealing with. What do we use? The most widely used formula is the Parkland's formula. It is also endorsed by the American Burns Association. Okay, but of lately, based on multiple trials, what they have understood is the 4 ml per kg total body surface area, which the ABA recommends in the first 24 hours, can be an overkill. Okay, so generalizing this in all patients would not be uh, a good practice. Okay, so as of now, there is no evidence to put it down, but then it has also been associated with issues as well. Okay, so what is Parkland's formula? So it is 3 to 4 ml into total body surface area, that is the percentage of burn involved, into weight in kgs of the patient. How do we do that? First half of the calculated volume will be given in 8 hours. The second half will be given in 16 hours. Remember, the timing here, the first 8 hours, is not from the time of entry to the hospital, but on the contrary, it is the time the burn has occurred. Okay, so that is what is very important when you're writing Parkland formula. Okay, so when do we start? If they ask you, it is the first 8 hours response corresponds to the occurrence of burn. Okay, it's not from the time of arrival to ER or ICU. Coming to the choice of fluids, balanced crystalloids is the first choice. Okay, so we usually have only options like crystalloids, colloids, blood products, right? So as of now, major trials, what they're telling you is balanced crystalloids are the first line of treatment in the initial 24-hour period. Okay, only if you feel that the requirement of crystalloids is very high after 24 hours, you might consider the use of albumin, especially the 4.5% solution. Okay, so this is from one of the articles which I took it. So why are they telling this? Usually, I told you earlier on as well. What they said is with 4 ml, it can be a little. overestimation. Okay, so we don't know whether we have to do. So the best way forward is to keep a target, reassess the patient, and then hydrate the patient. Okay, so the best choice of fluid is balanced crystalloids. The other thing you can use is colloids. And when you're talking about colloids, the most common colloid which they have used is human albumin. That is your 4.5 solution. Okay. So, what are the clinical response rules that you're using for fluid resuscitation and burns? Improvement in sensorium, improvement in systolic blood pressure more than 100 millimeters of mercury, reduction in tachycardia and respiratory rate, and improvement in urine output. So urine output is actually one of the major endpoint targets which they are looking in fluid resuscitation. Okay, the target urine output would be usually around zero point 0.5 to 1 ml per kg per hour. Okay, so that is the goal that you need to have for fluid resuscitation in burns patient. Okay, so many formulas are there. You can remember this. So they categorize into first 24 hours and the second 24 hours. Majorly, the first 24 hours, especially in Parkland's formula, you use crystalloids followed by crystalloid or colloid. Okay, so that is what you can do. So if you remember one formula, it's more than enough. Okay, so you can remember other formulas like modified Brooks formula, Brooks formula, Evans formula, etc. Okay, so remember formulas, categorize them into colloids versus crystalloids. First 24 hours, majorly what they tell us to use crystalloids. Okay, only few things like Evans formula or your Brooks formula, they might tell you to use earlier colloid. Okay, otherwise, majorly it's crystalloid. Okay, so I told you earlier, major studies have been done. They told that 4 ml per kg body weight per body surface area of burns probably can be an overestimate. Probably that is one of the reasons they are looking at something called as goal directed fluid therapy. Why we are looking at it is because it's not just the fluid. Okay, if we are giving all the fluid therapy like what we do in Parkland formula, we are unable to reach the urine output criteria of zero point 0.5 ml per kg per hour. Then you have to look at alternate causes for AKI. It cannot be only IV fluids. Okay, so you shouldn't keep giving more crystalloids or colloids thinking that that is hypovolemia causing AKI or hypovolemia causing oliguria. Okay, so look at things like rhabdomyolysis, acute tuberous necrosis, etc. Another problem might be the shock which is present, right? The shock can be because of vasoplegia. I told you in the initial 24 to 48 hours is a low cardiac output state. Okay, so that might be one of the reasons. Probably you can give fluids with inotropes at that particular time. Okay, so that might offset the shock and then improve perfusion. So you have to look into this. Why do we have to look into this? Because two major complications of fluid therapy is what we are worried, especially in patients with burns. One major complication is compartment syndromes. It can be abdominal, it can be thoracic, okay, or it can be limb also. Okay, it's a polycompartment syndrome which can happen along with something called as fluid creep. Okay, because once the patient goes into this overload state, the mortality increases. So, coming to the question of fluid creep, what is fluid creep? It is nothing but unintended excessive administration of IV fluid during the treatment for burns. Okay, so this usually happens because of the capillary leak, which is seen in patients with burns with overzealous resuscitation in the first 24 to 48 hours period. Okay, and because of this, because of fluid creep, the patient can end up in organ malfunction. Okay, that is something like increased venous back pressure that can cause organ perfusion issues, or else it can be fluid overload causing organ issues like pulmonary edema, etc. Okay, so how do we know that this patient has ended up in fluid creep? Usually we'll see worsening of shock despite fluid therapy, then you'll see AKI also worsening with fluids. Okay, so patient would be edematous, patient would have pulmonary edema. Okay, and then patient can also develop electrolyte imbalances. For these issues, that compartment syndrome, vasoplegia, okay, all of these issues with overzealous treatment, the Scottish Burn Society came up with a very unique way of approach. Okay, this is, mind you, not universally accepted, but one way to use Parkland's formula for fluid resuscitation. Okay, so you can write this in your exam. Okay, so they say you can start at a lower end of Parkland formula, start with 2 ml per kg per body surface area. Okay, then calculate the urine output hourly. If it is less than 0.5 ml per kg per hour, give a fluid challenge of 250 ml. Okay, for every hour up to 3 hours. That is 250 plus 250 plus 250. If the patient is still hypotensive, probably you can start the patient with probably an inotrope like noradrenaline. Okay, in this meanwhile itself, if the patient improves, then continue with this. Okay, the same rate. If the patient has produced good urine output, that is between zero point 0.5 to 1 ml, keep the initial rate. If you're started at 2 ml, continue at 2 ml. If you're started at 4 ml, started at 4 ml. Okay. On the contrary, if it is very high, that is around 2 ml and above, reduce the fluid rate by 10%. And if it is more than that, reduce it by 25%. So this is a very structured way to assess the patient in the first 24 to 48-hour period. If you have done all of this, okay, and you followed your full fluid boluses, inotropes, and you feel that the fluid requirement is very high, at the end of 12 hours, if you feel that the cumulative requirement is more than 6 ml kg per total body surface area involved, then you can consider something called as a colloid. What do we do in that? You have to replace one third crystalloid regimen with 4.5% human albumin solution. Okay. So one third would be based on whatever fluid you have calculated. If it's 6 ml per kg or 4 ml per kg till now, how much ever you have given, one third of that value is what you can replace using a colloid solution. That is your 4.5 albumin. Okay. So you can write this as one of your uh, methods for fluid resuscitation in burns. So coming to role of colloids like albumin in burns, why do we do that? It helps in plasma volume expansion. It addresses the capillary leak, especially in patients whom the intravascular volume of retention would be reduced, right? So in these patients, probably leakage rates can be a little less as compared to other patients. It maintains the colloid osmotic pressure. It helps in improving the urine output, and the duration of effect compared to a crystalloid would be slightly higher. The expansion would roughly last around 6 to 10 hours. Okay. So that is the major role of albumin in burns. Remember, you can answer it under these headings. Okay. One, it's plasma volume expansion. It helps in addressing the capillary leak. It helps maintain the colloid osmotic pressure. It helps in maintaining the intravascular volume, thereby improving the urine output. It also helps by maintaining the intravascular volume because the plasma expansion, the half life, usually is between 6 to 10 hours. So it retains the fluid in the intravascular compartment as compared to crystalloid. So this is the role of albumin in burns. If you write these 5 points, it's good enough. Okay. If they ask you a focused question on role. Okay. So evidence, there have been multiple studies, okay, like the albumin study in 2004. Okay. What they could tell is probably the requirement of inotropes and improvement in hemodynamic stability was good. But as of now, based on a Cochrane review in 2011, there is insufficient evidence for long-term usage and mortality benefit with albumin. Okay. So that's the reason American Burn Association still does not universally recommend the use of albumin. Coming to burn wound management, that is your phase 3, topical antimicrobials, still not very great consensus. The thing is, reassess the wound every day, probably dressing on a routine basis. The gold standard approach is to do the grafting as early as possible when there is no sepsis, so that heat loss is prevented, hypothermia would be prevented, and issues associated with hypothermia can be prevented. Okay, so all of this is what is about the burn wound management. Rest is what you need to get a surgical consent and then think about later phases like rehabilitation, reconstructive surgeries, etc. Okay, that is based on splits and graft, whether it is partial or full thickness grafts. Okay, so this is about burn wound management. Coming to sepsis in burns. So how do we diagnose sepsis in burns? Correct, it is already a hyperinflammatory state. There's already an SIRS response. So American Burns Association, and there's another category, criteria called as the Mansarinus criteria. So both of them help us understand the diagnosis of sepsis in burns. The ABA criteria for sepsis is temperature more than 39 degrees Celsius or tachycardia of more than 110 beats per minute, progressive tachypnea, thrombocytopenia, hypoglycemia, or inability to continue enteral feeding for more than 24 hours. If you have at least three of these criteria, then you can think that this patient is having sepsis. Along with this, if you have any one of this, it should always be substantiated by either a culture positive infection or you have identified a source of pathology, or there is some clinical response to antimicrobial agent. If you have one of these also, along with the three of the prior one, that is your temperature, tachypnea, thrombocytopenia, hyperglycemia, and inability to tolerate fluids. Okay, with this, you can think that the patient is probably having sepsis in burns. The other one, which is a slightly simpler way to remember, is the Mann-Salina's criteria for burns sepsis. Tachycardia of more than 130 beats per minute, mean arterial pressure of less than 60 mm of Hg, base deficit of minus 7 or below, hypothermia that is less than 36 degrees Celsius, presence of inotropes or vasoactive medications, hyperglycemia. Okay, remember, as compared to other types of sepsis, hyperglycemia, that is a state of hypermetabolism, is considered a probability of sepsis in burns. Okay, so what we usually see is severe cases of sepsis, we see hypoglycemia commonly, but in burns we see hyperglycemia more commonly. Okay, so keep that in mind. Okay, so sepsis and burns, two criterias: the American Burn Association and the Mann-Salina's. Okay, so coming to the fourth phase, that is the supported phase. Okay, here what you need to do is optimization, probably offloading of fluids if at all it's required, weaning off pressors, nutritional optimization, maintaining your protein delivery. Okay, so pain management. Okay, and looking at probable complications and addressing them. All of this comes in supportive care. The last phase is rehabilitation, especially when there is joint issues involved, contractures involved, etc. Okay, and also looking at the social psychosocial impacts of burns. So this is usually the last phase of burns management, that is your rehabilitation. Okay, so start with assessment. Okay, first is assessment, primary survey, secondary survey. Then after that it's your fluid resuscitation. After fluid resuscitation, you think about your complications. Okay, so what are the complications that can happen, and burns wound management, development of sepsis. How do you categorize sepsis? Okay, use of American Burn Association or the Mann-Salina's criteria. What do you do with rehabilitation and supportive care? Okay, so that's about management of burns. There are at least four subheadings that I had to cover here, so it took quite a while. Okay, so this is about management of burns. Okay, do you guys have any question in particular about it? You can put it in the chat box. Okay, coming to the next topic, that is carbon monoxide toxicity. Uh, So we spoke about this when we were talking about burns, right? So that is one thing I thought I'll continue with it. Okay. So carbon monoxide is a colorless, odorless, and tasteless non-irritant gas which is produced because of incomplete combustion of a carbon-based fuel. Okay. So carbon-based fuels are present in a lot of places. It does not mean it is only in the petroleum or the oil-based industry. It also be present in your factory products, your garment industries, etc., crackers, so many places. Okay, so all these places, probably the patient or the person can be exposed. Even your day in and day out environmental pollution, there also we have a lot of combustible gas which can have carbon monoxide. Okay, so the cause of carbon monoxide toxicity can either be accidental or it can be an intentional poisoning. It has been one of the methods used for even suicides also. Okay, so what is the major issue with carbon monoxide poisoning? The major issue is the carbon monoxide binds to hemoglobin with roughly around 200 to 250 times the affinity as compared to oxygen. Okay, that's the reason it impairs the oxygen delivery and utilization, leading to tissue hypoxia and multi-organ dysfunction. It causes something like a hypoxic hypoxia to the patient. Okay, so the major pathophysiology is hypoxic hypoxia because of impaired oxygen delivery and utilization because of higher affinity of carbon monoxide to hemoglobin. Okay, so the major thing in critical care is rapid recognition, supportive care, and focused therapies for multi-organ dysfunction. So what happens, causes, I told you, right? It is present in a lot of places. It can be accidental, environmental exposure, occupational, intentional, or it can be hospital related, which is very rare. Okay, so environmental, it can be faulty heating systems. Okay, especially a gas geyser. Most of the people have come with us, and we had seen a few cases also recently. It's that improper ventilation with the use of a gas geyser can cause carbon monoxide poisoning, use of firewood, etc. Occupational injuries, especially in people like firefighters, industrial burns, okay, industrial gas leaks, etc. Intentional, I told you, right? Vehicle exhaust, okay, that can be used for a suicidal method of carbon monoxide toxicity. And hospital related, especially in few equipment which has compressed gas, so faulty equipment can cause carbon monoxide toxicity. Coming to toxicokinetics associated with carbon monoxide poisoning. So carbon monoxide is a gas at normal room temperature, and it is inhaled from the lungs and it is out. Okay, so minimal issues, no problem. Okay, minimal. It's when the amount of carbon monoxide is very high, what usually happens is it goes and binds to hemoglobin. I told you earlier, the affinity is very high. Okay, 230 to 270 times that of. Remember the range between 230 to 250. That's more than enough. Okay, so that causes carboxyhemoglobin. Okay, so once carboxyhemoglobin is formed in the RBCs, what happens is it hampers the delivery of oxygen and utilization of oxygen, and because of which there will be a loss of sequelae of events which happen. Okay, it can cause issues leading to uh, cardiac dysfunction, pulmonary dysfunction, neurological dysfunction. All of this can be ensued because of hypoxia. Okay, so majorly why it happens is because this carbon monoxide which is present, less than 1% will get converted to carbon dioxide, and it just remains as carbon monoxide. Okay, so that is the reason it gets retained in the body and causes multi-organ failure. So how does it cause this? It binds to hemoglobin to form carboxyhemoglobin and shifts the oxyhemoglobin, the curve. Okay, oxygen hemoglobin dissociation curve towards the left side. Okay, and because of which there will be impaired delivery, which happens. And when there is impaired delivery, hypoxia, which happens, the electron transport chain gets hampered in the mitochondria. So because of this issue, there will be impaired oxidative phosphorylation leading to cellular hypoxia. And when cellular hypoxia happens, it is a global phenomenon, and because of which it triggers an inflammatory response. Okay, so there will be lipid peroxidation, activation of leukocytes, inflammatory response. Okay, all of this. And as a counter regulatory mechanism, what happens? There will be release of nitric oxide as well. Okay, all of this triggers a neurological sequelae. The patient goes initially into an altered sensorium and probably can become unresponsive in the long run if we have not treated at the right time. Okay, usually the major two organs which are involved in carbon monoxide poisoning are CNS and heart. Okay, in CNS you develop encephalopathy and cognitive defects, majorly because it involves the global pallidus, hippocampus, and cerebral white matter. In myocardial issues, what we look in is ischemia, arrhythmia, and in the later phases of extreme hypoxia, because of lipid peroxidation, etc., the patient can develop cardiogenic shock. Okay, so this is the pathophysiology. Okay, remember the toxicokinetics or pathophysiology. If you remember this slide, it's more than enough. Remember, the affinity of carbon monoxide to hemoglobin is very high. It forms carboxyhemoglobin, shifts the oxygen dissociation curve to left side, cellular hypoxia, inflammatory response, multi-organ involvement, especially two major organs, CNS and heart. Okay, this is about pathophysiology of carbon monoxide toxicity. How do we diagnose? What do we do? Okay, so majorly you have to have a clinical suspicion. So when someone gives you a history, based on the history itself, you need to look at exposure. Once you have to go similar to ABCD here also. Okay, so airway, breathing, and circulation has to be optimized. Then look at other issues. Okay, if the patient has come with a closed room space of unresponsiveness, dizziness, unexplained headache, etc., then you need to dig in the history and find these. The same time, examine the patient. Okay, at examination, you have to look at probable cherry red sign. Usually, skin changes are seen. Okay, but they occur quite late. Okay, roughly around 16 to 20 hours and above is when they develop cherry red's color of the skin. But signs of hypoxia will be very glaringly present, that is tachycardia, altered mental status, etc. Okay, cardiac depression. So how do we come to a diagnosis? Majorly, the tool used is co-oximetry. Okay, that is the gold standard for assessing the carboxyhemoglobin value. Okay, less than 2% in non-smokers is normal. In smokers, the normal value is less than 10%. Okay, remember this value, they will ask you. Okay, smokers 10% and below, non-smokers 2% and below. When does symptoms occur in carbon monoxide toxicity? Usually it is present when the carbon monoxide levels go more than 25% involvement. That is, your carboxyhemoglobin should be more than 25%. Okay, if it goes more than 50%, it can be life threatening. I have a slide to show how the symptoms worsen. Okay, I told you earlier, co-oximetry is the tool of choice. ABG, probably the only thing which will look in and find is elevated lactate, metabolic acidosis. Other things, other tests like your CBC, renal function test, etc., would be required. Okay, all of this also have to be done. Okay, along with focused diagnostic for if there is altered mental status, you have to rule out stroke, etc. Also, okay, you need to do an imaging, probably to find out alternate causes for encephalopathy. Cardia, definitely go ahead and do an ECG first and look for signs of ischemia. You can also use your echo. Okay, so I was talking to you earlier, more than 25% of carboxyhemoglobin, there is a high chances of symptoms occurring. And more than 50% of carboxyhemoglobin, definitely it will be detrimental and risky. Okay. So this is one thing that you need to keep in mind. So usually when the carboxyhemoglobin level is more than 20 onwards, you'll start seeing CNS symptoms first. Okay, so CNS symptoms precede CVS symptoms. CVS symptoms usually occur at a higher carboxyhemoglobin rate, so roughly around more than 50. Okay, so that is when that starts worsening. Okay, so this is about the clinical examination of a patient with carbon monoxide toxicity. Coming to the treatment of carbon monoxide toxicity, majorly remember it under three headings. What do we do for gas exchange? What do we do about scavenging? What are the trial drugs which are available? Majorly, I told you what is the problem here: carboxyhemoglobin. That is the culprit here. That is because it has a higher affinity for hemoglobin. So first and foremost, try and give oxygen, 100% oxygen, non-rebreather, high flow oxygen therapy, etc. Okay. So remember, if you're giving only room air, the patient will take roughly around 4 to 6 hours to become normal. 100% oxygen, you can reduce the time limit to up 60 to 90 minutes. If you give hyperbaric oxygen at probably 2 to 3 atmospheres pressure, that can be reduced to 20 to 30 minutes. You can normalize the carboxyhemoglobin level less than 10%. Okay, so this is the main part of management of carbon monoxide toxicity. Okay, so I told you earlier, oxygen therapy is the main pillar. Okay, so by giving 100% oxygen, probably you can try and control worsening issues of this patient to probably in 1 or 2 hours. Okay, if you have hyperbaric oxygen therapy, then go ahead. Probably that has a good effect in reducing the timeline needed for treatment. Okay, I will talk about evidence for HBOT in the next slides. So indications for the use of HBOT or hyperbaric oxygen therapy is usually when the carboxyhemoglobin is more than 20%, or in pregnant patients if it's more than 50%. Okay. Why are we worried in pregnancy? Is because both mother and fetus are at risk. Okay. Probably fetal hypoxia is what we're more worried, and that's why we have a lower threshold for initiation of hyperbaric oxygen therapy. Okay. Other places where it is required is cardiac dysfunction. Whenever you feel that carboxyhemoglobin is the issue for cardiac depression, associated shock, and arrhythmia, that is one of place. Persistent metabolic acidosis despite resuscitation and oxygenation, that is another place where you can think about use of hyperbaric oxygen therapy. So what does it do? It enhances carbon monoxide elimination, restores the mitochondrial function, reduces the risk of neurological sequelae. I told you earlier what we usually do is give a 2.5 to 3 atmosphere pressure, okay, and then we give multiple sessions of hyperbaric oxygen therapy. It's not give this and continue it for a long period, probably 1 hour period or 2 hours period, something like that. Okay, it's a session of HBOT that we usually do. it does is it gives 100% oxygen in a supraatmospheric pressure condition, like 2 or 3 atmospheres, wherein the time required to reduce the half-life of carboxyhemoglobin is reduced from hours to minutes. Here in HBOT, it will be reduced to around 30 minutes. Okay, so this is about HBOT. So what are the principles, or what are the evidence why HBOT works is it alters the neutrophil mechanism because of the SIRS, which ends up because of carboxyhemoglobin, and prevents vascular endothelial issues. I told you earlier also, right? Because there will be issues with the endothelial surface, there will be lipid peroxidation, there will be delivery of nitric oxide, etc. All of this would be offset, okay, when you initiate the patient on hyperbaric oxygen therapy. Free radical mediated oxidative damage can be reduced. Neurological deficit can be prevented. Okay, this is one place we are always worried, right? Because the time is very less. Okay, why does this happen? Because the tissue oxygen tension would be achieved at a faster rate as compared to normobaric oxygen therapy. Okay, and when we make sure that hypoxia is offset, when the blood supply and hypoxia utilization becomes normal, then ATP production would be normalized, and then subsequent issues which is happening because of tissue hypoxia would be offset, and that helps the patient recover. Okay, so most of the times what happened, why we initiate HPOT earlier, is because cognitive dysfunction, whenever they have seen with carbon monoxide poisoning, can be very trivial in the beginning, okay, which we cannot pick it up. But later on, what they say, cognitive sequelae have been persistent even up to the timeline of 1 year. Okay. So, what is the evidence? If we are saying HPOT is very good, should we refer all carbon monoxide patients? Probably it is not practically correct. And another thing is, we do not have HPOT widely available. Many trials have been done. As of now, there is no direct evidence to tell HPOT is, mandatory as a guideline for the treatment of carbon monoxide toxicity. Definitely, it has shown some benefit in earlier resolution of the carboxyhemoglobin to less than 10%. But by and large, it is a plus minus right now. Okay, there are pro and anti trials. Okay, coming to the next treatment strategy, that is your scavenging therapies. These are still trial based. Okay, so similar to what we see in anesthetic drugs, like the and local anesthesia, etc., wherein we look at a link model, right? It is one of those things that we are looking at. Okay, this is also one way wherein a hemoprotein based scavenger, okay, is a small molecule which sequesters the carboxy hemoglobin. Okay, so what it does is it removes the carbon monoxide from the circulating hemoglobin, okay, and then removes it from the circulatory system. So this is where the therapeutics are going at molecular therapeutics. Okay, by and large, how can we do it? It is like a hemofiltration technique that they are trying to do it as of now. Okay, hemoadsorption techniques, I'm sorry. So by one thing you can remember is, along with the hemoprotein which I mentioned earlier, another thing is cyclodextrin. Okay, so cyclodextrin acts like a sink, okay, that helps to remove the carbon monoxide from the body. So oxygen therapy, carbon monoxide scavenging treatment. The pharmacotherapy associated with carbon monoxide toxicity is still in animal trials. Okay, still by and large there is no great evidence. Nothing more than oxygen is required. Rest of the treatment in carbon monoxide poisoning would be symptomatic care. Only in cases with patients with cardiac dysfunction, there is a role for levosimendan, but again, that is a case by case scenario. By and large, you have to treat all these patients like how you treat any case with encephalopathy or cardiac dysfunction, fluids, endoscopes, etc. Okay, and proper cardiac monitoring. Okay, uh, after looking at the focused treatment for carbon monoxide toxicity, then we talk about supportive ICU care. I told you earlier, carbon monoxide toxicity is similar to a case of trauma. ABC always takes precedence. You have to do that. Watch for seizures, look for silent seizures or non-epileptic status epilepticus. Okay, so all of this non-convulsive status epilepticus, I'm sorry. Okay, so all of these things you need to closely monitor. patients are at a higher risk of developing cerebral edema. So neuroprotective treatment has to go on, especially when the patient becomes comatose. Okay. So along with this, fluid management, hemodynamic management, and looking at cardiac output, all of this can be done. Okay. I told you earlier, long-term sequelae are looked in these patients. So probably patient has to undergo a neuropsychological evaluation once the acute phase has stopped. Okay. So cardiac evaluation also may be needed in the long term. So these are because there will be irreversible damage which happens both to the neuron and the cardiac myocyte. Okay. This is about carbon monoxide toxicity. Okay. So one thing I want to ask, you all have asked about saturation gap. So can anyone comment in the chat box where do you see saturation gap? Okay. So Anshul has typed it as in carbon monoxide poisoning. Is there saturation gap in any other place that you see? Uh, Is there a role for saturation gap in carbon monoxide poisoning? Okay. Any hemoglobinopathies, right? We think of using it. Okay. So I'm sorry, but the thing is, saturation gap, you remember, it's the difference between the oxygen saturation measured by the pulse oximetry compared to the ABG calculated oxygen saturation, that is your SaO2. It is SpO2 minus the SaO2. Usually it should be 5%, okay, and below. If it is more than 5%, then you have to think about dyshemoglobinemia. That will be abnormal hemoglobin. Okay. So when we are talking about abnormal hemoglobin forms, obviously you'll think carbon monoxide, carboxyhemoglobin is one such issues. Okay. But unfortunately, here what happens is the AbCO2, if you have taken for a carbon monoxide patient, no, it usually is normal. It gets stuck. It fixates at between 85 and above. If you, on the other hand, if you use it, okay, for a methemoglobin patient, there the saturation gap will be elevated. Okay. So what usually happens is in methemoglobinemia, it will be useful. That is because it will be higher and there you can pick it up. But in carboxyhemoglobin, what happens is the pulse oximeter, right? It can pick the wavelength in the same place. Okay, so it will not have a SaO2, which SpO2, which is low. It will get fixated as normal, or it will falsely show as high. Okay, so that is one of the reasons why the gap will not change. Okay, and it can be erroneous. Okay, I'll repeat myself. In carbon monoxide poisoning, the SpO2, the pulse ox, can be showing a falsely normal value or a higher value as compared to what actually is. Okay, so that is the reason it can be erroneous, and you might not see a saturation gap. Okay, whereas in methemoglobinemia, it drops, the saturation drops initially up to 88, 85%, and it fixes at that particular time. Okay, with this, based on the amount of methemoglobin, you can calculate the saturation gap. So the response to treatment with methylene blue, you can see by improvement of saturation gap in methemoglobinemia, whereas in carbon monoxide poisoning, you do not have any role for saturation gap. Okay, so this is the practical tip I just wanted to remember. Am I clear about it? Okay, this is about carbon monoxide toxicity. Okay. So someone, I think so, Dr. Shriyari has answered. Thank you about the role of prophylactic antibiotics in burns. Routinely, it's not recommended. Okay. So coming to the next topic in the presentation. Okay, it's about heat stroke, burns, carbon monoxide toxicity, heat stroke. All of these can be your small questions. Okay, and questions can be a tricky one if you have not studied. Okay, you'll be able to answer something, but focused answering is what necessary. Okay, so to understand what stroke, first you need to understand a few basic definitions like fever. Okay, so fever, as we all know, is temperature elevation due to activity of the hypothalamus in response to some sort of an inflammation released cytokines, and then they cause all these changes. Okay, so it can be infective or it can be a sterile inflammation also. Hyperthermia is a condition which is caused due to uncontrolled heat generation. Okay, so this can be because of vascular hyperactivity, etc. Okay, so what is heat stroke? Okay, there is Japanese acute medicine classification or Buchama's definition for heat stroke. Okay, heat stroke is a disease caused by imbalance of heat generation versus heat clearance from the body without an primary underlying cause. Okay, the patient was absolutely normal. Okay, suddenly there will be a overproduction of heat wherein the body is unable to clear out that heat and the heat gets retained in the body. This imbalance between generation and clearance causes systemic issues, which is called as heat stroke. Okay, I'm repeating myself. It is a disease caused by an imbalance because of heat generation versus heat clearance from the body with a person without a primary underlying cause. How do we define it? Okay, clinically, it is defined based on temperature usually being more than 40 degrees Celsius or 104 Fahrenheit, presence of neurological manifestations like seizure, altered mental status, imbalance, or it can be caused primarily because of in the background of exertion or exposure. Okay, A, B will happen in the presence of C. Okay, so I told you earlier, Buchama's definition is what I discussed with you. There is another definition that is your Japanese Association of Acute Medicine and Heat Stroke working group criteria. Okay, basically there should be firstly an exposure. Okay, it is an acute event associated with some sort of increased muscular activity or exposure to heat. There's increased production, decreased clearance. Temperature of the body will be usually more than 40 degrees Celsius, okay, or 104 degree Fahrenheit, causing some sort of a CNS abnormality majorly, which is seizures, confusion, or probably imbalance. What Japanese system involved is other systems. Okay, here Buchama took only central nervous system, but they said that there might be acute kidney injury or DIC, which can also be present because of either hepatic or renal impairment present due to increased temperature. Okay, so this is about the definition for heat stroke. Okay, if you remember exposure history causing fever or temperature more than, don't call it fever, call it as temperature more than 40 degrees Celsius or 104 degree Fahrenheit, causing neurological sequelae or organ failure. Organ failure, what all are there? CNS, coagulopathy, AKI. Okay, so this is one thing you can remember about definition of heat stroke. Is there a classification? Yes, probably it's one way to think about it. Is exertional or a non-exertional? So exertional is what I told you, rigorous physical activity, especially seen in soldiers, athletes, marathon runners, etc. Okay, these are the people who are prone to develop heat stroke. Okay, non-exertional are seen in patients with alcoholism, obese individuals. Okay, even with no physical activity, when they are exposed to some sort of heat atmosphere, they are also at a risk of developing heat stroke. So how do we manage heat stroke? Always remember, it starts with ABCs first. Start cooling the patient, look for organ failure, treat and prevent. Okay, that is what we go with management of heat stroke. So firstly, when you have high temperature, altered mental status, evaluate the cause. Okay, you look at the history, and if these two are present, check your finger glucose test, rule out possibility of hypoglycemia causing altered mental status. Okay, look for electrolyte imbalances, do all your basic lab panels. Okay, always do cultures in these patients and look for intoxication as well. You need to rule out all of this, and heat stroke becomes a diagnosis of exclusion when all the other things which I told you earlier is ruled out. Okay, so why do we do a blood panel and all of this? Patient is basically, you need to rule out all of this, and then we come to a diagnosis of heat stroke based on ruling out criteria. So what is the first step? I told you ABC. After ABCs, it is cooling the patient. Cooling you can do by surface cooling or intravascular. You give the patient IV. Okay. So if the patient comes to your ER, if the ABCs are managed and the patient is still a little conscious oriented and able to maintain his airway, best possible thing is to immerse this patient in a nice bath if it is available. If you don't have it, use a body bag, put the patient in the bag, fill the bag with cold water, okay, and add some ice into it, whatever you have. If you don't have that also, probably it's better to cover this patient in multiple plastic sheets, and then add ice into that. Okay, it's like a wrap. Okay, like a burrito wrap which you see, right? It's something like that. That's why it's called as a tarp taco. Okay, so and this is one of the other ways you can do surface cooling. Okay, along with this, if you don't have any of this, try and put a lot of wet blankets on this patient, and use convective methods like putting a fan, etc., to reduce the temperature. Okay, so it is called as an evaporative type of cooling. So what are the types of cooling? If you've understood all of this, it can be categorized as conductive cooling and an evaporative cooling. Evaporative cooling, I told you, put a blanket, use fan or air blower to reduce the temperature. In conductive cooling, the ones which we talked about earlier. Okay, so it can be internal or surface. Surface is what I told you about: immersive ice baths, ice packs, cooling blankets. Okay, especially when you have ice packs, etc., they tell you have to keep it in the groin area, axillary area, nape of the neck, etc., wherein it will help in reducing the temperature at a faster pace. Internally, if you're trying to do conductive cooling, it is by cold crystalloids and intravascular balloon catheter system. Okay, these are things which require expertise. The best thing is practically what we can do is cold crystalloids. Okay, so how do we do the cold crystalloids? Numerous studies have been done wherein they use chilled crystalloid, that is a temperature between 0 to 4 degrees Celsius, to reduce the core body temperature roughly to around 1 degree centigrade per liter of crystalloid. Okay, so if you're giving it at a 30 to 40 ml per kg, it will cause around 2 degrees Celsius drop. Remember, for heat stroke, IV, if you're giving cold crystalloids, one, the temperature of the crystalloid should be between 0 to 4 degrees Celsius. What do? Usually, you can use your 30 to 40 ml per kg itself. Okay, because you're going to reassess the patient the first 2 hours. Okay, the whole thing is in the first 2 to 3 hour period, you want to drop the temperature at least by 1 to 2 degrees Celsius, and by doing so with around 0 to 4 degrees Celsius of cold crystalloid, you can at least get a drop by 1 degree per liter of crystalloid. Okay, majorly along with this, better to use a multimodal, that is, do both evaporative cooling, conductive cooling. In conductive cooling, do internal cooling, surface cooling. Do whatever is possible, but always keep a watch on the temperature. Okay, that is what is the ultimate goal in heat stroke. Okay, like how we talked about oxygen therapy and carbon monoxide toxicity, each issue has its pillar of treatment, and pillar of treatment for heat stroke is cooling. Okay, so what do we do? When we do all of this, you need to monitor temperature. That is the most important target that we are having. Okay, so what the best way, okay, so is to use a esophageal probe or a bladder probe. Okay, to check the temperature when if it is available. Rectal temperature can also be monitored, but usually it has a lag time. Okay, so that is one thing you need to remember. Okay, what are the temperature goals? Let me tell you. Okay, so try and achieve the drop in temperature to roughly around 38 degrees Celsius within 1 to 2 hours, or as rapidly as possible. Okay, whenever it is there, it is always possible the patient can switch back to hypothermia as soon as you stop this. So you have to keep a watch on this patient and always monitor to prevent any overshoot. Okay, overshoot can be two things. Once when you have stopped, it can go back to more than 40 degrees, or else if you have given too much of cooling, it can drop below 36 degrees. Okay, both are detrimental, so you have to be very careful and have a close monitoring. More close monitoring is only possible when you have an accurate system of monitoring for temperature. Okay, always whenever this is present, first 6 hours is what is mandatory to have temperature monitoring, but it's always better to have it up to 24 hours. Okay, so what are the organ dysfunctions which we see in heat stroke? It can be rhabdomyolysis, hepatic failure. Okay, it can be as bad as requiring transplants. Okay, so we have to be very careful when we are looking at patient can present with acute fulminant hepatic failure. Okay, seizures, aspiration pneumonia, stress induced cardiomyopathy, arrhythmias, etc. These are the organ dysfunctions which are associated with heat stroke, along with coagulopathy, hypoglycemia, hyponatremia. Okay. So management is symptomatic care. Okay. So initially you have to closely monitor temperature, look for dyselectrolytemia, look for hypoglycemia, watch for coagulopathy, monitor GCS, rule out non-convulsive status epilepticus. Okay, neuroprotective measures, IV hydration. All of this is the supportive care that has to be looked into. And if at all any of these happens in the due time, if their patient is not responding, next subsequent care should be done as per routine principles for that particular organ failure. Okay, so prevention is very important. Okay, especially this is seen in marathon runners, etc., or patients who are in a closed atmosphere, obese patients, alcoholics, etc. Okay, and patients who are going to some sort of excessive cardiac activity. Nowadays there's high rocks, etc. Right, all of these things can cause hypothermia. So these patients have to be educated about hydration therapies. Okay, and whenever they are traveling, etc., probably they have to use light colored clothing, limit outdoor activities as much as possible, and use air conditioner whenever it's present. Okay, so few drugs can mimic this. Okay, especially like serotonin syndrome, hyperthyroidism, all of this can mimic this, like a heat stroke. Okay, so you need to be aware of these things. Okay, you need to ask the complete detailed history of the patient on what medications these patients are. If they're taking that, first rule out that is causing this, and then if it is there, probably these medicines have to be altered. So this is about heat stroke. Okay, any questions until now? So, by and large, I have completed most of the topics related to basic trauma and toxicology. Okay, so the next important thing in trauma is what is your trauma-induced coagulopathy, hemorrhagic shock, damage control resuscitation, and MTP. Okay, that is what I'm going to deal with next. Any questions you guys have? Okay, Vishal has asked about, yeah, okay, he's mentioned it. Yes, hyperbaric oxygen therapy, correct. Practically, it's not available always. High flow oxygen is always good. Okay, it's always better as a modality for carbon monoxide toxicity. Okay, so coming to the next topic, that is trauma-induced coagulopathy. Is my slide visible? Okay. So, trauma induced coagulopathy, by definition, is a complex coagulation disorder that occurs after severe trauma. Okay. It is categorized by dysregulated clot formation and breakdown. Okay. So, it is similar to what happens in burns, right? It's a dysregulated response to an event. Okay. In burns, it was inflammatory response. Okay. Here, you are seeing a problem with the coagulation pathway. So what happens in trauma-induced coagulopathy? It can be either a hypocoagulable disorder or a hypercoagulable disorder. Okay, so that is the definition of trauma-induced coagulopathy. Okay, major trauma causing complex coagulative disorder characterized by dysregulated clot formation and breakdown. It can be either hypo or hypercoagulable state. Coming to pathophysiology, what is the major issue here? The first and foremost is the trigger, that is your primary drivers. Tissue injury, as soon as there is a major trauma, there's a outburst of tissue factor release. Okay, that triggers the coagulation cascade, that is your extrinsic pathway. Okay, along with this there will be some amount of hypovolemia, acidosis, hypothermia. All of this, along with your resuscitative effort, causes some amount of shock and hypoperfusion to the organs. Along with this, there will be, if things are not kept in check, this will lead to endothelial injury because of disruption of the endothelial barrier, leading to abnormal activation of platelets and coagulation pathway. So, what are the major mechanisms by which TIC or trauma induced coagulopathy happens? it can be hyperfibrinolysis. Okay, that is excessive tissue plasminogen activator presence, which breaks down the fibrin clots. Usually, a clot has to form and prevent bleeding, but because of excessive presence of TPA, this clot breaks down and patient ends up bleeding again. So that is one, that is hyperfibrinolysis. The second one is platelets are present but they are dysfunctional. Okay, sometimes the number can be normal, or some, on the other hand, it can be reduced as well. Okay, so this is one more reason why there can be trauma induced coagulopathy. Majorly when we are talking about platelets in trauma, it can be dilutional thrombocytopenia. That is usually in the second half phase when you have resuscitated the patient with some amount of resuscitative fluids. It can be your crystalloids, blood, or a combination of both. The other mechanism is coagulation factor depletion. Okay, it leads to a DIC like state. Along with this, there will be an inflammation thrombosis crosstalk. Okay, there will be complement activation and inflammatory pathway which gets exacerbated, and that is one reason where you will see a hyperfibrinolytic pathway. Okay, I told you it can be both bleeding type, clotting type, right? So sometimes because of this crosstalk, what happens, there will be a clotting type of trauma induced coagulopathy which can also be present. If we don't check all of this, the patient can end up in the lethal triad of death, which is characterized by hypothermia, acidosis, and coagulopathy. Okay, so remember this part. Okay, this is basically about pathophysiology of trauma-induced coagulopathy. I'll put in another slide which will help you understand. Okay, this, if they ask you about this, start about major trauma. There'll be three major problems. Okay, one is the shock, bleeding, tissue damage. Okay, tissue damage causes endothelial activation, neurohumoral activation. Both of this ends up causing platelet dysfunction and hyperfibrinolysis. Bleeding, what does it cause? It causes consumption of clotting factors. It causes hypocoagulation. Shock, what happens? We start resuscitating the patient. And because of shock, there is acidosis also. And once we start resuscitation, there will be hypothermia also. Okay. All of this will also worsen the clotting factors, which causes dilutional thrombocytopenia, dilution of clotting factors. All of this will end up causing hypocoagulation again. So because of these three major in initial triggers, there will be hypocoagulation, platelet dysfunction, hyperfibrinolysin, which causes trauma-induced coagulopathy. Okay, so if you can remember this: shock, bleeding, tissue damage causing hypocoagulation, platelet dysfunction, and hyperfibrinolysis, that causes trauma-induced coagulopathy. So if you write this much in exam, it's more than enough. Okay. So what are the stages? Okay, so initially you will see acute traumatic coagulopathy. Okay, followed by your resuscitative effects causing dilution of clotting factors, metabolic acidosis, interstitial edema, and hypothermia. And later on, you will see issues like trauma induced coagulopathy. Okay, so that is what usually happens. Along with this, what are the factors which worsen TIC? Elderly patients, male predilection is there, patients with pre existing issues requiring oral anticoagulation, patients with traumatic brain injury. All of these patients, along with some amount of genetic predisposition, they are known to develop trauma induced coagulopathy. Okay, so these are the stages of TIC. Okay, so if they ask you stages, you can write that, and you can also write telling that it is categorized as early TIC and late TIC. Early TIC is usually less than 6 hours. Okay, so it is usually of the bleeding variant. The late TIC is usually between 6 to 24 hours. It is a clotting type. Okay, so if you can see here, the tag also is given there for you to understand it better. Okay, what usually happens in the early TIC is hyperfibrinolytic pathway. Okay, clot is forming but it is unable to sustain. Okay, there's an increased TPA presence. So at this stage in early TIC, there comes a role for tranexamic acid. Okay, so if you see the ATLS guidelines and TBI guidelines, and if you see about the role of tranexamic acid, they always say it is best given or best beneficial if it is given less than 3 hours. Correct? So this helps us understand, it correlates, right? So this is about early TIC. Late TIC is usually the clotting type. Okay, there'll be a coagulopathy because of the crosstalk that I was talking about earlier, inflammation, thrombosis, crosstalk, which happens. So in this particular patient, we need to look at the TEG, reassess, look for microthrombi, look at organ perfusion issues like acute kidney injury, encephalopathy, okay, all of this, and treat it accordingly. So this is about early TIC and late TIC. Coming to the effects of hypothermia and clotting. Till now, we were talking only about resuscitative effects, tissue factors, shock, bleeding, etc. But we told lethal triad of death usually has two other important things, one of which is hypothermia, correct? What does hypothermia do for clotting? So, whenever there is a bleeding which happens, the coagulation cascade is activated. And this cascade of enzymes are temperature sensitive. Usually, they're best in action when they are working at the temperature of 37 degrees Celsius. Okay. If there is hypothermia, okay, say it drops to less than 36 degrees Celsius, it's between 33 to 36, that is a moderate hypothermia. 50% of your enzymatic activity will be lost. If it drops below 30%, there will be bleeding type of a coagulopathy which can be seen. It is majorly because enzymes are not working. Okay, so one of the drawbacks of TEG is this. If you feel that the TEG is normal but the patient is still bleeding, please look at the temperature of the patient. Okay, one of the drawbacks is TEG always normalizes the temperature, then check the enzymes activity. Okay, here, whenever you are having a bleeder present, look at this as well. Okay, because temperature also adds to the enzymatic machinery's functionality. Okay, factor 7A, which is the earliest factor to get depleted, or the a factor which has the shortest half life, is the most vulnerable one. Okay, and it is highly temperature sensitive. If this is not present, the rest of the clotting cascade would not work properly. Okay, so this is the role of hypothermia on clotting. Coming to platelet function, what happens? Similar to what we see in enzyme machinery. Whenever there is hypothermia, adhesion of platelets, production of thromboxane, okay, and the aggregation of platelet, all of this would be reduced. Okay, what happens in hypothermia is the possibility of this getting delivered to the liver and the spleen for sequestration becomes higher. Okay, so this is one thing that we need to remember about the effects of hypothermia on the clotting mechanism. What happens to fibrinolysis? Okay, in fibrinolysis, again, plasmin activity is not very much affected. Okay, so majorly clot breakdown does not happen. The clot itself is not formed. That is what is the major issue. But on the same time, okay, if the temperature is too low, if the clotting factors, the quality is not good, that itself can cause a breakdown, and that can result in fibrinolysis. Okay, so if someone asks you a question on what are the effects of hypothermia on clotting, answer them on three headings. Okay, so any clotting, you have to talk about clotting factors first, that is your temperature dependent enzymatic kinetics. Next, after clotting factors, you have to talk about platelet function, correct? So first clotting factors, platelets, then the final clot which is formed, that is your fibrin. So you talk in these headings. Okay, so temperature, platelet function, and fibrinolysis. Okay, so remember, major effects is on clotting factors and platelets. Okay, coming to the effect of acidosis. So this is the other triads part, right? So what they say is, once the acidosis worsens, okay, the best coagulation can be achieved in normal pH between 7.35 to 4.5. If it goes below 7.2, your factor, especially again your factor 7A, drops, the activity drops. Okay, and the generation of factor 10A and thrombin is also hampered. Okay, so what happens if the pH drops to less than 7? The factor 7A activity is reduced majorly by up to 90%. Okay, so fibrinogen is also impaired, the cross-linking does not happen, the clot is not stable, and this might cause the breakdown of the clot. Okay, platelet function is also altered, and it can cause degranulation of platelets, and the aggregation of platelets also do not happen in severe metabolic acidosis. Okay, so this is about the effect of acidosis on clotting. Coming to diagnostic approach for trauma-induced coagulopathy, okay, routine blood tests like your CBC, etc., have to be done. Okay, uh, look at the sites for bleeding. Okay, after that, arrest it. If there's any major visible bleed, probably you have to address it with your crystalloids. Then go ahead with blood products. Okay, you have probably, if the patient is in shock, your ABC score is high, probably activate your MTP. Along with the same time, do your laboratory test. Do your PTA, PTT, INR, check your fibrinogen level. Okay, if you have a tech, go ahead and use it. Okay, having said that, you have to also remember the drawbacks of tech. Okay, so all of this would be the initial diagnostic approach for this thing. What is that? Trauma-induced coagulopathy. Along with this, dyselectrolytemia has to be kept in mind because you're giving products to this patient, so the patient can end up in hyperkalemia. And because you're giving a lot of products, there might be chelation of calcium that can lead to hypocalcemia. Okay, so keep check on calcium and potassium for these patients. Okay, so you have done your routine tests, you have got your studies. Okay, so how will you treat is what is based on the next step. Okay, that is your management. So next question is, if TEG is present, ROTEM is present, is it anyway superior to your coagulation testing? As of now, IACTIC study did not show that is superior over the other. Major thing is turnaround time. Okay, so if you have a TEG and ROTEM present there, it is a point of care device, so it will give you the result as early as possible. Okay, that is the major thing. Okay, but majorly no difference if you have ROTEM or TEG as compared to your hemogram. Just keep a watch and keep a follow up. That should be more than enough. Okay, so management, control bleeding, restore perfusion, uh, damage control resuscitation. I'll be talking to you in the next topic. Okay, so in that you can do something called as permissive hypertension after ruling out 3BI. Okay, if 3BI is there, we can't do this. Again, you have to be very judicial in using crystalloids. Probably you might have to follow a massive transfusion protocol, and based your proper trial, there is a ratio of 1:1:1. That is your plasma platelet and RBC bags, and based on your laboratory value of fibrinogen, etc., you might have to supplement this patient either on cryoprecipitate or a fresh frozen plasma. Always try and maintain the ionized calcium level of more than 1 millimole per liter. I told you early TIC, there is a big role for tranexamic acid, especially within 3 hours. Okay, the dosing is 1 gram over 10 minutes, followed by 1 gram IV over 8 hours. Okay, all along with all of this, avoid acidosis, prevent hypothermia. Okay, so if you have done all of this, if the patient is still bleeding, then you can think about the use of recombinant factor 7a, desmopressin, etc. Okay, this is again management of bleeding. Okay, in general, whatever you do. Okay, so when do we think about the need for recombinant factor 7? When the pH is normalized, you have got it at least more than 7.2. You have normalized the ionized calcium of more than 1.1 millimoles per liter. Temperature is normalized. Fibrinogen is normalized. Platelet count is optimized. If you have done all of this optimization, then think for the factor 7. Otherwise, if you have not optimized all of this, don't routinely ask factor 7. Okay. These are the checkpoints for the indications for use of recombinant factor 7. Okay. So targets and TIC, systolic blood pressure, non-TBI 80 to 90, in TBI more than or equal to 110. MAP targets roughly 60 to 65. Maintain temperature, pH, reduce the base deficit. Base deficit you can't directly look into, but what is the target is between 0 to -2. Fibrinogen, maintain it more than 1.2 grams per liter or 1.5. It's the best way. Try and optimize the platelet count up to 1 lakh. Okay, and the hemoglobin target, if it's more than 7 grams, it's more than enough. Again, depends on the comorbidities associated. Okay, ionized calcium should be more than equal to 1 millimole per liter. Okay, this is about the diagnosis and management of trauma induced coagulopathy. Okay, thank you. Any questions in this? So coming to the next topic, that is about damage control resuscitation. Okay, so is my slide visible? So, damage control resuscitation is a systematic approach used to manage severely injured patients, particularly those with life threatening hemorrhage, to optimize survival by addressing the lethal triad of trauma. that is your hypothermia, acidosis, and coagulopathy. This concept is rooted in minimizing further physiological deterioration, wherein we stabilize the patient for a definitive type of care. Okay, it's like buying time. Okay, so that is the whole understanding of DCR. Okay, you're looking at addressing the most life threatening hemorrhage at the earliest, try to prevent the lethal triad of death, stabilize the vitals, and then take the patient for a definitive care. Okay, so it's a stepwise approach. So, what does DCR encompass? It has permissive hypotension, minimizing the use of crystalloids, a protocolized transfusion, and hemostatic resuscitation. Okay, this is what we look in damage control resuscitation. So, remember in pathophysiology, what usually happens in DCR is there will be first hit and second hit. Okay, the first hit is the SIRS, which is usually because of the serious injury which happens. Okay, injury, that is trauma, causes SIRS, that causes activation of the immune inflammatory system. The second hit is what we are worried about. Okay, the second hit can be iatrogenic. Okay, when does that happen? It is because of uncontrolled physiological disequilibrium. Okay, that can be because of our IV fluids, it can be because of hypothermia, etc. Okay, or else sometimes it can be a sequelae of the primary insult itself. Okay, so these two things can push the patient into trauma induced coagulopathy, or can push the patient into lethal triad of death. Okay, that has higher mortality. So this is basically the underlining need for damage control resuscitation. So the next question will be, in when and in whom we initiate DCR. Okay, so in patients with major trauma, okay, firstly we need to look at patients whether they have major trauma. You've analyzed whether the patient is in a red zone, yellow, or green zone. Then you triage this patient and transport this patient. Firstly, you do a damage control resuscitation or a damage control surgery, then optimize the hemodynamics. Hemostatic resuscitation would be done. Then you plan and do a definite surgery. Okay, so this is where we do. Okay, lastly, we have the reconstructive surgery. These are the phases of DCR. Okay, so coming to damage control approach, it can be anatomical injury or it can be a physiological derangement. Okay, so the question I asked you earlier, where and in whom? Okay, I'm sorry, the earlier slide came in as a googly. Okay, it was the phases of DCR which you saw. Okay, starting from triaging, DCR, okay, hemostatic resuscitation, definitive, and rehabilitation. Okay, and coming to the question of whom to do it, you have to look at two things. Okay, one is the anatomical parameters, other one is physiological parameters. If you cannot remember this, I have another slide where you can remember it in total. Okay, patients with an injury severity score of more than 36 warrant DCR. Patients with penetrating abdominal or chest injuries warrant DCR. Unstable pelvic fractures, long bone fractures, head injury, truncal hemorrhage, or amputation. All of these patients would require damage control resuscitation. Patients with physiological derangement, okay, especially leading to excessive tachycardia, absent radial pulse, with any other type of injury, also might require damage control resuscitation. So, what I talk about physiological parameters are patients who do not have the above anatomical derangements but still have signs of hemodynamic instability. In those patients, also, you can initiate DCR. Okay, so none of these criteria should be used as an isolation. It should be on a case by case scenario, and most of this you can remember looking at the clinical presentation of the patient. So, what is the changing paradigm in management of a patient with trauma and DCR? Here, the ABC becomes CABC. Okay, that is the most important thing is you have to address the catastrophic hemorrhage which is happening to the patient, because in the meanwhile you're doing all the other resuscitative effects but you have not addressed the leaking patient. Okay, so if you have not plugged the hole there, probably this patient will bleed out and exsanguinate to death. Okay, so that's the reason they say if there is a compressible hemorrhage, especially from an extremity, that would rapidly kill the patient, start with addressing that along with your ABC approach. Okay, so it should happen in a simultaneous process. So it is a team based approach, and in team based approach, start with the catastrophic hemorrhage in tandem with your ABC. So that is a part of damage control resuscitation. Okay. So how do we do that? You can use field dressing, tourniquets, hemostatic agents, sometimes even riboa. Okay. So these are the things that you can do to avoid a catastrophic hemorrhage. Okay. So coming to the role of radiology in this, so what do we do? Firstly, we do an e-fast, and if we are unable to find out any bleeder, probably we can even think of doing a CT angiogram or a polytrauma CT. Okay, but all of this depends on the hemodynamic stability of the patient, and if we feel that there is active bleeder anywhere, probably you can even in the same setting do an angioembolization of the bleeder as well to arrest the bleeding. Okay, so the role of radiology in damage control resuscitation can be of two things. It can be diagnostic or therapeutic. Okay, so firstly we start it as a diagnostic tool with the efast. Okay, so if at all the patient's hemodynamics is stable, then we can go ahead with the definitive tool like a CT angiogram followed by an angioembolization plus or minus depending on an active leak. Okay, this is the role of radiology in damage control resuscitation. So I told you earlier there were the five phases which we discussed. The initial surgery in a DCR is always a life-saving procedure. Okay, so usually it should be less than 90 minutes. Okay, the OT time should not be very high. You just have to control the hemorrhage, prevent contamination, make sure the patient gets a very judicial fluid resuscitation, and the patient is shifted back to the trauma unit for further observation and management. Okay, it's just a temporary surgery. The second phase is the ICU resuscitation phase, wherein we have to optimize the hemodynamic targets. So prevent your lethal triad of death or your diamond of death, that is your hypocalcemia as well. Okay, so all of this have to be kept in mind. Optimize end organ perfusion, prevent acute kidney injury, ventilate the patient if required. Okay, all of this has to be addressed in phase two. Definitive surgery is usually after we have stabilized the hemodynamics. It can be anywhere between 24 to 48 hours period. Okay, so permissive hypotension is a part of damage control resuscitation, especially in the first 6 to 12 hours period. What do we do this? Usually we maintain a lesser systolic blood pressure target. All of these patients who have trauma do not warrant permissive hypertension. I'll be talking to you about the limitations for the use of permissive hypertension. Why do we do this? Firstly, it is to limit the blood loss. Along with that, they also say that a clot which is formed, if at all there is a fluctuation in blood pressure which happens in these patients, can cause dislodgement of cause clot and further bleeding. So this is major reason why they think that permissive hypotension is the best way forward in damage control resuscitation in the early phase. Okay, so what is the target blood pressure? You target the target, a BP between 80 to 90 millimeters of mercury in patients without traumatic brain injury. Okay, if it's TBI, probably have to have a higher target, that is 110 millimeters of mercury. Okay, why higher? It's very straightforward. You have to maintain the cerebral perfusion pressure. Okay, so, what are the challenges associated with permissive hypotension? Always you're compromising vital organ perfusion. Watch for oliguria, anuria, AKI, shooting up of liver enzymes. Okay. Probably you can't feed the patient, obviously. And if it is a gut injury, again, a lot of issues related to gut translocation of bacteria. All of this is possible. Okay. These are the challenges associated with permissive hypotension. The other thing is patients with elderly age group, chronic comorbidities, which is uncontrolled, especially IHD, CKD, they may not tolerate this, permissive hypertension, and that can further worsen their organ failure. And as you all know, in TBI, it's a contraindication. After permissive hypertension, the next important thing is balanced fluid resuscitation. That is the component of damage control resuscitation. What do we do this? Avoid excessive fluid overload in these patients. Okay, have a close watch. Okay, a goal directed therapy with your hemodynamic parameters is necessary. After 1 liter of crystalloid therapy in trauma, better to use your blood products. Okay, so things like your ABC score, shock index, etc., would be a trigger factor. Okay, or else you can also use your ATLS hemorrhagic shock algorithm for initiation of your MTP protocols. Okay, so remember, this is a patient who is sick. This is a patient who is bleeding. This is a patient who is going to have multi-organ failure. Okay, so you need to prevent adverse effects of your resuscitation. That is what is the goal of balanced fluid resuscitation. Okay. In the meanwhile, with permissive hypotension, you have to maintain the intravascular volume. Okay. Optimize coagulation factors. Check in for derangements like hypothermia, hypo, uh, hyperkalemia, hypocalcemia, and metabolic acidosis. Okay, all of these are metabolic derangement associated with fluid therapy and damage control resuscitation. Okay, so dilutional coagulopathy is the major problem along with hypothermia, which we see with excessive fluids. Okay, and along with this, you should have a proper ratio, that is 1 is to 1 is to 1, based on your proper trial and prompt trial. Okay, so that is one thing. Early use of blood products, that is the best way forward in DCR. Okay, calcium replacement is similar to what I discussed with trauma induced coagulopathy. Okay, I told you earlier as well when we were discussing about fluid resuscitation, especially in burns. Okay, similar to that is what happens here as well. Okay, excessive fluid can lead to compartment syndrome, initially abdomen, or it can be a polycompartment syndrome. Okay, so targets is similar to what we saw earlier on. Okay, so you need to maintain a map more than 60 to 65, urine output of more than zero point 0.5 to 1 ml. Calcium should be more than 1, prevent coagulopathy. Okay, and try and normalize the lactate. Okay, these are the targets which we usually see with balanced resuscitation or damage control resuscitation. uh, Crash 2 proper trial. Proper trial is for your blood products. Crash 2 evidence is for a tranexamic acid, early tranexamic acid. Okay, all of this can also reduce the use of blood products, right? So that is how it is. And coming to per se, what is the evidence for damage control resuscitation? There's one trial called as by Mattox et al. In 2017. Okay, so in which they looked at patients with military wounds. Okay, they said early balance resuscitation and rapid hemorrhage control had better outcomes. So this is majorly where we have the data from. Okay, that is your military backgrounds. Okay, that's about your damage control resuscitation. Okay, thank you. You can write the same targets which I mentioned in trauma-induced coagulopathy for damage control resuscitation. Okay. Any questions? Okay. I don't see. I'm coming to the last talk for today. Okay. About trauma and toxicology. I'll be joining back again for pregnancy-related topics. Okay. So the last topic would be massive transfusion protocol and hemorrhagic shock. Okay. So hemorrhagic shock is a life-threatening condition resulting from significant blood loss, leading to inadequate tissue perfusion and oxygenation. Okay, so it is characterized by hypovolemia, reduced cardiac output, and cellular hypoxia, leading to impaired organ function, potentially leading to death. Okay, if not checked at the right time. So if you remember this heading, it's more than enough. So what are the key features? Usually in hemorrhagic shock, there is hypovolemia, that is because of decreased circulating volume, which causes hypotension. Okay, and that will in turn cause tissue hypoxia. Okay, tissue hypoxia in turn can lead to metabolic acidosis. So what is the primary cause? It can be trauma, surgery, gastrointestinal, obstetric cause, etc. So these are the causes. Okay, and what is the physiological response to bleeding or hemorrhagic shock? There will always be a compensatory response. No, so it will be increased heart rate, vasoconstriction, and activation of the renin-angiotensin aldosterone pathway. So this is majorly what you need to write about hemorrhagic shock. If someone asks you definition, causes, physiological response, and pathophysiological effects or sequelae of hemorrhagic shock. Okay, if you can take a screenshot of this, it's good enough. Okay. So classification is the next important thing in hemorrhagic shock. It is classified into 4 classes. Okay. So it's class 1 mild, that is blood loss less than 15% of the total body volume. That is around 750 ml in a 70 kg adult. In class 2, it is moderate hemorrhagic shock between 15 to 30% loss, 750 to 1500 ml of blood loss. Okay, here you will see tachycardia, decreased pulse pressure, anxiety, etc. Okay, so altered mental status happens in second grade or class 2 shock. In class 3, it is a severe type of a hemorrhagic shock. It is blood loss of 30 to 40%, with roughly up to 2 liters of blood loss, patient can have signs of end organ hyperperfusion like oliguria and altered mental status. Class 4 is a life-threatening shock wherein the blood loss is usually more than 40% and the total blood volume loss would be more than 2 to 2.5 liters. And this patient will be in a state of altered mental status, distress, and will be in a stage of doom, that is impending cardiac arrest. Okay, so that is what we see in class 4. Okay, so, what are the clinical hallmarks of hemorrhagic shock? Systolic BP of less than 90 mm of Hg in severe cases, tachycardia, narrow pulse pressure. Along with this, signs what do we see? Cold, clammy extremities, prolonged capillary refill time, oliguria, and altered mental status. In metabolic pathways, what do we see? An elevated lactate of more than 2 millimoles per liter and a base deficit, which we elevated, okay, more than minus 2 millimoles per liter. Okay, that is what we see in ABG. So this is the same classification that I have mentioned earlier. So what you have to categorize them is class 1, 2, 3, and 4, percentage of blood loss, what happens to heart rate, BP, pulse pressure, GCS. Okay. Remember, grade 3 shock, you have to activate the MTP, alert the blood bank that the patient might read. And once the patient goes into class 4 hemorrhagic shock, you need to activate MTP. So this is one thing I wanted you to take home from this slide. Okay. So recently, in Journal of Clinical Medicine, no, they have had another staging of hemorrhagic shock. I wanted you to look into this as well. Okay, wherein they have categorized hemorrhagic shock into 5 stages. Okay, so it is basically, imagine the patient has come to your ER or your ICU. Okay, and the patient has developed hemorrhagic shock. How the patient progresses and what happens in each stage is what they have told this as. So initially, when the blood loss is very minimal, less than 10%, it is stage 1. Okay. So only skin signs and tachycardia will be present. That is called as a stable hemorrhagic shock. The next thing is called as stabilized or compensated hemorrhagic shock. That is stage 2, wherein the patient is responsive. Okay. So if you have read your ATLS guidelines, there is one particular terminology where they use as responders, fluid responders and non-responders. So this is basically based on this categorization. Okay. So if at all your patient has hemorrhagic shock, they respond to fluid resuscitation, they fall under stage 2 shock, that is stabilized compensated hemorrhagic shock. If your patient is transiently responding to fluids and blood blood products, then he is categorized in stage 3, that is your progressive unstable hemorrhagic shock. Who are these patients? They have hypotension and they have transient response, usually between 30 minutes or less. Okay, and even after giving 2 or 3 boluses of 500 ml of crystalloid, they go back into shock. Okay, so such patients who improve and go back are patients called as progressive unstable hemorrhagic shock. Stage 4 is critical hemorrhagic shock, wherein there is impending cardiac arrest, similar to what we saw in the ATLS categorization. Okay, so wherein there is shock with end organ hyperperfusion signs, usually categorized by a blood loss of more than 40%. And the last thing is a patient who is categorized with patient with cardiac arrest. So that was the limitation of the previous thing if you look into it also. Okay, so they are not categorized what happens if the patient has a cardiac arrest due to exsanguination. So this actually includes those patients. So cardiac arrest by exsanguination is categorized as stage 5. So this is just to have a comparison. This is the American College of Surgeons and Trauma, the same thing which we spoke about earlier, as compared to the new guidelines based on staging. Okay, so coming to the next important part of management. Okay, again, hemorrhagic shock, we know initially you need to manage with crystalloids followed by blood. If this doesn't happen, if the patient slips into stage 3 and stage 4 he ends up, then you have to activate the MTP protocol. Okay, so that is where we come into the discussion of MTP. Okay, MTP, there is no single universally accepted definition. Massive transfusion protocol is a standardized systemic approach to the rapid and efficient replacement of blood and blood products in patients with life-threatening hemorrhage. Okay, it is designed to optimize hemostasis, restore circulating blood volume, and prevent complications associated with massive transfusion. Massive transfusion is different. Massive transfusion protocol is different. Okay, Remember, if they ask you what is MTP, tell it's a standardized systemic approach with rapid, efficient replacement of blood and blood products given to treat patients with life threatening hemorrhage. On the contrary, massive transfusion is these, okay? Patients who have replaced more than 10, who have required more than or equal to 10 units of PRBCs within 24 hours, or patients requiring more than equal to 4 units of PRBCs within 1 hour, or replacement of more than 50% of the total blood volume within 3 hours, categorized as massive transfusion. Okay. So, what is the goal of MTP? It's rapid delivery of blood products in a systematic fashion and to minimize complications, especially the lethal triad of death, that is coagulopathy, acidosis, and hypothermia. Okay, this is the goal of MTP. Okay, so remember, if they ask you lethal triad, this one, diamond of death include hypocalcemia. Okay, so this is about the focus or the need for MTP. Why MTP? Okay, so because it's a very structured format, it has a clear criteria which activates the MTP protocol. You have a predefined blood product ratio, the protocols for monitoring, adjusting the therapy based on clinical and laboratory data. You are reassessing. Okay, so these are the three reasons why MTP is necessary. Okay, so it is a structured approach with clear guidelines for activation and stoppage, and you get blood products in a fixed ratio. So that is one of the major advantages of MTP. So what are the tools for activation? I told you earlier there are multiple tools that you can use. Remember one of them. Okay, one is critical administration threshold. Whenever your patient has hemorrhagic shock, if they require more than 3 PRBCs in 1 hour, you can call for MTP. Shock index is one thing, that is heart rate over systolic blood pressure. If it is more than 1, even then you can activate an MTP. If an ABC score is present of more than or equal to 2, then you can active MTP. What is ABC score? It is nothing but patient with penetrating mechanism of trauma, systolic blood pressure of less than 90 mm of Hg, heart rate of more than 120 beats per minute, and a fast positive ultrasound. So if these are present, then the patient is categorized as a patient who requires MTP. There's another tool called as a RABT score. Okay, RABT is slightly a little more sensitive and specific as compared to ABC score. Okay, along with this, what it does here is systolic blood pressure and heart rate. It combines it into a shock index. Okay, so other things are similar. There is fast positive. There is shock index, penetrating mechanism. Only other additional thing that we could is pelvic fractures. Okay, pelvic fractures are notorious to cause concealed hemorrhages. Okay, so concealed hemorrhage is one thing which can be easily missed. Okay, especially when you're doing a fast as well. Okay, so in such cases, that is the reason it is mentioned as a separate entity in RABT. Okay, so what are the 7 T's of trauma resuscitation? You should have a trigger plan. It's a team-based approach. Early use of tranexamic acid, test hourly, achieve the target, prevent hypothermia, and terminate the code when stabilization has occurred. What are the steps? It's 6 steps. Okay, so you identify based on your scoring systems. Okay, you have a clinical judgment, activate it, talk to your transfusion officer or a blood bank. Then step 3, and you will check for your clotting parameters. You send a CBC, everything. Okay, LFT is supposed to be done. Your fibrinogen value has to be done. Okay, and coagulation parameters. You give tranexamic acid, like I've mentioned earlier, 1 gram 10 minutes, less than 3 hours, 1 gram over 8 hours. Okay, then we need to get blood products in a fixed ratio. 1:1:1 is what is uh, good enough instead of 1:1:2. Okay, so this again 1:1:1. It does not mean 1 bag of plasma, 1 bag of SDP, or 1 bag of RDP, and 1 bag of PRBC. It depends on the local institutional protocol. Okay, it can be 1 bag, it can be 3 bags, it can be 6 bags. The ratio is what is mentioned. It is not the number of bags. Okay, please keep that in mind. Okay, so it can include FFP or cryoprecipitate. It is depending on the availability. Okay, after this, after you have done a fixed ratio resuscitation once, you have to check, okay, whether hemodynamic stability has occurred firstly, whether clotting parameters have normalized. In this place, probably you can use TEG and ROTEM if it comes earlier. If you don't have, then you can send a CBC, PTINR, okay, and then check for dyselectrolytemias, etc. Monitor for hypokalemia, hypercalcemia, correct them if at all it's present. The penultimate step is once you have achieved a goal, okay, your fibrinogen value is more than 1.2 grams per liter, ionic calcium is good, more than 1 millimoles, okay, and your INR is normalizing, you have a platelet count which is in an improving trend, and hemodynamically the patient is stable, then you can stop the MTP. Okay, so this is the 7 steps for MTP. Okay, so activation, okay, first identification, activation, assessment of coagulopathy and adjunctive therapies, transfusion of products, reassessment after delivery. Then, once reassessment is done, once the targets are achieved, stoppage of MTP. Okay, this is about MTP. What are the guidelines for calcium replacement? I told you earlier, each unit of PRBC or FFP contains citrate that becomes the chelator, which binds to the calcium and reduces bioavailability. Okay, severe hypocalcemia can itself be the cause for bleeding. Okay, so that is one thing you have to remember. So what they say is for every 4 to 6 units of blood products transfused, probably you might have to check the ionized calcium and then give the patient ionized calcium. So there are many ways that we can give calcium, either by calcium gluconate or calcium chloride. Remember, when you're giving calcium chloride, it is for a central venous access because it's too painful. Okay, so that is the reason calcium chloride is usually not routinely available. Calcium gluconate is a good enough option. Okay, so the only advantage of calcium gluconate is it can be given in the peripheral IV access. Okay, dose is 1 to 2 grams for calcium gluconate, and chloride it is 0.5 to 1 gram IV. Okay, so what are the triggers again for checking this? If you have, one is the blood bag, two ionic calcium, okay, three is if you're having ECG changes. All of this are triggers for giving the patient IV calcium. Okay, so along with this, if there is ongoing bleeding also, you can think about and supplement it. Okay, so always don't stop monitoring calcium as soon as MTP is stopped. Post MTP also there may be some amount of utilization over a period of 6 to 8 hours, so recheck calcium another 12 hours later as well. Okay, so this is an example for one of the hospital based activation coding. Okay, so as you can see, there is initial management specific things, they have involved cell salvage. Okay, they've pre-specified the dosages. Okay, what they said is one adult therapeutic dose, especially if the platelet count is less than 50,000 for platelets. Okay, so adult therapeutic dose can either be 4 to 5 bags of RDPs or 1 bag of STP. In INR, they've told 15 ml per kg of FFPs. If it is cryo, they have told 3 to 4 grams of cryoprecipitate. Okay, so this is a very clear, very good guideline. It is different from different hospitals. Okay, so this is one such examples that I have put here. Okay, recombinant factor 7, I told you earlier also. Okay, always make sure no acidosis, no hypothermia, blood products are normal, platelets are normal, and your clotting factors are okay. Only then lastly you give recombinant 7. Otherwise routinely don't use recombinant factor 7. Tranexamic acid, there are a lot of trials. They have told you earlier in trauma induced coagulopathy less than 6 hours, you saw, right? There'll be hyperfibrinolysis. So that's the place where the role of tranexamic acid has been proven beyond any doubt. Okay, so I don't want to repeat again. Loading dose is 1 gram over 10 minutes. Maintenance dose is 1 gram IV infusion over 8 hours for 24 hours based on your crash trial. Okay, crash 2. So evidence for tranexamic acid, please remember MATRIS trial, crash 2 trial. Okay, these are most important. Again, you have crash 2, crash 3 both. Okay, so it is TBI, trauma, both come into picture. Okay, both places tranexamic acid has proven some benefit for sure. Okay, so both this is the evidence for the use of tranexamic acid. What majorly all of these trials are telling, early initiation, what is the timeline cut off? 3 hours. Okay, so what do you do on MTP? You have to monitor temperature, maintain acid base balance, ionize calcium, platelet count target is more than 50 thousand, and PTINR less than 1.5. Okay, and fibrinogen 1 to 1.2 grams per liter is the target. Okay, so proper and prompt trial is the evidence for which the 1:1:1 ratio came into existence. Okay, so if they ask evidence for this, this is proper and prompt. You don't have to remember this. I just put this slide so that you understand what is this. Okay, it's categorized very easily. You can get this in multiple places. Okay, so what are the criteria for stopping? Hemodynamic stabilization, normalization of laboratory parameters, surgical control of bleeding has also occurred, and then you see that the patient does not have any risk of rebleeding based on interdisciplinary uh, discussions. Okay, so when all of this is there, you can stop the MTP. Yeah. So what are the complications associated with massive transfusion protocol? It can be TRALI, TACO, which is circulatory issues because of products, dyselectrolytemia, hypothermia, coagulopathy, dilutional thrombocytopenia, metabolic acidosis, infections, ABO input compatibility, and ARDS. Okay, so these are the issues with MTP. Okay, so whenever they ask you about hemorrhagic shock or MTP, first tell what is MTP, what is massive transfusion. They are different. Okay, after that, tell when you will activate MTP. Okay, after that, what do you do in MTP? All the 7 steps. Then what do you target in MTP? And if that particular target is not reached, what are the targets you need to reach? Your hemoglobin target of more than 7, your platelet of more than 50, your kinases calcium of more than 1 millimoles per liter. Okay, along with this, arresting the primary cause, the address has to be done to that as well. If there's an ongoing bleeder, surgical control if necessary, all of that has to be taken place. Okay, all of this you have to mention. And after stabilization of all these things, you have to tell that we can stop MTP. And later on, you talk about complications. Then you talk about adjuncts in MTP, that is your tranexamic acid. Write the evidence. Then you talk about what is the rationale of using 1:1:1 in MTP. Then you can write the evidence based on a proper and proper trial. Okay, so this is how you answer a question about massive transfusion protocol. Okay, thank you. Srihari, I think so. You can take over. Thanks. I'm sorry I had to prolong.
Is the slide visible?
Yeah, yeah. Go ahead.
Okay. 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 Good evening to all. So we go on to the next part of toxicology, that's on snake envenomation. So this is a very, very high potential short note. So coming to the introduction, just to give a clarity, the total number of snake bites over the year account for almost 5 million cases. So out of that, 50%, that's almost 2.5 million cases are envenomations, and out of that, 75,000 to 1 lakh deaths occur globally. So, with respect to India, the highest reported deaths are in UP, Bihar, and Andhra Pradesh. So, 3 families of venomous snakes are there, which are of clinical importance in Southeast Asia, which all of you need to know about. One is the Elapidae. So, the basic thing about them is they have small fangs. So, the 2 common species are Indian cobra, that is Naja Naja, and crate, that is Bangar species. So the features are they have short fangs, they have a less triangular head, and they have large scales. So these are the 3 differentiating features for elapids. And commonly they are associated with neurological signs and local reactions. Then you have Viperidae. They contain the true fangs. And under them, we have the Russell's viper, the saw-scale viper, the green tree pit viper, and the hump-nosed viper. So the features over here are the opposite of the elapids. They have longer fangs, they have triangular head with an abrupt transition to body, and a small scale pattern on the head. So these are usually associated with local reactions, hemostatic complications, renal complications, rhabdomyolysis, and some viper can cause neurological manifestations also. Then you have a third classification called colubriae. So this is more in the sub-Saharan areas. So the special features are they have shortened fangs at the back of the upper jaw, and mostly they are associated with coagulopathy, though in most scenarios they are harmless. So here are the 3 distinguishing classes of snakes. Here you have the elapids. You can see the large scales over the head. Then you can see the short fangs. All right. Here you can see the viperids where the fangs are larger. There are small scales over here that are present. And here you can see there is an abrupt transition from the head till the body. And there is a triangular head. So this is characteristic of a viperid. All right. And the one over here that you can see is the colobria, where the fangs is usually at the back of the mouth. So coming to the venom pharmacology, so model techniques of venomics, that is basically proteomics applied to venom, such as high performance liquid chromatography and mass spectrometry, have revealed the enormous complexity of snake venoms. So more than 100 different proteins have been isolated from snake venom. Why this is important is many of the clinical features that occurs following snake envenomation has been attributed to all these enzymes. So the identified components and physiological sites of action of snake venom determine the spectrum of clinical features commonly seen after the snake bite. So there are almost 100 different proteins. But from an exam perspective, I think it's good to know about at least 7 to 8 of them. So the most important is the zinc metalloproteinases. So these degrade the basement membrane components of the blood cells, leading to endothelial damage and contributing to spontaneous systemic bleeding. Then you have anticoagulant enzymes, especially like Russell's viper venom, which is associated with anticoagulation related hemorrhage. Then you have phospholipases A2 and lecithinase, which cause widespread damage of various tissues. Like in peripheral nerve, it can cause neurotoxicity. In RBCs, it can cause hemolysis. Skeletal muscles, it can cause rhabdomyolysis. And in the vascular endothelium, it can cause capillary leak. Acetylcholinestrases, mostly seen in elapids, may cause fasciculations. Hyal urinodases and endopeptidases are usually associated with tissue destruction at the local site. So this swelling, blistering, tissue necrosis are all attributed to these two enzymes. That is the hyal urinodases and the endopeptidases. Then you have the procoagulant enzymes like the serine proteases, which activate factors 5, 10, and 2, leading to the formation of fibrin. Because of the intact coagulation system in the body, most of the fibrin clot gets immediately broken down by the fibrinolytic system. So ultimately, there is a consumptive coagulopathy which occurs. Then neurotoxins, which generally target the neuromuscular junction, which can be either presynaptic and postsynaptic, or it can be both, or they can also affect the skeletal muscles. Now, why you need to know about the presynaptic and postsynaptic is in presynaptic, it acts via phospholipases A2. Now, when it acts through the presynaptic receptors, they are not reversible. So once the action has occurred, the toxin effect is produced. And if it is going to be presynaptic, there is not going to be any reversible activity following anti-snake venom. So it takes days to weeks for recovery of function as the axon regenerates. Then you have postsynaptic, where the target acetylcholine receptors are on the muscle end plate. They respond to acetylcholine, and these are the ones which can be reversed with antivenom or anticholinergicases to an extent. So these are the basic enzymes which you need to know in relation to venom pharmacology. So coming to the clinical manifestations, the first one you need to keep in mind is about the local reactions. So there can be pain, blistering, swelling, tissue necrosis, ecchymosis, regional lymph node swelling with tenderness, and fang marks is usually seen in most cases. So this is the first thing you need to always have a look into. So many a times when we examine a patient, we always just look at the bite side. All right. It is always important to look at the ipsilateral inguinal nodes because the spread of the toxin will definitely cause lymphangitis and they will cause lymphadenitis also. So you always need to check those areas also. Then coming to the neuromuscular junction, it can manifest as ptosis, dyspnea, diplopia, nystagmus, bulbar palsy, where there can be pooling of secretions in pharynx, limb weakness, usually flaccidity with decreased or absent reflexes. So to differentiate between a presynaptic and a postsynaptic, you can go with the neostigmine test. So you first give atropine 0.6 milligrams or glycopyrrolate 0.2 milligrams. Then you give neostigmine in a dose of 0.025 milligrams per kg and observe for an improvement in ptosis with an upward gaze and resolution of respiratory weakness within 30 to 60 minutes. If it is present, then it is likely to be a postsynaptic paralysis, which will be responsible to anti-snake venom and anticholinesterase. Then coagulopathy is the next clinical manifestation that can be there. Can manifest as epistaxis, gingival bleeding, oozing from gingival sites, bleeding from many puncture sites, or clinically evident bleed like hemoptysis or hematemesis. So, like I said, because there is going to be consumption coagulopathy or the toxins itself can lead to anticoagulation, it is going to cause a derangement in your hemat parameters like thrombocytopenia, anemia, deranged INR or APTT, raised D dimer, and elevated WBCT, that is whole blood clotting time, more than 20 minutes. Then shock. It can be either absolute because of plasma leak or massive bleed, relative hypovolemia because of vasodilation of the splanchnic vessels, or myocardial depression, or a combination of all three. So the usual manifestation can be with hypotension, tachycardia, and signs of poor peripheral perfusion like prolonged capillary refill and lower urine output can be there. So this can manifest and can be identified as abnormalities on ECG and echo. So if patients present with shock, hemodynamic monitoring would be necessary. So rhabdomyolysis can be identified by the presence of red and brown urine, and oliguria can be there. So you need to check the urine for myoglobin. Other tests that you can do to identify is assess for presence of elevated serum creatine phosphokinase, serum potassium, and serum creatinine. And other manifestations that can be there are lethargy, seizures, nausea, vomiting, and abdominal pain. So these are the general clinical manifestations that you always need to look into in a case of snake envenomation. And another important thing you need to keep in mind is even though elapids are usually associated with neurotoxicity and viperids are associated with other manifestations, it's not necessary it has to be a standard rule. That can be overlap of features because, like I said, venom pharmacology will be common to most of the snakes. So they can produce a wide variety of symptoms, but the commonest features that are seen in elapids are neurotoxicity, and the commonest in viperids are rhabdomyolysis, coagulopathy, and rhabdomyolysis, coagulopathy, and other hemostatic complications. So here are just few images. Here you can see local reactions. Then here you can see lymphangitis that has occurred. Then you can see ptosis following neurotoxic envenomation. Then here you can see gum bleeding, gingival bleeding. And here you can see pituitary apoplexy, that is in extreme cases. So for diagnosis, important is about the history. So you need to inquire about when and where the bite occurred, the description of the snake if possible, then any symptoms and timing of onset, the initial treatment received, any recent ethanol or recreation drug abuse, relevant medical history and medications, or if there was history of a previous snake bite. If it was there, you need to also inquire about the history of ASV, if it was given or not, or any reactions in relation to that. Then you look for clinical manifestations, local reactions, neuromuscular signs, coagulopathy, shock, and features of rhabdomyolysis. Then the initial lab test, so you do a complete blood count, coagulation profile, renal function test. Then you assess for hemolysis. You do a P smear, LDH, bilirubin, direct bilirubin, and a direct Coombs test. Then echo to assess for myocardial dysfunction if it is present. Ultrasound thorax to assess for effusions or volume overload, and Doppler of the affected limbs to assess for deep vein thrombosis. So this should be the general lab protocol that you need to keep in mind. So coming to whole blood clotting time, so what you need to do is you take 2 ml of a freshly sampled venous blood in a small, new, dry glass vessel. Leave it undisturbed for 20 minutes at ambient temperature. Tip the vessel once. If the blood is still liquid, that is unclotted and it runs out, the patient has severe hypofibrinogenemia as a result of coagulative and consumptive coagulopathy. In case you feel little doubtful, then you can repeat the test. Now, the important thing is this test is mostly done in the emergency setting or in a resource limited setting. In setup where in most of the tertiary care setups where you have access to coagulation testing like fibrinogen, PT-INR, APTT, whole blood clotting time is not routinely needed. This is as per the National Rural Health Mission guidelines from India. So one other thing you need to keep in mind is if the vessel used for test is not made of ordinary glass or if it has been cleaned with the detergent, its wall may not stimulate the clotting of the blood sample because of the surface activation of factor 12 and Hedgeman factor, and the test may be invalid. So this is one thing you need to keep in mind. So differential diagnosis. So when you're mentioning differential diagnosis for any kind of a disease, always mention it in what, in relation to what. So in relation to snake envenomation, the commonest problem is in relation to neurotoxic snakes. Neurotoxicity. So it may be difficult to identify it immediately. If the history is pretty straightforward, it's not a problem. But if they present with weakness as the primary problem and there is no prior history available, we need to keep other differentials in mind. So, tick paralysis, OP compound poisoning, botulism, GBS, myasthenia gravis, and myopathies like polymyositis, steroids, or hypothyroidism need to be in the back of your mind in scenarios where you don't have a clear history. So, coming to the treatment, first aid, first reassure the patient. 70% of snake bites are from venomous species, and even if it is a venomous bite, only 50% envenomate. Rest are dry bites. All right. So, this is the important thing that we need to keep in mind. Immobilize without compression. Get to the hospital immediately, inform the physician of any symptoms, and tetanus prophylaxis. So you go with TT 0.5 ml IM. If coagulopathy is there, first administer ASV, then give TT. So this is the general norm. No tourniquet, strictly no tourniquet. So coming to the treatment, we have supportive management, that is airway breathing circulation, anti-snake venom, and treatment of various complications related to snake bite. So coming to ASV, it is an immunoglobulin purified from plasma of horses and sheep, hyperimmunized with venom of one, that is monovalent, or more, which is polyvalent snake species. All right. So antivenom is the only specific antidote for snake venom. The most important decision is to give or not to give. So the indication is if you have signs of snake envenomation, then you need to give it. So 1 ml of ASV neutralizes 0.6 milligram of cobra and Russell's viper. All right. And 0.45 milligram of gray and saw-scaled viper. So it is produced both in a liquid and lyophilized form. Both are equally effective. The liquid form needs to be kept in cold chain and has a shelf life of 2 years. Whereas the lyophilized form needs to be just kept cold and has a shelf life of 5 years. So prior to usage, it just needs to be reconstituted with 10 ml of distilled water or normal saline. So in India, only polyvalent vaccine is available against cobra, Russell's viper, great and saw-scale viper. It is not effective against pit viper or sea-scale viper. It should be given intravenously and within 48 hours. Intramuscular has altered bioavailability, plus there is a risk of hematoma, so it is not recommended. And there is no dose adjustment in pregnancy in children. The dose, you have a classical regimen and an alternate regimen. The classic regimen, you first give 10 vials of ASV diluted in 250 to 400 ml of 5% dextrose over 30 to 60 minutes. If there is no improvement in 1 hour, then you give another 10 vials. The alternative regimen, if the patient is in coagulopathy, is to first give 10 vials IV, then 10 vials every 6th hourly till the coagulation parameters normalize. So these are the two regimens that can be utilized. So the rationale is the dose of venom injected is around 5 to 150 milligrams. So each vial neutralizes 6 milligram of cobra or Russell's viper and 4.5 milligrams of crate or saw-scale viper. So the total required dose ranges from 10 to 30 vials. So with 30 vials, no response is seen, it is less likely to respond to ASV after that. So that is the important thing that you need to keep in mind. So strict monitoring of patients on ASV therapy is crucial because they can develop ASV reactions. And there is no role for local infiltration of ASV. And Failure to respond to ASV can be due to insufficient antivenom, inactive or poor quality ASV, excessive delay in administration after envenomation, and presynaptic neurotoxic paralysis. So these are the four differential thought processes that you need to keep in mind when ASV effect is not seen in your patient. So coming to ASV reaction, it is an IgE mediated. Important thing is no ASV test dose should be given. So you need to administer ASV and assess for reaction. If it is there, then you stop ASV temporarily, start a fresh intravenous saline drip, then administer injection adrenaline 0.5 milligram IM in adults over the deltoid or lateral thigh. Then you go with IV chlorpheniramine maleate 10 milligrams IV. The role of hydrocortisone in ASV reactions is still not proven. If there is bronchospasm, then you go ahead with beta 2 agonists like salbutamol or levosalbutamol. Once the patient has recovered, restart ASV slowly for 10 to 15 minutes with close observation. If no new reactions is seen, then you continue ASV till the infusion is completed. So this is about ASV reaction management. Adrenaline, chlorpheniramine, beta 2 agonists. So these are the three main areas. Hydrocortisone, if ASV reactions is present, even though there is no proven benefit of it. So the observations that you need to see in response to anti-snake venom is patient gets symptomatically better. There will be spontaneous resolution of bleeding. The coagulation parameters usually normalize. In shock patients, the BP starts to improve. In neurotoxic envenomations, because of postsynaptic involvement, usually they start to improve as early as 30 minutes. And active hemolysis and rhabdomyolysis may cease in a few hours. So these are the features that you usually see. The best way of remembering is you know about the clinical manifestations. You will see that there is a gradual improvement over time. So the time period may vary as early as 30 minutes for neurological manifestations until 9 hours for hematological related parameters. So coming for neurotoxic envenomation, if it is presynaptic, it is only supportive management. Intubate, mechanically ventilate. If it is going to be long-term ventilation, you proceed with tracheostomy. So that weaning is more practical and possible. If it is postsynaptic, then you go with anticholinergic therapy like oral neostigmine 15 milligrams 6th hourly or oral pyridostigmine of 60 milligrams 6th hourly with atropine if needed. Coagulopathy, blood products only if there is life-threatening bleed after ASV administration. Heparin, tranexamic acid are not helpful and don't need to be given. If there is shock and hypotension, fluid resuscitation plus vasopressors plus or minus inotropes if cardiac dysfunction is there. And if rhabdomyolysis is there, IV normal saline in volumes to establish sufficient urine output with sodium bicarbonate for urinary alkalinization. If the patient has developed AKI, then there is no role of urinary alkalization. You then assess the need for renal replacement therapy based on the indications. So the three important indications are refractory hyperkalemia, metabolic acidosis refractory to medical management, and oliguric or anuric volume overload. Then coming to wound management, most likely they are going to be polymicrobial infections where there can be gram negative plus skin flora present. So they can manifest from cellulitis till gangrene. So the management can be just from bone debridement till the worst case scenario of amputation. So if compartment syndrome is present, fasciotomy may be needed, and the ideal antibiotic choice would be to go with amoxicillin clavulanic acid because it would cover basic gram-negative organisms and anaerobes. So these are the procedures that are usually done following a local reaction. So fasciotomy has been done here because of compartment which had developed. So this is about toxicology. So the next one is on nutrition. So hope the screen is visible. Okay. So, so the main questions I'll be discussing here are on assessment of a nutritional status in a critically ill patient, how to make a nutritional plan in a critically ill patient for enteral nutrition, refeeding syndrome, gut dysbiosis and probiotics, and trials in nutrition. So coming to the first question, assessment of nutritional status in a critically ill patient. So why assess nutrition in ICU? Because critical illness is associated with hypermetabolism, catabolism, and rapid muscle loss. So why this is a problem is lean body mass that occurs because of this rapid muscle loss has been attributed to increase in mortality, increase duration of ventilator, and length of hospital stay. So this is why nutrition has been taken as a very important factor in ICU management. So malnutrition is associated with increased infections, poor wound healing, prolonged ventilation, and increased mortality. So guidelines recommend systematic assessment on ICU admission and monitoring during stay. So coming to the screening tools, the one which most of you would know about is about the Nutrix score. So it has 6 parameters. So age, the Apache score, SOFA score, the comorbidities, the days from hospital stay till ICU admission, and IL-6 if it is available. So the total score can be calculated from 0 to 5, where it would indicate a low score, and from 6 to 10, which would indicate the high score. Now, how do you interpret a low score and a high score? In a low score, if it is low, it indicates a low malnutrition risk. It is less likely to benefit from aggressive nutrition therapy. Whereas if it is a high score, then it is associated with worse outcomes like mortality or prolonged ventilation. So these are the subsets who would benefit from aggressive nutrition therapy. So aggressive nutrition therapy is the main word that you need to keep in mind when you mention about Nutrix score. Then you have something called the modified Nutrix score. So here IL-6 is omitted because in many centers they would not be doing serum interleukin 6 levels. So in that kind of a scenario, it can be omitted, where the other parameters alone can be looked into: age, Apache 2 score, SOFA score, number of comorbidities, the day from hospital to ICU admission. So the interpretation, you just reduce 1 point from the original score, 0 to 4 and 5 to 9. So based on that, you can classify it as low risk or high risk. Then you have something called the MUST tool, that is the malnutrition universal screening tool. So here we have 3 factors that you need to keep in mind. One is the BMI, the next one is the unplanned weight loss in the past 3 to 6 months, and acute disease effect. If the patient is acutely ill and has no intake in the last 5 days. So BMI of cutoff is between 18.5 to 20. Weight loss, the cutoffs are between 5 to 10. And the disease effect, the score, if there are if the disease effect, if the nutrition intake is for more than 2 days, then that comes into the criteria and a score of 2 is given. So the total score is 0, 1, and 2 or more. So based on that, you can classify it as low risk, medium, and high risk. If it is low risk, you go with routine clinical care. Medium risk, you observe, monitor, and consider dietary support. If it is high risk, then refer to a dietitian and implement nutrition support plan, either oral, enteral, or parenteral as appropriate. So for must, you need to keep 3 things in mind. One is the BMI, unplanned weight loss, and an acute disease effect with decreased nutritional intake for a period more than 5 days. Then you have the NRS. So this one is favored by the SPEN guidelines. So that is the nutrition risk score that came out in 2002. So it combines nutritional status with the disease severity. So in nutrition status, you have 4 parts. That is normal nutrition, mild impairment, where there is more than 5% weight loss in 3 months, or food intake of 50 to 75% of normal in the last week. Moderate, more than 5% weight loss in 2 months. Here it was 3, here 2, or BMI between 18.5 to 20.5, or intake of 25 to 60% normal. And severe is more than 5% weight loss in 1 month, or BMI less than 18.5, or intake of 0 to 25% of normal. All right, so you have a score of 0, 1, 2, and 3. And for disease severity, you have normal, mild, moderate, and severe. Normal is no increase needs. Mild is like hip fracture or chronic disease with complications. Moderate is major abdominal surgery, stroke, or severe pneumonia. Severe is head injury, ICU patients with an Apache 2 score more than 10, sepsis, or bone marrow transplant. Then you have an age adjustment. So you need to add 1 point if the age is 70 years or more. And based on these three, you need to calculate the score. So if the score is 3 or more, then there is a nutritional risk and nutritional support is indicated. So this is how we proceed about the NRS scoring. So nutritional status assessment, disease severity, and age assessment. Then we have the subjective global assessment. If you see the actual assessment sheet, it is supposed to be for 2 pages. So I have condensed it from an exam perspective. So there are two areas that you need to look into. One is the history, and the other one is the physical exam. So under history, you need to look into the weight change, the dietary intake, GA symptoms, functional status, and the metabolic stress. So weight change, more than 10% loss in 6 months or more than 5% in 1 month. Dietary intake, reduced intake compared to usual, anorexia or poor diet. GA symptoms, persistent nausea, vomiting, diarrhea, or anorexia more than 2 weeks. Functional status, decline in activity, fatigue, or bedbound. Metabolic stress like fever, sepsis, trauma, or major surgeries. Under physical examination, you need to assess for subcutaneous fat, that is seen as loss of fat in the triceps or chest, where the ribs are very much visible, or presence of muscle wasting, temporal hollowing, or at the clavicle level, or prominence of shoulder and quadriceps wasting. Presence of edema or ascites may mask weight loss, considered as malnutrition indicator if unexplained. So you, based on this, you can calculate the rating as A, B, and C, where A is well nourished and C is severely malnourished. So the important thing you need to keep in mind is for SGA, it takes history and examination into consideration. So it is subjective but validated, simple, and widely used at the bedside. Why this SGA is important is in the ISCCM nutrition guidelines, SGA is the one which they recommend. So then you need to assess the risk factors for malnutrition in ICU while you assess the patient. If there was pre-existing malnutrition like chronic illnesses, cancer, CKD, cirrhosis, prolonged NP or inadequate intake pre-ICU, hypercatabolic states like sepsis, trauma, burns, ARDS, or pancreatitis, and prolonged mechanical ventilation. So these are the common risk factors for malnutrition. Then you assess the clinical and anthropometric assessment, the weight and BMI, the role of which are limited in fluid overloaded patients, recent weight loss or reduced oral intake, muscle wasting, loss of subcutaneous fat, may be masked by edema, hand grip strength if it is feasible, and functional assessment. So difficult weaning from ventilator may suggest muscle loss. Then lab and biochemical markers, they are by themselves not reliable because inflammation alters albumin, prealbumin, and transferrin levels. So they can be used to monitor trends and complications. Like example, sodium, potassium, magnesium, and phosphorus can be used to assess the risk of refeeding syndrome. And micronutrients like zinc, selenium, vitamin D, B12, and folate levels can be assessed in patients who are in ICU for a prolonged period of time. Then metabolic assessment can be done by indirect calorimetry, which is considered as the gold standard for energy expenditure. If IC is not available, then you go with predictive equations, that is 20 to 25 kilocalories per kg per day initially and then adjusted. You need to importantly note one thing. In obese patients, burns, those on CRRT and sepsis, this metabolic assessment needs to be modified accordingly. Then ultrasound for nutrition assessment. In recent advances paper, this is a very, very high potential question. So I would recommend to give a thought into this. So the main rationale for this is can be done at the bedside. It is non-invasive and repeatable. It is not affected by fluid overload like BMI or weight. It detects muscle wasting early and monitors effectiveness of nutrition therapy over time. All right. So the parameters that you can assess with ultrasound are muscle thickness. So the site where you do it is at the quadriceps femoris, that is the rectus femoris and the vastus intermedius. The other size that can be done at the biceps, triceps, and abdominal wall. So the key findings that can be there is decrease in thickness up to 10% loss can be there in the first week following critical illness. So the significance is it correlates with muscle mass, strength, and outcomes. Then coming to cross-sectional area, you can assess it using the rectus femoris. It is supposed to be more accurate than the thickness alone, and it is a better measure of global muscle mass. Then coming to echogenicity, you can use it for any muscle. Increased echogenicity indicates increased fatty infiltration or fibrosis. It reflects muscle quality, not only quantity. Then you can assess the diaphragm thickness and excursion, which most of you would know about. So the site is the diaphragm. So if there is a decrease in thickness or excursion or thickness fraction, then it predicts prolonged ventilation and weaning failure. So these are the four things that you can assess using ultrasound in relation to nutrition assessment. So next question is how to make a nutritional plan in a critically ill patient for enteral nutrition. So first is look for contraindications. So if there is hemodynamically instability or shock, bowel obstruction, severe or protracted ileus, major or upper GA bleed, intractable vomiting, gastrointestinal fistula, gastrointestinal fistula, and abdominal compartment syndrome. So these are all considered as contraindications for enteral nutrition. So the initial assessment is first you need to go ahead with the nutritional risk screening. So you go with validated tools like Nutri-Score. Like I said, you need to assess the Nutri-Score to assess whether you can go with the aggressive nutritional therapy in high risk groups. Then you can assess the M-Nutrix score, which is another alternative. Then you can assess the subjective global assessment tool. Then anthropometrics and clinical parameters like BMI, then weight, muscle mass, edema, or presence of organ dysfunction. Then lab parameters that can be used are prealbumin, then electrolytes, glucose, renal, and liver parameters. Then disease severity like sepsis, ARDS, and shock states. So these can be kept in mind. Then the timing of enteral nutrition. They say it needs to be started as early as possible. So start within 24 to 48 hours of ICU admission if the patient is hemodynamically stable. If they are on vasopressor supports, delay until MAP is stable and lactate is improving to avoid gut ischemia. Then caloric requirements in the early phase, that is the first 4 to 7 days, start with a hypocaloric feeding, that is less than 70% of the needs to avoid the risk of overfeeding. So then target energy after stabilization would be 25 to 30 kilocalories per kg per day as per the ESPN and ASPEN guidelines. And for assessment of energy expenditure, you can go with indirect calorimetry if available, or you can go with predictive equations like the one I had mentioned previously. Then protein requirements, you go with 1.2 to 2 gram per kg per day, higher in burns, trauma, sepsis, lower in advanced liver or renal dysfunction without renal replacement therapy. During CRRT and hemodialysis, you need to increase the protein intake to 2.2 to 2.5 grams per kg per day. Then regarding the route and formula selection, nasogastric is preferred or post-pyloric should be considered if aspiration risk is there or intolerance. So the formulas that can be used are standard polymeric formulas for most patients, semi-elemental if malabsorption is present, and disease-specific feeds like renal diet, hepatic diet, or diabetic diet when indicated. So high protein formulas are often preferred in ICU. The main reason, like I said, is because of critical illness causing a decrease in your lean body mass. It is always preferable to go with high protein formulas. So then the feeding strategy. We start at 20 to 30 ml per hour, advance it gradually over every 4 to 6 hours as tolerated. So this is not a standard norm. This varies with each ICU protocol. All right. So what I mentioned here is based on the ISCCM guidelines. So continuous feeding is preferred over bolus in critically ill patients. Continuous feeding with pumps or gravity bags can be preferred with use of fine bore tubes, that is 8 to 12 French. Then scientific feed formula should be preferred over blenderized feeds to minimize feed contamination. Check gastric residual volumes by syringe aspiration and not by suction pump. This point is very, very important. And GRV of less than 300 ml can be refilled if it is not blood stained. Whereas if it is more than 300, it is recommended to use prokinetics. And other indications for use of prokinetics are regurgitation or aspiration of feed contents. Now, with regard to use of the prokinetics, SPEN guidelines recommends only two. One is metoclopramide in a dose of 10 milligrams 12th hourly to 8th hourly. And the other one is erythromycin in a dose of 250 milligrams 8th hourly. So main concern with erythromycin is you need to give it for a maximum of 48 to 72 hours because after that period, the risk of tachyphylaxis sets in. So most of the setups, metoclopramide is what is used routinely used. Other drugs like cisapride or levosulfuride also can be used, but they are not recommended as per the guidelines. The next is monitoring and adjustments. It is always important to monitor the electrolytes, especially potassium, magnesium, and phosphorus, to assess for refeeding risk. And along with that, you need to assess the glucose levels and the hydration status. Assess for GI tolerance, that is, you assess for distension, vomiting, diarrhea, or constipation. Assess for aspiration risk. Always keep the patient in a head up position of 30 to 45 degrees. And if refeeding syndrome is present, you start slow, then supplement thiamine also and correct electrolytes prior to feed initiation. Micronutrient and adjuncts provide daily vitamins and trace elements, especially if the patient is in a prolonged ICU stay, because they will be having deficiency of trace elements and vitamins. So vitamin D, selenium, zinc supplementation, if deficient, should be given. The other trace element I missed is chromium. So that also needs to be given. Special considerations in obese patients, that is BMI more than 30, you go with the hypocaloric, high protein feeding. That is 11 to 14 kilocalories per kg of the actual body weight and the protein of 2 to 2.5 grams per kg ideal body weight. And in AK and CA30, you can go with higher proteins. In severe liver failure, adjust proteins carefully, but avoid unnecessary restrictions. Because many a times, because of hyperammonemia causing hepatic encephalopathy, there is always thought process that you need to cut down on the proteins or limit the proteins. That concept is now not there. And in shock, you delay feeds till the perfusion is restored. Simple to say once you receive the patient, you stabilize the patient is on dual vasopressors, but that vasopressor concentration is static or it is starting to reduce. That is the point when you can start feeds because that is what is called as a stable shock. So this is just what I had adapted from the ISCCM guidelines. So on patient admission, check if they are stable or not. If they are not stable, wait for the stabilization. Then if they are stable, then you assess the patient for risk of malnutrition. So you do the Nutrix score and the SGA, do anthropometric assessment if it is feasible, assess the electrolytes and the nutritional requirements. So you can use indirect calorimetry or formula, algorithmic formulas. If enteral feeding can be initiated, you go ahead with that. You assess if oral feeding can be given. If not, then you go with enteral feeding. So enteral, the ideal one will be to go with the nasogastric feed. If the post pyloric feed is recommended because of increased aspiration or because of poor feed tolerance, then you can go ahead with that also. Whereas if enteral feeding is not feasible for more than 72 hours in a high risk case, then you will have to consider parenteral nutrition. If it is a low risk scenario, then you can go waiting till period of 5 to 7 days also. So when you start the feeds, you start in the shock state, you started as trophic feeds around 10 to 20 ml per hour. If they are not in shock and you are starting it as part of a routine protocol, you can start it as 30 ml per hour and progressively increase it. Some ICUs increase the feed rate every 24 hourly, whereas the IACCM guidelines recommended to increase it every 4 to 6 hours. So by 72 hours, it would be ideal to get the target to the baseline, like satisfactory target. Like what energy requirement, the minimum is 25 kilocalories per kg per day. By around 72 hours, if you are able to get it, well and good, but it should be achieved within 7 days. Then important to assess for feed tolerance, you assess abdominal distension, whether there is nausea, vomiting, or aspiration of contents or diarrhea. So if any of those are there, then there is probably intolerance and that needs to be troubleshooted. And if persistent diarrhea is there because of malabsorption, then you will have to consider changing to semi-elemental formula feeding. So this was what I had mentioned about the nutritional assessment, road energy requirement, then symptoms indicating gut dysfunction. Reasons for intolerance that you need to keep in mind is oral hyperosmolar solution, especially when you give syrup potassium chloride, then antibiotics or sorbitol-based drugs. All these can cause osmotic diarrhea. So this is about enteral nutrition. So I would personally recommend those who are watching this to please take a screenshot. I had compiled all the disease states and made a table on the energy requirements, the proteins, and the preferred routes. And in the last, I have mentioned the key references also. So if you take it within 5 to 10 seconds, I'll then move on to the next topic. Okay. So coming to refeeding syndrome, very, very high potential question, must know question. So, refeeding syndrome is defined as a medical complication that results from fluid and electrolyte shifts as a result of aggressive nutritional rehabilitation from any source. It can be an oral diet, enteral nutrition, parenteral nutrition, or intravenous dextrose solutions. So, even in dextrose solutions, you can get refeeding syndrome. Metabolic disturbances manifest as cardiopulmonary, hematological, and neurological dysfunction in these subset of patients. And hypophosphatemia is considered as the hallmark of refeeding syndrome and is often used as surrogate marker for refeeding syndrome. So the American Society for Parental and Enteral Nutrition, ASPEN 2020, they define it as a decrease in serum phosphate, potassium, and magnesium within 5 days of starting feeds or significantly increasing nutritional support in a previously malnourished or starved patients. So they have a grading, mild, moderate, and severe, where mild is 10 to 20% fall in any of the electrolytes, moderate is 20 to 30% fall, and severe is more than 30% fall. Or there is presence of organ dysfunction due to electrolyte shifts and or thiamine deficiency. So this is a very important definition that you need to keep in mind. So the risk factors, we have high risk factors like BMI less than 16, more than 15% weight loss in 3 to 6 months, no intake for 10 more than 10 days, or low baseline electrolytes. Then you have very high risk factors like BMI less than 14 or no intake more than 15 days. And ICU specific amplifiers like organ failures, sepsis, mechanical ventilation, alcohol use, oncological patients, diuretics, insulin therapy, CRRT, and frailty. Frailty meaning the elderly group of populations who are the ones who are at increased risk of refeeding syndrome. So these are the important risk factors that need to be kept in mind. From an exam perspective, when you read so much of content for theory, it is difficult to remember. Please remember at least 3 of these. So coming to the pathogenesis, first you need to know what happens during starvation and then what happens during refeeding. So the metabolic changes during starvation is, under normal circumstances, the primary fuel of the body consists of glucose that is derived from carbohydrate breakdown. So at least 100 to 150 grams of glucose is needed for daily optimal brain function and to prevent protein breakdown. So excess carbohydrates and protein intake can be stored at fat. So during short periods of fasting up to 24 hours, glucose which is stored in liver and muscles can be utilized after glycogenolysis to provide carbohydrates. During prolonged fasting, the metabolism switches from fat and protein utilization after glycogen stores have been depleted. So glucose is produced via gluconeogenesis, that is by degradation of amino acids, fatty acids, lactate, and pyruvate. So when the fasting period prolongs, the metabolic rate decreases by 20 to 25%, plus there is concomitantly depletion of your intracellular electrolytes and vitamins. So these loss are further exacerbated by diarrhea, vomiting, diuretic use, and other additional losses. So what happens during refeeding? So the patient is already starved. There is intracellular depletion of electrolytes and vitamins. So when a patient is reinitiated on a refeeding program, metabolism switches back from the protein and fat metabolism to the breakdown of carbohydrates. This leads in a marked increase in insulin secretion, leading not only to an increase in intracellular glucose uptake, but also an intake of electrolytes such as potassium, phosphorus, and magnesium. So this shift, along with the already depleted glycogen stores, can lead to changes in cardiac arrhythmias, neuromuscular dysfunction, and hematopoietic dysfunction. Insulin causes natriuretic effects on the renal tubules, so that leads to increased sodium and water reabsorption and retention, leading to extracellular volume expansion. And in susceptible set of patients, it can lead to severe pulmonary peripheral edema, and if very, very severe, can lead on to acute heart failure. So the clinical manifestations are usually seen within 2 to 3 days of refeeding. So they can manifest as hypophosphatemia. So from an exam perspective, you can classify it into 4 areas: neurological, CVS, RS, and hematological. So in neurological, there can be paresthesias, weakness, delirium, seizures, and coma. CVS, there can be shock because of decrease in contractility, causing a decrease in stroke volume. Then there can be cardiac arrhythmias. There can be diaphragmatic weakness. Then hemolysis, thrombocytopenia, and leukocyte dysfunction can also occur just because of hypophosphatemia. With regard to hypokalemia, there can be weakness, cardiac arrhythmias, gastroparesis, paralytic ileus, or colonic pseudo-obstruction can occur. So that can manifest as nausea, vomiting, abdominal distension, and constipation. And in worst case scenarios, it can cause rhabdomyolysis. Hypomagnesemia can produce symptoms which can be a combination of hypokalemia and hypocalcemia, whereby there can be weakness, tremors, altered mental status, tetany, seizures, and coma. Cardiac arrhythmias can be seen in these groups, and they can also lead to ileus, which can manifest as nausea, vomiting, distension, and constipation. Then thiamine deficiency can occur, which can manifest as lactic acidosis, Wernicke's encephalopathy, Korsakoff psychosis, wet beriberi manifesting as heart failure, nystagmus, and dry beriberi manifesting as peripheral neuropathy. Then sodium retention, which can lead to fluid overload, pulmonary edema, and cardiac decompensation in susceptible group of patients. So the diagnostic criteria, like I said in the initial slide, it occurs within 5 days of reintroducing or significantly increasing the calories. So the severity can be classified as mild, moderate, and severe. So mild is 10 to 20% fall in serum phosphorus, potassium, and magnesium. Moderate is 20 to 30% fall, and severe is more than 30%. The hallmark is hypophosphatemia, though hypokalemia and hypomagnesemia are equally important to be looked into. So coming to the treatment. So identification of critically ill patients at risk of refeeding syndrome is very, very important. So you see there is a decrease in phosphorus level of at least 0.5 milligrams per deciliter to below 2 milligram per deciliter from the baseline levels on ICU admission within 72 hours after commencement of nutritional support is very, very high suggestive of refeeding syndrome. And important to assess for risk factors. Like I said, you have high risk factors, very high risk factors, and ICU related factors. So the initial management, the initial treatment, you can classify it into two parts. There is the general measures and the specific measures. So in general measures, you have airway management, where if it is compromised, you will have to intubate. And ventilatory management, you can go with NIV or invasive ventilation if there is respiratory distress, apnea or bradypnea. Then circulatory management is mainly you need to concentrate on management of heart failure and cardiac arrhythmias. So cardiac arrhythmias can be managed with pharmacological and or electrical cardioversion, and acute heart failure can be managed with inotrope supports, vasopressors and or diuretics. And with regard to disability, if they present with coma, you need to rule out other causes like structural lesions and other metabolic abnormalities before you come to a diagnosis of refeeding syndrome related complications. And if seizures are there, then you will have to initiate them on anti-seizure medications. So with regard to specific treatment measures, before feeding, you check phosphorus, potassium, magnesium, you correct them if they are low. Administer thiamine of 100 to 200 milligrams IV before starting feeds or IV dextrose and continue it for 5 to 7 days. And supplement multivitamins, that other vitamins, for at least a period of 10 days in this subgroup of patients. With regard to caloric initiation, start with 10 to 20 kilocalories per kg per day or 100 to 150 grams dextrose in the first 24 hours. So you advance by about 25% of the goal in every 1 to 2 days. If the electrolytes is very severely low post initiation, then delay the feeding till it is corrected. If the electrolyte fall occurs rapidly during feeds, then you reduce the caloric content by 25%, stabilize, and then re-advance slowly. The best way of explaining this is through this diagram. So on day 1, you start at 25%. Then on day 2, you increase it to 50%. Day 3, you increase it to 75%. And day 4, you try to get it to 100%. So you assess the daily phosphorus levels and you then see how severe the fall is. So if there is about a 0.5 to 2 milligram per deciliter fall, then it's something that you need to be concerned about. So if it is very severe and you see that the other electrolytes are also very markedly low, then you need to reduce it by 25%. All right. So usually for a 50 kg patient, you would start with 10 kilocalories per kg per day as a target. So you go with 10 into 50 is 500 kilocalories on day 1 and gradually increase. So this table is being taken from the ESPN guidelines. So this advancement of 25% is based on the ESPN. It is preferable from an exam perspective to go based on the ESPN guidelines for this, because the ASPEN recommends it as 33%, but it is very, very difficult to titrate the feeds forward and backward based on the ASPEN guidelines. So what I would personally recommend is to go with the ESPEN guidelines of management of feed initiation and titration. Then with regard to electrolyte management, like I said, you need to monitor the phosphate, potassium, and magnesium levels every 12 hours for the first 3 days. Repeat according to the standard ICU protocols. So what they generally say is to potassium levels should be like supplemented as 2 to 4 milliequivalents per kg per day, phosphorus as 0.9 to 1.8 milliequivalents per kg per day, and magnesium of 0.4 milliequivalents per kg per day IV or 0.8 milliequivalents per kg per day oral. So this is as per the ASPEN guidelines. So you continue daily monitoring till the patient is clinically stable from a lab perspective and clinical perspective. Monitor vital signs every 4 hours for the first 24 hours. Usually in ICU setup, there is continuous telemetry, so this is not really concerning. Cardiac monitoring is essential in severe cases. Strict fluid balance should be kept in mind, and daily weight should be noted if it is feasible, and it is important to monitor the blood glucose levels. So there are there was one trial in relation to refeeding syndrome. This came back way back in 2015. Restricted versus continued standard caloric intake during the management of refeeding syndrome and critically ill adults. So the question was, in critically ill patients with refeeding syndrome, does restricting caloric intake compared to unrestricted caloric feeding reduce the composite outcome of ICU length of stay, overall survival time, and mortality at 60 days? So the final conclusion was there was no significant difference in the primary composite outcome, that is alive and after ICU discharge at day 60, but secondary outcomes like higher survival at 60 days in the restriction group was seen, longer overall survival time, fewer respiratory or airway infections, and shorter hospital stay. So these were the main positive takes from the refeeding trial. So then coming to the next question, that is gut dysbiosis and role of probiotics in ICU. So gut dysbiosis is basically alteration of the intestinal microbiota composition, diversity, and function. So ICU patients are at high risk due to antibiotics, mechanical ventilation, vasopressors, enteral nutrition interruptions, and critically induced immune dysfunction. So dysbiosis is considered as the motor of multi-organ dysfunction syndrome. So the pathophysiology of how this causes a problem is critical illness or ICU factors lead to loss of commensal microbes with a decrease in diversity. So on the contrary, there is an overgrowth of pathogens like Enterococcus, Pseudomonas, and Candida, which leads to increased gut permeability and barrier dysfunction, which leads to gut translocation with endotoxemia, leads to systemic inflammation, sepsis, and MODS. So the normal gut function helps to maintain the gut integrity, barrier integrity. It produces short chain fatty acids like butyrate and acetate, which are the energy for the colonocytes. It helps to maintain, helps to balance the immunity via the T helper cells and the regulatory T cells. And colonization index resistance is very, very preserved. That is, it helps to block the pathogens from interfering with their function and proliferating within the gut. The problem is because of the effect of dysbiosis in ICU, there is a barrier leak which leads to endotoxemia. There is loss of short chain fatty acids leads to poor mucosal repair. There is immune dysregulation leading to increased inflammation, and there is a pathogen overgrowth because there is no regulation. So that can lead to Enterococcus, Candida, and MDR bacteria. So the causes for dysbiosis in ICU, broad spectrum antibiotics, which kill the commensals, leading to domination by resistant organisms. Mechanical ventilation, where there is an oropharyngeal flora translocation leading to VAP. Vasopressors and shock, which leads to gut hypoperfusion, leading to ischemic or reperfusion injury. Parenteral nutrition, which leads to loss of enteral stimulation, leading to atrophy of mucosa. Opioids, PPIs, and stress, which alter the motility and acid barrier, leading to overgrowth. So these are the important causes of dysbiosis that you need to keep in mind. So the clinical relevance in relation to sepsis, gut translocation fuels bacteremia. So the patient would have come for one problem. Because of this dysbiosis, this gut translocation further adds fuel to the problem. In relation to VAP, migration of gut flora to the oropharynx and lungs is the main mechanism how it is one of the mechanisms how it produces the problem. With regard to MODS, dysbiosis drives the systemic inflammation, and in relation to C. difficile infection, loss of microbiota is associated with the pathogen bloom. So the main management strategies are to prevent or avoid dysbiosis is antibiotic stewardship, early enteral nutrition, probiotics, selective digestive decontamination, and fecal microbiota transplantation. So with regard to antimicrobial stewardship, the main rationale is to limit microbiome injury. Early enteral nutrition, it helps to preserve mucosal barrier and microbiota. Probiotics helps to restore the balance and helps to decrease the VAP rates. Selective digestive decontamination helps to reduce the pathogens, and fecal microbiota transplantation helps to restore the diversity. So that is the main rationale for all these management strategies. So just an overview, you have an ICU patient, dysbiosis is suspected. supportive management is antibiotic stewardship and early entry feeds. Adjunctive is probiotics in selected cases and selective digestive decontamination only in selected ICUs. This is more important only from a theory perspective. In most of our India ICU settings, this is not a feasible option because of the high resistance rates. And in rescue scenarios or in research phases, fecal microbiota transplantation can be considered in refractory cases. So coming to probiotics in ICU, probiotics are live organisms that when administered in adequate amounts confer a health benefit on the host. So critical illness profoundly alters the gut microbiota due to antibiotic exposure, mechanical ventilation, altered nutrition, and systemic inflammation, like we discussed in gut dysbiosis. So this predisposes to VAP, antibiotic-associated diarrhea, and C. diff infections. So
restoring microbial balance with probiotics has therefore been studied as an adjunct in ICU care.
So the physiological aspects are gut barrier protection. So it helps to strengthen the intestinal, epithelial, tight junctions and mucosal defense, thereby reducing bacterial translocation. Then the metabolic effects. It helps to generate short-chain fatty acids like butyrate and acetate that support the enterocyte health and systemic metabolism. Colonization resistance. It helps to compete with pathogens for adhesion sites and nutrients, produce organic acids and bacteriocins that inhibit harmful flora. Immunomodulation, that is increase mucosal IgA, modulate cytokine profile, that downregulate the harmful cytokines, TNF alpha, IL-6, and upregulate the good interleukins, that is IL-10. And with the systemic impact, it helps to reduce endotoxemia, modulate inflammatory signaling pathways. So indications are prevention of VAP, prevention of antibiotic-associated diarrhea, reduction of the candida colonization in gut and oropharynx, enteral feed tolerance. Some trials show a decrease in diarrhea and feeding intolerance. And immune support in sepsis, it is still an investigational area. So when you have indications, there are always contraindications. So absolute contraindications is severe immunosuppression like neutropenia or hematological malignancies, because lactobacillus and Saccharomyces have been associated to cause bacteremia and fungemia respectively. So I put just a reference article over here for your reference. And relative contraindications are disrupted gut mucosa like perforation or uncontrolled fistula, where gut translocation risk is higher if the mucosal integrity is compromised. So probiotics crossing into the bloodstream is being documented in GA surgery and short gut cases. Another important contraindication is in severe pancreatitis. The landmark trial was the Propatria trial. So multi-species probiotics increased mortality and increased the risk of bowel ischemia. So the probiotic strains that were studied are, from exam perspective, just concentrate on this column: Lactobacillus, Bifidobacterium, Saccharomyces, and Streptococcus. So these are the 4 important strains that you need to keep in mind. So coming to the current evidences, there was one study that came by in 2016 by Manzanares, where they showed probiotics decreased VAP incidence, even though there was no mortality benefit. In 2020, there was another meta-analysis where it showed to reduce the incidence of VAP, but there was a high heterogeneity which was noted. Based on a Cochrane review, probiotics reduced VAP with a low to moderate certainty. So there was one RCT, that was a prospect trial, where they had studied lactobacillus versus placebo. There was no significant reduction in VAP, diarrhea, or C. diff or mortality. So that was when there was a concern regards its efficacy in ICU. And from a guideline stance, based on the SCCM guidelines and the ESICM guidelines in 2021, they do not recommend routine use. It may be considered in antibiotic-associated diarrheas. And in the IDSA 2021 for C. difficile, it is not recommended for primary CDA prevention. So these are the current recommended guideline evidences. If at all they ask you to appraise probiotics, I think this slide gives a good amount of information. So another important thing you need to know is about the difference between prebiotic and probiotic. So probiotic, like we had discussed, are live microorganisms that when administered in adequate amounts confer health benefits to the host. Whereas prebiotics are non-digestible food ingredients that selectively stimulate the growth or activity of beneficial microorganisms already present in the gut. So the nature are probiotics are living organisms, whereas prebiotics are dietary substances like fiber, oligosaccharides, and resistant starches. So the examples, like I said, are Lactobacillus, Bifidobacterium, Saccharomyces, and Streptococcus thermophilus. So here in prebiotic, you have inulin, fructooligosaccharides, galactosaccharides, and resistant starches. So the mechanism for probiotic, they colonize the gut, suppress the pathogens, enhance gut barrier and immune functions. Here in prebiotic, they serve as food for beneficial gut bacteria, increase short-chain fatty acid production, and promote growth of bifidobacteria and lactobacilli, which are present within the gut already. So the clinical role, been studied for the prevention of VAP, antibiotic-associated diarrhea, and C. diff prevention. They're used with probiotics to enhance survival and activity in probiotic strains. So they generally stay safe, but they may cause bacteremia or fungemia in immunocompromised patients. So prebiotics are generally safe, but the side effects are usually limited to bloating or gas. So coming to the last question, this is just an add-on, just for benefit for all you guys who are going for the exams. List of trials with relation to nutrition. So with regard to calories and the route and timing of nutrition, we have the EPANIC trial, calories trial, Nutrient 2 trial, Eden trial, and the PERMA trial. So I'm not going into the content of this. This was one PPT I just wanted to put so that you guys could just like use it as a fast reference before the exam. So those who are online, you could just take a snapshot of this. So within 5 seconds, I'll move on to the next slide. So that also you can see. Okay, so the next other few important trials that came up are the Target trial, the Eat ICU trial, the Nutria 3 trial, and the Intact trial. So mainly made it like a pickup format so that it would be easy to identify and like revise it before your exams. Then coming to immunonutrition and micronutrients. So usually immunonutrition and ICU usually can be asked as a short question. So that is why I thought I should put this table. So this is just one table which shows the basic important trials and the outcomes that were associated with it. So we'll take 5 seconds, then we'll go on to the next one. Okay. So with regard to the protein dose, you have the effort protein trial, which was done in 2023. Intervention was high protein, 2.2 grams per kg per day versus low protein, 1.2. No benefit, but with high proteins, there was a potential harm in AK. So they say to avoid very high proteins. With regard to indirect calorimetry, you have the Tikakos trial. So the one which came in 2011 was a pilot study which showed benefit, whereas the one which came in 2021, it did not show any mortality benefit. So it is used for accuracy, but it has no relation to outcome. So the summary based on this trial is early nutrition, if enteral nutrition if feasible, but don't push to full feeds within the first 48 to 72 hours, especially if the shock is there, because there can be the risk of bowel ischemia. Proteins of 1.3 gram per kg per day is acceptable. Higher doses don't help. PN is safe if EN is not possible, but don't start too early in low risk patients. Avoid immunonutrition. It has not shown to be beneficial. This was the latest trial which came up in 2025. That is the Target protein trial. That is augmented enteral protein nutrition during critical illness. So the main population question was in adult patients on enteral nutrition, does augmented enteral protein improve outcomes? So the formula with 100 ml, 100 grams per liter protein, that is an augmented protein group versus standard protein group, that is 63 gram per liter. So there was no improvement in 90-day mortality. So higher enteral protein did not improve outcomes in the general ICU population. So this was the important take home. So this is one thing you need to keep in mind in the latest trials. Okay, I think this is the nutrition has been covered from my side. So next we'll have the next topic for discussion is on pregnancy.
Thank you, Srihari. That was very nice. Actually, you covered most of the recent articles also. You stop sharing your
Yeah,
screen. Hugh. Okay. Slide visible?
yeah, it's visible.
Am I audible?
Yeah, yeah.
Okay, great. Okay, so going ahead with the topics in pregnancy. So we have AFLP, that is acute fatty liver of pregnancy. So this is one of the short notes questions that can be combined with other questions in pregnancy or topics related to any hepatic disorder also. Okay, it is a very short topic. Okay, so I will go under the following headings. And what is acute fatty liver of pregnancy? It is a combination of hepatic dysfunction due to a microvesicular infiltration of hepatocytes. Okay, what are the infiltration which happens? It's the fatty acids which is incompletely metabolized. Okay, so it is thought to be a variant of the preeclamptic toxemia, has a higher mortality rate, both fetal and maternal. Okay, and the etiology is more likely told about improper metabolism in the fetal system as compared to maternal system, but exact etiology is still not known. So fetal fatty acid metabolism abnormality is what is known to be one of the processes or the causes for acute fatty liver of pregnancy. Okay, often these patients are also associated to develop diabetes insipidus. So if you look at the pathophysiology, if at all a question is asked, it's more commonly seen in low BMI nulliparous women with multiple gestation in the third trimester of their pregnancy. Okay, nulliparity, multiple gestation, low BMI, and towards the end of pregnancy, that is in the third trimester. So these are the pregnant females who are at a higher risk of developing AFLP. What usually happens is if these patients have a male fetus, predominantly it is seen in male fetus as compared to female fetus, it has issue with fetal fatty oxidation defects. So what happens? It causes accumulation of fetal long chain 3 hydroxy fatty acids. So this fetal fatty acid metabolism, which is not able to metabolize the fatty acids, overwhelms the maternal mechanism. Okay, the maternal hepatic metabolism to metabolize fatty acids. So because the enzymatic machinery in the mother is overwhelmed by excessive outpouring of fatty acids from the fetus, the liver goes into something called as acute fatty liver of pregnancy. That is what is characterized by the microvesicular deposition of free fatty acids. Okay, so remember, pregnant females, low BMI, last trimester, mostly male fetus, improper fatty acid metabolism in the child, overwhelming the maternal metabolism, causing acute fatty liver of pregnancy. So this is about the pathophysiology of AFLP. So precisely what happens is something which is still under research, but fetal fatty acid oxidation defects is what is seen. Okay, that is the long chain 3 hydroxyacyl CoA dehydrogenase deficiency. Okay, if you can remember it as LCHAD deficiency is more than enough. Okay, it is quite straightforward for long chain 3 hydroxyacyl CoA dehydrogenase. Okay, so because of this deficiency, the free fatty acid goes up, and then the maternal system cannot metabolize this, and there's a lot of fatty acid which is in the circulation of the mother, which is getting sequestered in the hepatocytes. Okay, so this is about the pathophysiology. Defect in free of fatty acid oxidation causing maternal hepatic dysfunction. So, what is the maternal hepatic dysfunction? One is the accumulation. It also causes impaired beta oxidation, causing reduction in the production of ATP, increased production of reactive oxygen species, and hepatocyte injury. Usually, the hepatic dysfunction is characterized by impaired gluconeogenesis, which causes hypoglycemia, impaired urea cycle causing hyperammonemia and hepatic encephalopathy, mitochondrial dysfunction causing coagulopathy, lactic acidosis, etc. Usually, these patients are also associated with renal and pancreatic abnormality. Please forgive the typo. Okay, so they are known to cause uh, acute kidney injury, and sometimes even pancreatitis is also associated with AFLP. Okay, so you might have an elevated lipase and amylase in patients who develop AFLP. So you might be thinking, what is the preceding insult? So it's always a little confusing when the patient comes to us. Okay. Coming to the clinical features, it can start with nausea, vomiting, epigastric pain, polyuria. Okay, usually these are the symptoms which can be seen even towards the end of pregnancy, sometimes in a few patients. So they might be initially very trivial like these. Later on, if you see this patient develops jaundice, encephalopathy, polydipsia, worsening, hemodynamic parameters. Okay, along with malaise. So this is the clinical symptom complex of acute fatty liver pregnancy. Okay, so always remember, if a patient with the last trimester of pregnancy presents with these symptoms, okay, with especially epigastric pain or right upper quadrant pain, rule out jaundice. Okay, rule out icterus in such patients. Analyze for presence of hypertension. Do a scan probably, and then if you have other associated symptom complex like polydipsia, polyuria, etc., then probably you have to come to a diagnosis of acute fatty liver of pregnancy. So this still now is not very straightforward, right? It can be seen in a lot of other conditions as well. Okay, so how do we understand this? So there is another criteria which I'll be discussing later. It's called as the Swansea criteria. So to come to the Swansea criteria, we need to do a certain investigations, because there's a lot of other diseases which can mimic AFLP. Okay, so what are the investigations that we have to send in AFLP? We have to send in your urine routine. You have to do a complete hemogram. Okay, probably you have to do a peripheral smear. Okay, because they also mimic something like micro angiopathic hemolytic anemias, which we will be discussing later on today. Okay, and patient can have consumptive coagulopathy. Okay, which also causes liver dysfunction. Okay, so pancreatitis, I told you, it can be the primary problem, or it can be a secondary sequelae of AFLP. So all of these things needs to be investigated in these patients. So what usually happens is, this is a beautiful diagram if you can understand how the process or the uh, disease progresses, okay, from the time of presentation, and how the patient even recovers. Okay, if treated at the earliest, if picked up and treated earliest, they have good results. But if it's not recognized earlier, then the patient can die. Okay, so it has a mortality of up to 20%, like I've discussed earlier. Okay, the whole problem is with the fetus. Okay, in the third trimester of the pregnancy. So because the fetus is overwhelmingly putting the maternal circulation, maternal hepatic metabolism at stake, this would happen. Okay, so remember, third trimester having all the abnormalities that I mentioned earlier, that is deranged LFT, acute kidney injury, uremia, polyuria, etc., with probable signs of plus and minus DIC. Think about AFLP. Best thing is to optimize hemodynamics and deliver the baby. Okay, probably you might have to also think about fetal lung maturation and then go ahead and deliver the fetus. Okay, so if you have done this, usually within the first 7 days the patient starts recovering. Okay, and at the end of 1 to 4 weeks, all the other parameters also is set to recover to normalcy. Okay, so the timeline of insult to recovery is roughly between 1 to 4 weeks if everything is managed accordingly. Okay, so I told you we need an objective criteria for diagnosis. So what is the objective criteria? It is the Swansea criteria. Okay, so there are a lot of parameters associated with Swansea criteria. So it is some tool that you need to remember. Okay, so it has basically starts with symptom complex like vomiting, abdominal pain, polyuria, polydipsia, and encephalopathy. And after the symptom complex, you can see the laboratory parameters. What are the laboratory parameters involved? It is bilirubin, hypoglycemia, okay, and uric acid and leukocytosis. After that, they go to enzymes, etc., like AST, ALT, ammonia, creatinine, and coagulopathy. The last thing is radiological, that is ultrasound showing ascites, and ultimately liver biopsies will help us diagnose microvascular steatosis. Okay, so in Swansea criteria, if a score is more than or equal to 6, then it is almost confirmed that this patient has acute fatty liver of pregnancy. Okay. So what do we do? So firstly, remember it is a diagnosis of exclusion. Okay, so you have to do all your routine investigations. So whenever the patient comes in the third trimester, look at other causes. Okay, there might be other causes for uh, jaundice as well. Rule out other causes of in raised bilirubin. Okay, so whether hemolysis is there. Okay, all of that has to be ruled out, and then you do all your routine testing. Most often, if there is hypertension present in the third trimester, we can also think that this patient can develop HELP. Okay, so HELP is one of the major differential diagnoses for AFLP. So that has to also be ruled out. So if you have done all your basic investigation and you still feel the labs are within normal limits, then you do a routine workup and observe this patient. But if you feel that it is not proper, then you have to work up, look for your Swansea's criteria, and then come to a diagnosis of AFLP. And the management is always delivery of the fetus with other supportive care like watching for hypoglycemia, hemodynamic optimization, watching for acute kidney injury, hepatoprotective measures. Okay, these are the things that you need to do for a patient with uh, acute fatty liver of pregnancy. Okay, so this is about the mother. So what do we have to do for the fetus? Always have a cardiotocogram, monitor the fetal activity, manage the hypertension, okay, and look for any acid base imbalance, because that can directly insult the fetal activity and can also cause a fetal demise. Okay, so these are very important. Okay, so this patient has to be closely monitored and timely intervention has to be done. Okay, so you might have to start this patient on Maxwell's drip also, okay, based on pre-eclampsia, if at all the patient is predilected to develop. So that is also supposed to be kept in mind. Okay, if the mother develops diabetes insipidus, then you need to use desmopressin. Other hepatoprotective measures, etc., have to be controlled. Most importantly, when you're giving hepatoprotective measures, beware. Okay, so patient might lose a lot of fluids also, so you might have to titrate all the hepatoprotective measures based on response. Okay, worst case scenarios, there have been case reports of even liver transplantation, but still widespread necessity and guidelines for liver transplantation in AFLP is not present. Most of the data which is available for AFLP, they say if you treat the patient at the earliest and delivery is done, it is more than enough that the patient will recover. Okay. So what are the complications associated with acute fatty liver of pregnancy? It can be encephalopathy, ascites, hypoglycemia, consumptive coagulopathy, and pancreatitis. Okay, so these are the complications, and they have to be managed accordingly. Okay, sometimes even volume sequestration, etc., can happen. Capillary leak that can also cause ARDS. Okay, so I told you earlier the most important differential diagnosis of AFLP is HELP syndrome. Okay, so whenever the patient has AFLP, also think about HELP. Okay, most important diagnostic distinction, what you would see is acute kidney injury, etc., is more common in AFLP as compared to HELP. In HELP, mostly you will see proteinuria, elevated LDH, hyperbilirubinemia, etc. Okay, so that is more thing, and the development of jaundice will not be as severe as compared to AFLP. Okay, AFLP will have a higher burden of jaundice as compared to HELP. Okay, so this is most important categorization. Along with that, HELP itself has a different set of the enzyme derangement would be very high. Okay, so you have to use your other criteria for diagnosis of HELP in such patients. Okay, so keep that in mind most often. Okay, and schistocytes, etc., are most commonly present in HELP, which is usually not seen in acute fatty liver of pregnancy. Okay, so there is some amount of lysis. So lysis is always associated with low haptoglobin, schistocytes, etc. So these are the markers that can help you differentiate between AFLP and HELP. Okay, so this is about the differentiation between AFLP and HELP. So this is a summary. Okay, this is just about how to go about. Okay, pathophysiology, write about the presentation, findings, differential diagnosis, and lastly, management. In management, don't stop with maternal support. Think about fetal also. Okay, so you need to talk about sequelae and complications as well. Okay, so this is the gist of a management of fatty liver of pregnancy. Okay, that's a very straightforward thing. Okay, so it can be asked like a short note. Okay, not much to know about. Coming to the next topic in pregnancy, that is about maternal cardiac arrest and perimortem cesarean section. Okay, so this is also one question which can be both in practical and theory. Okay, so as we all know, maternal mortality is a key health indicator. Okay, especially with majority burden, when 120,000 still having this issue. Okay, so cardiac arrest in mother usually has a higher mortality for mother and also the fetus. Okay, so the WHO estimates roughly around 25% of deaths in India are usually because of maternal mortality. Okay, so that is something that we need to look up. Okay, so why is it different compared to any adult cardiac arrest? Okay, the only reason is because here both mother and the fetus is at risk, and we are going to treat them. Usually, maternal cardiac arrest, unlike an adult cardiac arrest, involves a pediatrician or a neonatologist, obstetrician, intensivist, and an anesthetist. Okay, so usually it's a multi-department or multidisciplinary approach for while managing. Okay, you need to call for help at the earliest. So, what are the risk factors associated with maternal cardiac arrest? Broadly, we can categorize into cardiac and non-cardiac. So, cardiac risk factors for maternal cardiac arrest are congenital heart disease with pulmonary hypertension, valvular heart disease, cardiomyopathy, coronary artery disease, recent ACS, connective tissue disorders or vasculitic disorders, prior history of cardiac surgery, recent pulmonary embolism. Okay, all of this is a cardiac risk factor for maternal cardiac arrest. Non-cardiac are hemorrhage, sepsis, eclampsia, and anemia. Okay, so these are the risk factors. Coming to etiology, what are the etiology? We all know there can be two ways that you can categorize the etiology of maternal cardiac arrest. It can be by A, B, C, D, E, F, G, H, or Biochops. Okay, remember when we're talking about adult cardiac arrest, we usually talk about 5 H's and T's, right? So along with them, then you have to think of all these issues. Okay, so each A stands for anesthesia accidents, B stands for bleeding, cardiovascular causes, drug causing maternal cardiac arrest. Okay, embolic events like pulmonary embolism because they're in a procoagulant state, any sepsis causing this. Okay, along with your 5 H's and T's, and hypertension, especially hypertensive disorders of pregnancy. Okay, so usually all of this is what we need to remember. So it's similar. The other mnemonic is Biochops. Okay. So, if all of this is present, is there an early warning sign which can be used as an objective tool to pick up these things? So, most of the times we have mothers admitted in the labor wards, in the wards as well, right? So, is there an objective tool that can help us? Yes. Similar to the Muse which we use, we have an obstructive early warning score as well. Okay, so usually it has to be done. Okay, on an hourly basis, and whenever the score is more than 3, then probably it has to be appraised to a doctor, especially probably an obstetrician. Okay, or else if there is any other intensive care being involved with obstetrics, they have to be appraised. So what are the parameters that are involved in obstetric early warning score? It's temperature, pulse, respiratory rate, systolic blood pressure, urine volume. Okay, mode of birth. Okay, most of the other parameters are similar to what we use in Muse. That is your temperature, heart rate, respiratory rate, SBP, and consciousness level. Urine output is also there in Muse. The only additional part here is the mode of delivery. Okay, so surgical, we all know probably the blood loss is high. Okay, so that is the reason it carries a higher risk. Like that is 2. Vaginal delivery, probably it is anticipated to have a lesser blood loss, so that is why the score of 0 to 1 comes there. Okay, so this is about an objective tool to assess high risk mothers for patients deteriorating in the wards. Okay, so usually a score more than 3, you have to call a doctor. Score more than 6 is associated with a higher mortality, roughly up to 6.8%. So why is maternal cardiac arrest different? We all know the maternal physiology is very different. Okay, not going into details of physiological changes of pregnancy, but this is something that we have to know. So we all know that mother is a procoagulant condition, hemodiluted state. Okay, and there is increased demand. Okay, supply is always being challenged, and there is always change in the respiratory and the circulatory systems. Okay, so the reserve in the mother is usually less as compared to any other adult. Okay, so this is one of the major reasons why maternal cardiac arrest is discussed as a separate entity. Okay, even in ACCLS. Okay, so coming to the basic life support and maternal cardiac arrest. Okay, so it is similar to what we see in any other condition wherein the patient has a cardiac arrest. So you have to activate the maternal code blue. Okay, or else if you have a bystander approach, you have to check for unresponsiveness, check for breathing like how we do, check for the pulse, and then you have to activate the code. Okay, so usually it needs a special consideration because it's an obstetric patient. Time is of the essence. The time of cardiac arrest has to always be documented. Okay, so if spontaneous circulation is not restored after 4 minutes of effective resuscitation, probably this patient warrants a cesarean section if the patient is in a hospital based setting. Okay, obviously if the patient is in the public, probably we cannot do, but yes, definitely if it's in the hospital based setting, we can think about it. Okay, so coming to what are the nuances associated with maternal cardiac arrest. Firstly, chest compressions. Okay, the positions of the hands for the chest compression is similar to what is seen in non-pregnant. Okay, so there is no change in the position of placing. Okay, so why they said this is based on multiple MRI scans which they had collected over a period of time. They saw that there was no significant vertical displacement of the heart in pregnant state. Okay, so that is the reason they said there is no change. Okay, on the other hand, how do we do about compression, fraction, depth of compression, etc.? Everything remains to be the same like we do in any other adult. Okay, only thing is, remember, the important thing is here the reserve is less, so you have to act quickly and you're trying to save 2 lives. So the depth should still be 5 to 6 centimeter of depth. Rate should be 100 to 120. Compression ratio to ventilation ratios should be 30:2. Okay, always have a cardiac board when you start. Okay, initially you might not have it, but then later on during the compressions you should place them. Okay, and similar to what we do in adult cardiac arrest, the interruption between compressions should not be more than 10 seconds. The other important thing which happens here is the uterine displacement, which usually we don't see in other adults, right? So here, because there is a gravid uterus present, there's always an issue of aortic compression which can happen along with caval compression. So aortocaval compression can be caused because of a gravid uterus. So when does this happen? Is it there in the early trimester? Unlikely in the earlier trimester. Once the uterus becomes a abdominal organ from the pelvic, it comes into the abdominal compartment. So the patient here at the gestational period of more than 12 weeks can have aortocaval compression. Okay, so in such patients you should do a left lateral uterine displacement. Okay, when you're implementing CPR. Okay, so it's always a good practice to do this in all gestational age, because most of the time you would not know the gestational age. Okay, so that is the best practice statement we can give, but definitely if at all you know it is more than 12 weeks, better to give LUD, that is your left uterine displacement. Okay, so how do we do that? It is usually uh, depending on where the provider is standing. Okay, one hand technique or the two hand technique, as it is shown in the diagram. Okay, so whenever you're giving two-hand technique, you stand on the left-hand side. One-hand technique, you stand on the right-hand side. So this is one practical thing that if you can remember. And adequate shift whenever you're thinking about is to move it up to 1.5 to 2 inches. Okay, so if you move it by 1.5 to 2 inches, it helps optimize the venous return, thereby improving the stroke volume. Okay, especially during CPR. Okay, so when you're doing the displacement, it should be leftward and upward towards the ceiling. So that is what is usually the way to move the uterus. Okay, coming to airway management. So I told you earlier the reserve is very less. So the thought of intubating such patients, especially in a cardiac arrest, should have a lower threshold to secure the airway. Okay, so remember that part. Okay, and always there are other things like we have been studying from time immemorial. That's a full stomach, decrease the reserve. Okay, so chance of aspiration is very high. All of this have to be kept in mind. Okay, so the airway should always be open using a head tilt chin lift maneuver unless otherwise contraindicated. You can try and use adjuncts, but better to avoid a nasopharyngeal airway because these patients are prone to have bleeds. Okay, they'll have a friable mucosa, so it's always better to avoid a nasopharyngeal airway. Oral airway should be okay. Okay, so that is one of the important things associated with airway management. Okay, so always probably if the patient is a little obese, try and have multiple size endotracheal tubes, etc. These are the things that we need to be mentioning in airway management in a maternal cardiac arrest. Coming to breathing, we know FRC is low, oxygen demand is high, shunt is high because of gravid uterus. Okay, so with all of this, Bagmar's ventilation should be there, but do not delay intubation. Okay, so ventilation rate, don't increase it to more than 8 to 10, again because alkalosis will again cause a lot of fetal and maternal complications. Okay, so that is very important. So don't hyperventilate this patient. Okay, 8 to 10 breaths or maximum to 12 breaths is more than enough. Don't cause iatrogenic respiratory alkalosis. Okay, this is one important thing I would want you to write in breathing when they ask you. Okay, so larger tidal volumes decrease the cardiac output. Again, they also can cause fetal acidosis. So be very judicious when you're giving ambu breaths. Coming to defibrillation, it should be used as soon as available. The energy joulage is similar to what we see in non-pregnant patients. Okay, it depends on the type of rhythm you're giving. Okay, there is no contraindications for cardioversion in mother. Okay, so the only thing is before giving a cardioversion to this patient or a defibrillatory shock, make sure that the fetal cardiac monitors are removed. Okay, so because there is a theoretical risk of transmission to the fetus. Okay, so that is one thing they have mentioned. Okay, but still things cannot be proven, but by guidelines way they're telling you not to continue with the CTG when you're doing it. Remove the CTG and then give the shock. AEDs can also be used wherever it is available because that will be much it will help us analyze and also shock the patient. Okay, coming to ACLS. Okay, in these patients, I spoke about airway. The next important thing, airway, breathing, and is majorly covered. Okay, so the most important thing I told you, don't use an nasopharyngeal airway. Other one is tubes. I told you multiple sets you have to have. Better to use 0.5 to one size lesser as compared to a non-pregnant person. Okay, if so, usually what they say use around 7 of. Okay, for an adult well-built lady. Okay, otherwise 6.5. It depends on the patient again. Okay, so this is one thing about the airway. Okay, keep a smaller size to avoid trauma. That is a major take-home point for airway. Okay, other one is IV drugs. The first and important thing in IV access securing is it should be above the level of the diaphragm. Okay, because again, if the gravid uterus is present, if the circulation is not going, then most of the drugs would not be circulated properly. So that is one of the practical reasons why they say secure an IV access above the diaphragm. Okay, if you're not getting it, emergency IU access, that is your intraosseous access, can also be accessed. Okay, dosing is very similar to what is in a non-pregnant patient. There is no change in doses for the drugs. Okay, remember the most important thing you have to remember is one is the size of the airway should be less, the other one is IV access you should secure above the diaphragm. Okay, and the left uterine displacement. If at all you have known the cause of cardiac arrest, you have to go ahead and use the particular antidote. There is no contraindications for using an antidote in maternal cardiac arrest. Remember, mother is the priority over the child in maternal cardiac arrest. Its fetus is an added bonus if we save it. Okay, but yes, when mother has a cardiac arrest, mother is the priority that we give. Okay, that is a non negotiable aspect of maternal resuscitation. Okay, so this table, I think so, will help you understand what is the difference between a non-pregnant cardiac arrest resuscitation and a pregnant cardiac arrest resuscitation. Okay, so if you can go see this, majorly we are not seeing much. What they say is the airway that I've already mentioned. Okay, one left uterine displacement, lesser reserve, overzealous ventilation can cause acidosis. That has to be kept in mind. IV access should be above the diaphragm. Okay, always keep a watch for drug toxicity. If at all they are present, then you have to give particular antidote. Okay, so this is about the differences between a non-pregnant and a pregnant cardiac arrest. Okay, so the algorithm is call for help, LUD, start compressions at the earliest. Okay, compression depth ratio, all of them, drugs, defibrillation, everything is the same. Okay, so only when you're giving a defibrillation, if you're using AED, etc., remove the fetal monitors. Okay, by and large, you can remove the fetal monitors as soon as the maternal cardiac arrest happens. Okay, that will be an easy way to go ahead. Okay. So if at all you do all of this, you have addressed your A, B, C, D, E, F. Okay, all of these causes for cardiac arrest have been ruled out. Then, if you are achieved ROSC within 4 minutes, good. If not, if it's more than 4 to 5 minutes, probably you have to think about calling the neonatologist and going ahead with the perimortem cesarean delivery. Okay, again, we need to have a lot of team who has to coordinate and do this. It's very easy when we tell in a flow chart. Okay, but there are a lot of issues associated with this when we're taking a call. It has to be informed and then we have to go ahead. Okay, so routinely there is no guideline telling that you have to do it. Okay, that is one thing most of us will have the doubt, do we always have to do it? No. Okay, so coming to the guidelines from the ACC-ALS. Okay, so what are they telling? Like good recommendations are, again, you have to have a team, start the resuscitation as the earliest. Resources show wherever for perimortem CS is there, you can think about it. Okay, especially when the patient is in the second half of gestation where the fetal maturity would be good. Okay, in such patients. Okay, again, protocols for out of hospital cardiac arrest have to still be made available to think about resuscitating even at the out of hospital cardiac arrest state. Okay, so by and large they're telling it's a team based approach, nothing great about the evidence for this, because this is all based on case reports. Okay, so most of the other thing is about targeted temperature management. So what they're telling is whenever the patient has achieved ROSC, in such patients better to do the TTM like we do in any other case. Okay, keep the temperature between 34 to 36 degrees Celsius. Okay, don't need to induce hypothermia, etc. Go ahead, get your other workup like a cardiac workup, etc. Probably based on the diagnosis, you can go ahead similar to a non-pregnant patient. Okay, so this is again level one recommendation. Coming to role of ECMO, there is still no widespread evidence for initiation of ECMO. Okay, because a lot of parameters will be haywire. Okay, it has not shown great benefits. Again, to talk about evidence for this, it's really difficult because you do not have that many cases that we are that are being done for this. Okay, so the best way to do is if the ACLS is less than 10 minutes, if you feel that the patient is getting a rhythm back and then going back again and back and forth, probably at that time you can convince them and see for the benefit of doubt. Okay, by and large, as of now, currently with whatever data is available, there is no evidence for VA ECMO in patients with maternal cardiac arrest. Coming to the last part of this talk, that is about perimortem cesarean section. So perimortem cesarean section, I told you, after 4 minutes of a CPR, if you're not able to get a ROSC, then at the end of fifth minute is what they're telling you to deliver the baby. Okay, so a cesarean section performed during maternal cardiac arrest or during impending maternal cardiac arrest. Okay, so it does not mean that majorly you need to understand this. The primary goal of perimortem CS is to increase the chance of survival for the mother. Okay, and potentially it might improve the fetal survival. Okay, but again, the primary duty for this procedure is aimed at maternal mortality reduction. Okay, so it is only to improve the circulation and improve chances of uh, achieving ROSC. Okay, so the whole gravid uterus might be one of the reasons why all this might be happening. So that is one area where we are looking at it. Okay, so again, it is for improvement of maternal, not the fetal resuscitation. Again, it is offsetting the compression of the IVC, helping the return of circulation. Okay, it also helps improve the respiratory mechanism, because the major effect of the gravid uterus on the diaphragm would be lowered. Okay, so by and large, this was actually introduced in 1986 by Carls et al. Lot of case reports have been studied, but as of now, also, okay, ACOG, everyone do not have any recommendations for perimortem cesarean section. Okay, so they say what even the ACLS criteria, what they say is, if there is a cardiac arrest, continue all your resuscitative measurements like your left uterine displacement, etc. Okay, look for causes. If you are able to do all of this and you still feel it is futile at the end of fourth minute, then consider doing a PMCS. Okay, so to accomplish the delivery ideally within 5 minutes at the time of arrest is reasonable, but again, practicality, if they're seen, there is no larger recommendations for PMCS yet. So, what are the recommendation by the RCOG, that is the Royal College of Obstetrics and Gynecology? So, if the fetus is dead, also even then you can go ahead and do it, just to see if it can help the maternal outcome. Okay, so anything if it's a pregnancy of more than 23 weeks, probably it can help improve the fetal outcome as well. Okay, the only thing, only essential equipment which is required for a PMCS is a 10 number blade. Okay, so unlike the phenenced incision, a longitudinal incision is what is made. Okay, directly the uterus is assessed and then the fetus is delivered. Okay, so this is about the procedure. Okay, so you have to do the left lateral decubitus incision from xiphoid to symphysis pubis. Okay, so bladder is retracted and a second vertical incision on the uterus. Okay, so that is given to deliver the baby. Okay, so in summary, remember, majorly there are no differences except a few physiological changes in the mother. Only the etiology of maternal cardiac arrest is more. Always secure an IV line above the diaphragm. Use a smaller side airway. Always watch for mucosal injury causing bleeding. Okay. Volume assessment is always necessary. Look for drug-induced maternal cardiac arrest, especially with patients with hypertensive disorders of pregnancy, patients receiving magnesium, patients who have been posted for cesarean or epidural, etc., who might develop local anesthetic systemic toxicity. All of this, okay, these have to be ruled out. Okay, so they are all reversible causes. So if they're picked up, probably at that time you can go ahead and do it. So these are the cases again which can be taken as a case for ECMO as well. Okay, wherein there is a definitive cause of cardiac arrest. In such patients, you might even think of doing an ECMO if they are having ROSC which is achieved but not sustained. Okay, so this is what you need to understand. So PMCS after 4 minutes, fifth minute you have to do it. Again, no major recommendations. If done, mostly it is focused on maternal outcomes, not the fetus. Okay, thank you.
Thank you, Darshan.
Thank you, ma'am.
So I have already completed PIH. So the next topic would be in obstetric, the PPH. Okay. So we all know that pregnancy results in a physiological compromise, which may pose a threat when presented with a pathology like eclampsia, pulmonary edema, and trauma. So what are the common causes of obstetric emergencies, which is leading to maternal mortality? The most common first one is your postpartum hemorrhage, followed by hypertensive disorders and some pregnancy related infections. The physiological changes include an increase in cardiac output by 30 to 40%, decreased SVR, and compression of gravid uterus on the aorta, which leads to a decrease in cardiac rhythm. So, physiologically, all your systolic, diastolic, and your mean, everything will be reduced. Your systemic vascular resistance is decreased. So, chances of hypotension in a patient, pregnant lady, are high. And in such patients, if they have a postpartum hemorrhage, then the risk of mortality increases, right? So I think we have already discussed in detail about the physiological changes of pregnancy. So just go through it once again. Now coming to the definitions. So the traditional definition of PPH was blood loss of more than 500 ml after a vaginal delivery, and if it is a cesarean delivery, more than 1 liter blood loss. So that was the traditional definition. But recently, this has been redefined as a cumulative blood loss of 1000 ml or more, or a blood loss which is associated with signs and symptoms of hypovolemia, irrespective of the route of delivery. Okay, so this is the new definition of PPH. And usually the typical signs and symptoms of the hypovolemia, like your hypotension, tachycardia, which usually occurs with the second stage, like within 15 to 30% of blood loss, it is usually not seen in postpartum hemorrhage until the blood loss exceeds nearly 25% of total body volume. So identification of PPH also becomes difficult. Okay, hence in worldwide, 8% of maternal deaths occur due to PPH in developed countries, whereas nearly 20% of maternal deaths occur in developing regions because of PPH. So now coming to the types of PPH. So there are two types, primary PPH and secondary PPH. Primary PPH is that which occurs within the first 24 hours after delivery, and secondary PPH occurs between 24 hours and up to 12 weeks after delivery. Okay. So what are the most common causes of postpartum hemorrhage? Remember your 4 T's. So first T is tone. So the most common causes uterine atony. Second, trauma, could be some lacerations or uterine rupture. Third T is tissue, that is your retained placenta or clots. And fourth one is thrombin, that is clotting factor deficiency. So these are the 4 T's causing your PPH. Okay, so as I told, the most common cause is uterine atony around 70% of cases, followed by obstetrical lacerations, which are around 20%, retained placental tissue around 10%, and clotting factor deficiencies account for less than 1% of the causes. Now coming to the risk factors. So this risk factors can be divided into antepartum, intrapartum and postpartum risk factors. So antepartum, most common is your multiple gestations, grand multiparity, any prior uterine incisions, history of postpartum hemorrhage, okay, morbid obesity, abnormal placentation and known coagulopathies. All these are the risk factors for antepartum risk factors for PPH. Next comes your intrapartum. Intrapartum, any augmented labor induction, protracted labor, intrauterine infections, magnesium sulfate use, and abruptio are the intrapartum causes. And coming to the postpartum causes, any operative vaginal delivery like your forceps or vacuum delivery, third or fourth degree laceration, cesarean delivery, precipitous delivery, retained placenta, and uterine inversions. So all these may cause PPH. So coming to the management. So management, it includes a coordinated multidisciplinary approach. That is very, very important. Okay, so you should have a good communication, accurate assessment of blood loss, proper monitoring, proper fluid replacement, and arrest of hemorrhage, and everything should occur concurrently. Now coming to the indications for ICU admissions. So there are two scores which helps us to decide the patient for admission into the ICU. So the first score is your MEOS score charting. Okay, it helps to better prognosticate the severity as well as the outcomes in obstetric patients. So this should be carried out at 8 to 12 hour interval depending on the clinical presentation of the patient. If the bleeding is mild, then every 12 hourly is okay, but if bleeding is severe, you need to repeat it at 8-hour intervals. And a score of more than 3 to 4 is an indication to consider the shift to an intensive care facility. Now, what is the score? So, it is a modified early obstetric warning system, that is your MEOS. Okay, so here you monitor basically your physiological parameters and you grade it as 0 to 3. Okay, so respiratory rate, oxygen saturations, any requirement of supplemental oxygen, temperature, what is the systolic and diastolic BPs, heart rate, the level of consciousness, whether patient has excruciating pain, any discharge, or presence of proteinuria. All this will be seen and you will grade it accordingly. So as I told, a score of more than 3 to 4 is an indication for shift to the ICU. Okay, and the second score is your OMQ SOFA, that is obstetrical modified Q SOFA score. It is same as our normal Q SOFA. So respiratory rate, systolic blood pressure and altered mental status. So a score of 1 will be given if your respiratory rate is more than or equal to 25 breaths, systolic BP is less than 90, 1 point, patient is not alert, 1 more point. So a score of more than 2 is suggestive of clinical deterioration and a need for intensive care management. Okay, so please remember 2 scores, MEOS scores and the OMQ SOFA score. Now, as I told, management should be multidisciplinary and it should be a protocol based management. So what do you mean by protocol based management? First one is you need to call for help. Second, you have to draw blood for cross matching and send for necessary investigations. Third, you have to simultaneously monitor the vital signs, urine output, see what drugs that has to be given and fluids administered, and side by side you need to inform the OT in case of any laparotomy or hysterectomy that has to be planned. Okay. So this patient is admitted in the ICU. Now, as a intensivist, what do you do? Okay. So first priority is your ABC, right? So we will go in that order. So first is airway. So assessment of the airway is very, very important because pregnant patients tolerate hypoxemia poorly and they always have a difficult airway. Okay, so monitor the saturations, do an ABG. If a PaO2 levels are less than 65 mmHg, please provide some supplemental oxygen. Okay, and think of an early intubation whenever possible. Okay, and keep a standby difficult intubation cart ready and always monitor oxygen level by pulse oximetry and simultaneously using a ABG analysis. Now coming to the breathing. So for effective gas exchange, you can use a face mask or a high flow oxygen or rarely NIV also. And what are the indications for endotracheal intubation? One is if your PA2 levels are less than 65, PCO2 levels more than 45, and your PF ratio, if it is less than 150, then all this suggests increasing respiratory distress and it prompts a urgent endotracheal intubation. Okay, and in patients who have a refractory hypoxemia and a continued respiratory distress, even you should think of ECMO in these patients. Okay, so this has already been discussed. Now coming to the intubation, so we'll discuss about the drugs. So muscle relaxants and sedatives. So scoline, it has a better safety profile in rapid sequence anesthesia in pregnant women. Coming to the non-depolarizing agents, your rocuronium, vecuronium, they are also a good choice of agents, but they cause prolonged neuromuscular blockade. So if possible, reduce the doses of these non-depolarizing agents. Okay. Now coming to the sedatives, your opioids, barbiturates, and benzodiazepines all are safe in pregnancy, even though they easily cross the placenta and may also enter the breast milk. So risk versus benefit situation, you can give these drugs. Opioids, fentanyl is the drug of choice, and also dexmedetomidine can be used as a sedative in these patients. So that is about breathing. Now coming to circulation. So what is the main important thing in the circulation? You need to avoid tissue hypoperfusion because you need to maintain the uteroplacental perfusion. So these two words has to be written in case of circulation. So first secure the IV access, then send the blood samples for all the routine investigations. Additionally, you should do urine microscopy, coagulation profile, and look for any DIC in these patients. Okay. Now, in the circulation, first is your fluid resuscitation. So, a crystalloid challenge can help improve the fall in circulating blood volume. So be careful in giving the fluid boluses because these patients are much more prone for pulmonary edema. So try to give aliquots, small aliquots of a fluid challenge and see whether the patient is responding to it. So the choice of fluid would be either normal saline or ringer lactate. There is no role for colloids, and importantly, you should maintain a urine output of more than 25 to 30 ml per hour. Okay, so despite adequate replacement by IV fluids, if the BP is not improving, then try to start the inotrope infusion, and side by side, please announce for an MTP, or if the blood is already arranged, please start the blood transfusion in the ratio of 1:1:1. Okay, now as I told, vasopressors. So what vasopressors can be started in pregnant women also should be known. So, first one is your ephedrine. So, for any short-term episodes of hypotension, ephedrine is a good drug because it has a good safety record and has a minimal effect on placental perfusion. Only in case of compromised fetuses, it may lead to fetal tachycardia and acidosis. Suppose you require vasopressor for a longer time, then phenylephrine infusion would be a better option. Now coming to your dopamine and dobutamine, both of them cause decreased uterine blood flow, so better to avoid it. Your vasopressin is not advised because it causes uterine contractions, whereas your adrenaline and noradrenaline, they also cause severe uteroplacental vasoconstrictions and are best avoided especially in hypoxemic situations. But they can be used in an emergency situation for a short duration if possible. Okay, so you need to know about what vasopressors, because there is some change here. So what vasopressors to be used in a pregnant lady is very important. Now the next part in circulation is your blood products. Okay, so simultaneously, as I told, arrange for the blood and transfuse it. So cross-matched PRBCs would be a better option, but in cases of unavailability, you can use an uncross-matched Rh negative O blood group. Okay, so ideally, if it is a severe bleeding that is happening, you may require to transfuse 2 to 4 units of PRBCs in a single go. Okay, simultaneously, you need to monitor all your hemostatic parameters, and if available, TEG would be a compromising diagnostic modality. Okay, so this is about the PRBC. Now, when to give your platelets, when to give your FFPs and your cryoprecipitates. So FFPs are indicated if the INR or an APTT is more than 1.5 times the normal. Platelet transfusion is required if it is less than 50,000, and if you're planning for an urgent surgical intervention like laparotomy or hysterectomy, then the platelet should be around 80 to 1 lakh. So in such cases, you need to transfuse the platelets. Coming to cryoprecipitate, so if it is less than 200, in a normal patient, it would be less than 150, the transfusion trigger. But in case of pregnant lady, the transfusion trigger is slightly on the higher side. It is less than 200. Then what is the role of recombinant factor 7A in PPH? So indication is if conventional medical management fails, And also, when varying degrees of surgical management are unsuccessful, up to and including hysterectomy, patient is still bleeding, then you give recombinant factor 7A. The recommended dose is 90 microgram per kg, and a second dose can be given 20 to 60 minutes after the first dose if there is no response. But the disadvantage is it is very expensive, and its use is in less severe cases may be potentially harmful because it has a lot of side effects also. Okay, in all these cases, if the mother is a Rh negative mother, please give a anti-D immunoglobulin. Okay. Now coming to the next important drug, role of tranexamic acid. So what is tranexamic acid? It is a synthetic derivative of the amino acid lysine, which basically acts at this level. So it prevents conversion of plasminogen to plasmin. So when plasmin is not formed, there is no formation of your fibrin, and the plasmin is not formed, then the fibrin will not be degraded to your fibrin degradation products. So here is the level where the tranexamic acid acts. Okay, and in pregnant lady, especially in PPH, tranexamic acid has been demonstrated to have reduced need for blood product transfusions as well as mortality, and the trial is women trial. Okay, so what is the dose of tranexamic acid? So 1 gram, which is given over 10 minutes, and a second dose of 1 gram if bleeding continues within 24 hours. Okay, so it should be given as a slow IV because if you give as a bolus, it can actually cause further hypotension. Okay. So this is a trial which I have told, the women trial. So what did it tell? Tranexamic acid reduces death due to bleeding in women with PPH with no adverse effects. So when used as a treatment for PPH, it should be given as soon as possible after bleeding onset. Okay, so this is one of the important trial. Please go through it because they are going to ask, because very few trials in obstetrics. Okay, so please go about this trial. So this is how you actually manage. This is about the circulation part that they have been given. So if it is the blood loss is less than or equal to 500 ml, just monitor the patient, empty the bladder, and administer your first line uterotonics. What are they? I will tell you in the further slides. Suppose if the blood loss is more than or equal to 1000 ml, then you have to activate the PPH protocol. It is same as your MTP protocol. So certain hospitals have this PPH protocol. So when you activate, they keep ready all the blood products. And next, two important things you should do. One is you should maintain your temperature because hypothermia, your triad, basically lethal triad. So you have to maintain your pH, you have to maintain your temperature and your calcium levels. Okay. And as I told, tranexamic acid should be given within 3 hours after the start of bleeding. And you can run your viscoelastic tests here. And depending upon what is the deficit, you can correct it. Okay. Now, one more important thing is you have finished A, B, C. So since the patient is bleeding, the patient has high risks of infections. So please send all the biomarkers of sepsis and try to start a broad spectrum antibiotics, especially which covers E. coli and group B streptococcus, because these are the most common bacterial pathogen in obstetric cases. Okay, so try to start those antibiotics which can cover this, like piptas. Okay, so during pregnancy, you should screen all the women for the risk factors for PPH, optimize the hemoglobin level before delivery, and seek multidisciplinary consultations. This is during pregnancy. On admission to labor and delivery, same again you need to assess the patients for risk factors for PPH, categorize the patients as low, medium, and high risk for PPH, secure a proper IV access, send all the labs, arrange for blood, and also you should notify your anesthesia and other consultation services. Okay, so if the patient has developed PPH, then categorize them as estimated blood loss 1000 to 1500, more than 1500 to 3000, and more than 3000. Okay, so then how do you manage this patients? So if it is a minimal blood loss of 1000 to 1500 ml, You call for help, notify the anesthesia people, secure one more additional IV catheter, IV access if possible, and see for the cause, whether there is a retained placenta or if there is any lacerations that are there, please correct it, monitor the urine output, and you can give a bimanual uterine massage and manual uterine exploration and evacuate the retained tissues or clots. Okay, and administer the first line uterotonics, that is in case of mild hemorrhage. Coming to the moderate hemorrhage, apart from what we have done here, additionally try to secure a central and arterial line here, administer blood and blood products, and continue your pharmacotherapy which we were giving in previously. And if possible, you can place a uterine tamponade device like Buckley or Rush balloon tamponade and administer tranexamic acid. And if the blood loss is more than 3000, okay, apart from all these things, you can consider giving a recombinant factor 7A additionally. Consider uterine artery embolization if patient is stable. Suppose if patient is really unstable, then you perform laparotomy and do whatever possible. If nothing is working, then try to do hysterectomy. Okay, so this is how you screen, evaluate, and manage a patient of PPH. Okay, so I was talking about the medical management. So the first line therapy is your oxytocin. Okay, you should remember the dose. Okay, and if possible, the adverse effects. The second line therapy are your methyl ergovin or the carboprost. So if suppose with these it's not reducing, you can give any one of these drugs. And the adjunctive drugs include your tranexamic acid and recombinant factor 7A. Okay, and treatment of uncertain usefulness is your misoprostol. Okay, so initially misoprostol was used, but now the use has come down. So these are the drugs which can be given for a PPH patient. Now, as I told, surgical management, just if you remember the names, that is more than enough. So if the patient is in an early stage, hemodynamics are stable, you need to consider uterine artery embolization by calling the interventional radiologist. Till then, okay, wherever the patient has delivered, you can do a uterine massage, you can do a bimanual uterine compression, or if possible, an external aortic compression. Bleeding has not stopped, shift the patient to OR. So in the OR, see for the cause. If try to do a curettage, surgical repair of genital tract trauma, and you can do a uterine tamponade, either by balloon or by surgical. Still the bleeding is persistent, do a laparotomy, apply compression sutures, ligation of uterine arteries or internal iliac artery. Still the bleeding is persistent, then the final option would be your emergency hysterectomy. Okay, so this completes your PPH. Srihari, you can join.
Is the slide visible?
Yeah, visible, visible.
Okay, okay. So next topic for discussion is on peripartum cardiomyopathy. So coming to the introduction, it's a form of systolic heart failure with reduced LV ejection fraction affecting childbearing women during pregnancy or early postpartum period. So it's potentially life-threatening disease. So it is basically defined as development of heart failure in the last month of pregnancy or within 5 months following delivery. Absence of any other identifiable cause of heart failure. LV systolic dysfunction with an LVEF less than 45% with or without LV dilatation. So these are the three important criteria that need to be kept in mind. So risk factors: age more than 30 years, African descent, pregnancy with multiple gestations, prior or concurrent preeclampsia, eclampsia, or postpartum hypertension, maternal cocaine abuse, long term, more than 4 weeks of oral tocolytic therapy with beta-adrenergic agonists like terbutaline and parity. So the mean age for PPCM is 31 years and the mean parity is 3. So coming to the pathogenesis, the important thing to note is there is no single cause for PPCM identified so far. So one is angiogenic imbalance due to the lack of PGC1 alpha in preeclampsia patients, which normally plays an important role in cardioprotection. It causes an increased stress on the heart tissue. This, along with activating antioxidant enzyme, that is MSOD, that inhibits the apoptosis of vascular endothelial cells, plus triggering of provascular VEGF, that is vascular endothelial growth factor mediators, leads to increased angiogenesis signaling. So, along with this, there is increased prolactin, which causes endothelial damage, along which there is myocardial dysfunction. Pregnancy-related hemodynamic changes, especially during labor, causes an increased burden on the heart, which leads to an increased stress. So, in addition to angiogenic imbalance and increased prolactin, pregnancy-related hemodynamic changes further causes stress. And inflammatory cytokines, especially TNF-alpha, IL-1, IL-6, and CRP, are elevated in PPCM and also contribute to injury. And viral myocarditis onset, which is more seen during the postpartum period, which can be due to Coxsackie virus, echovirus, parvovirus B19, Epstein-Barr, or cytomegaloviruses. So these viruses also can lead to PPCM. So ultimately, any of these pathological features lead to cardiac cell injury occurring due to increased reactive oxygen species and inflammatory cytokines and chemokines. So that leads to vascular endothelial dysfunction with cardiomyocyte ischemia and metabolic insufficiency, ultimately leading to apoptosis. So that leads to myocardial damage, which leads to decreased contractile function and downregulation of beta receptors, which leads to a decreased stroke volume with increased LV pressures during diastole. And along with that, there is an impaired conduction system of the heart, which leads to cardiac arrhythmias, which can further cause a decrease in cardiac output. So all these ultimately lead to acute heart failure. So the clinical manifestations, as in any other cardiac patient, dyspnea is the most common. Along with that, other manifestations can be cough, orthopnea, PND, pedal edema, hemoptysis, elevated JVP, displaced apical impulse, and MR murmurs, that is pansystolic murmurs. Initial diagnosis may be delayed because symptoms like dyspnea, pedal edema, and fatigue are similar to those that occur in normal pregnancy, but usually they are more pronounced. So the diagnosis, usually ECG is done to detect other abnormalities such as pulmonary embolism, myocardial infarction. So the commonest abnormalities seen are sinus tachycardia, atrial fibrillation, and non-specific STT changes. Echocardiography usually reveals a global reduction in LV ejection fraction nearly always, because along with that, there is dilatation of all the chambers. Other possible findings that can be there are LA-LV thrombus, mitral regurgitation, tricuspid regurgitation, and by RV dysfunction, which can lead to a biventricular failure. Chest X-ray per se is not necessary for diagnosis of PPCM due to the increased risk of exposure of ionized radiation. If it has to be used, fetal sheathing is a must during the antepartum period. Cardiac biomarkers such as NT-proBNP measurement is suggested in the evaluation in the patients with suspected heart failure, especially when the diagnosis is uncertain. So other less frequently used tests are viral and bacterial cultures if clinically implicated. Cardiac magnetic resonance imaging, generally not needed for diagnosis, but can be used to assess LV volumes and functions, especially when echo is suboptimal. Cardiac catheterization of the right heart, which is now not very commonly used because of availability of 2D echo and physical examination, which is possible. And left heart catheterization is usually done only when CAD is strongly suspected. And endomyocardial biopsy in PPCM, usually there is no pathognomic features seen. So it is usually considered only as a differential workup. So coming to the differentials, pre-existing cardiomyopathy unmasked by pregnancy, pre-existing valvular disease, pre-existing undetected cyanotic congenital heart disease, diastolic heart failure due to hypertensive heart disease, Takotsubo cardiomyopathy, pulmonary embolism, and acute coronary syndromes, which is quite common in the Western populations. So important thing to note is PPCM is usually a diagnosis of exclusion. So once you rule out these factors is when you really need to look into PPCM. So management is the four pillars of management are heart failure treatment, investigational therapies, delivery, and postpartum management. So coming to heart failure management, supplemental oxygen and assisted ventilation as needed, optimization of preload using diuretics and or NTG, hemodynamic support with inotropes and vasopressors if needed, and important considerations in pregnancy are mineralocorticoid receptor antagonists, SGLT inhibitors, AC inhibitors, ARBs, and RNAs are all contraindicated. Arrhythmia management with regard considerations in pregnancy, amiodarone is usually associated with congenital goiter or hypothyroidism and QTC prolongation. Beta blockers in newborn can be associated with the risk of bradycardia, hypoglycemia, reduced placental weight, which is with the most significant one being atenolol. Adenosine, digoxin, quinidine, and procainamide usually not associated with teratogenicity, but associated with increased risk of adverse events. So caution is needed. And cardioversion per se is not contraindicated in pregnancy. So with regard to antithrombotic therapy, patients with PPCM are at high risk of thrombus formation and thromboembolism due to hypercoagulable state of pregnancy with stasis of blood due to LV dysfunction. So the preferred anticoagulant is heparin and low molecular weight is preferred over unfractionated. Aspirin, warfarin, and direct acting oral anticoagulants are not recommended in PPCM. So these are the important heart failure considerations in pregnancy. An implantable device therapy should be deferred till 6 months following presentation when the patient is receiving optimal medical treatment to determine whether the criteria for placement are present. So mechanical circulatory assist device should be considered in patients who are hemodynamically unstable plus unresponsive to medical therapy with maximum inotropic support. The modalities available are IABP, VECMO, or LVADs. So it is implanted in acute phase as a bridge to recovery with subsequent weaning as LV function improves, or a bridge to bridge with implantation of a more durable device if continued circulating support is needed, and a bridge to transplantation, rarely required as most PPCM patients will have some recovery of LV function. So coming to cardiac transplantation, the transplant rates vary from 5 to 25%. However, unlike non-pregnant patients, PPCM patients post-transplant have been associated with increased mortality, increased incidence of rejection with poor graft survival and higher retransplant rates. So investigation therapies, bromocriptine, which is a prolactin inhibitor, given at a dose of 2.5 milligrams 12 hourly for 2 weeks, following that 2.5 milligrams OD for 6 weeks. In severe cases, it can be increased up to 10 milligrams BD for 2 weeks. So it should be stopped once VECMO is initiated because it shows no proven benefit thereafter. The alternative that can be used is carbagorin. And IVAG can be tried, though there are no available trials till date. That is totally 2 grams per kg over 5 days or 400 milligrams per kg once daily for 5 days. With regard to delivery, the decision regarding the time and mode of delivery should be a multidisciplinary approach which involves the cardiologist, obstetrician, anesthesiologist, and neonatologist. Ideally, stabilizing the mother prior to delivery is preferred in a hemodynamically stable status. However, in advanced heart failure with HT instability, despite medical treatment, emergency CLCS is needed. With regard to postpartum management, contraception should be explained since the risk of recurrence is very, very high. And the progression to the next pregnancy with low LVEF is associated with high morbidity and mortality. Use of OCP should be avoided in this subset of patients because the risk of thromboembolism is very high in the background of low EF. Breastfeeding, if clinically stable, should not be discouraged. So the mortality rate within 30 days varies from 1.4 to 3.4. The mortality rate at 6 months is around 11% in Asia Pacific countries. And complete recovery of LV function at 6 months is almost seen in 50% of the patients. That is in a range of 44 to 56% patients. Thank you. So with this, pregnancy is over. So there are a few topics in hematology that we shall cover. So hope the screen is visible. So we'll cover about
Yes,
TTP.
Srihari, visible.
Okay, ma'am. So we'll cover about TTP and HUS. So coming to the overview, thrombotic microangiopathies are a group of disorders that are characterized by microangiopathic hemolytic anemia, that is MAHA, thrombocytopenia, and microthrombi leading to ischemic tissue injury. So microangiopathic hemolytic anemia is a descriptive term for non-immune hemolysis, that is Coombs negative hemolysis, resulting from intravascular red cell fragmentation that produces schistocytes on the peripheral blood smear. So characteristic lab data include negative antiglobulin, that is Coombs test, with an increased LDH, increased indirect bilirubin, and a low haptoglobin levels, usually undetected levels. So TMI describe a specific pathologic lesion in which the abnormalities in the vessel wall of the arterioles and capillaries lead to microvascular thrombosis. So that is the concept behind TMS. So that even though they are rare, TMAs are life-threatening conditions that require urgent management. So the spectrum of TMAs are TTP, Shiga toxin-induced HUS, that is STHUS, secondary causes of TMAs, which can be malignancy, hypertensive emergencies, drug-induced, pregnancy-related complications, which can lead to TMAs like HELP syndrome, preeclampsia in a severe state, AFLP. So these all can produce a TMA-like picture, and complement-mediated thrombotic microangiopathies. Under drug-induced, quinine, tacrolimus, cyclosporin are the commonly implicated factors contributing to TMS. So our main discussion will be in these three, TTP and HUS, which will include ST toxin-induced HUS or the typical HUS and complement-mediated TMAs, which were previously called as atypical HUS. So coming to TTP, so TTP is a thrombotic microangiopathy caused by severely reduced activity of von Willebrand factor cleaving protease, that is ADAMTS13. So it is characterized by small vessel platelet-rich thrombi that cause thrombocytopenia, MAHA, and associated organ damage. So it is an important diagnosis to make because untreated mortality is 90%, which can be reduced very significantly with prompt delivery of plasma exchange. It is a rare and potential fatal blood disorder with an incidence of 2 to 6 per million involving young adults, predominantly females more than males. So it can be hereditary or acquired. So hereditary can be due to pathogenic variants in ADAMTS13 gene, whereas acquired can be immune mediated due to autoantibodies against ADAMTS13. So drug-induced causes can be immunosuppressive agents, antiplatelets, HIV itself, estrogen-containing contraceptives, and pregnancy. And vasculitis can be because of autoimmune diseases. So coming to the pathogenesis, TTP is caused by severely deficient activity of von Willebrand cleaving protease, that is ADAMTS13, clinically defined as activity level less than 10%. So what is ADAMTS13? It is a disintegrant and metalloproteinase with thrombosporin type 1 motif number 13. So each letter has a meaning. So disintegrant refers to the domain of the protein that interferes with the interaction between platelets and endothelial cells. All right. Metalloproteinase refers to the metal-dependent enzymatic domain of the protein, which cleaves the von Willebrand fractal into smaller fragments. So its catalytic activity is facilitated by the metal zinc. That's why metalloproteinase. Thrombosporin refers to the domain of the protein similar to the thrombosporins, which have anti-angiogenic properties, thereby preventing new angiogenesis within the microvasculature. So it helps to maintain the patency of the lumen because in the event of thrombosis or angiogenesis that occurs, the luminal size reduces, which actually leads to an increased risk of hemolysis and platelet destruction. So Adam TS13 is the 13th member of the Adam TS family to be described. So Adam TS13 is a plasma protease that was initially defined by its function as a von Willebrand factor cleaving protease. So it cleaves the ultra-large string-like molecules of von Willebrand factor that are synthesized by endothelial cells and secreted into the plasma but remain attached to the endothelial surface. So this normal cleavage to smaller size multimers prevent ultra-large multimers from accumulating, especially in areas of high shear stress, that is small arterioles and capillaries. So shear stress leads to a conformational change in the large von Willebrand multimers that expose the ADAMTH cleavage site. So when the protease activity is reduced, the large von Willebrand factor multimers accumulate on the endothelial surface where the platelets attach and accumulate. Because when the endothelium is exposed, then there is usually platelet activation and aggregation which occurs. So thereby there will be accumulation. So platelet aggregation and formation of platelet thrombi occurs. Uncontrolled platelet activation and consumption leads to thrombocytopenia, reduced clotting activity, and purpura. Whereas on the other side, formation of fibrin strands leads to microangiopathic hemolytic anemia, cellular RBC damage due to the fibrin deposits, that is intravascular non-immune hemolysis, widespread microthrombi occluding the blood vessels causing tissue damage and necrosis. So from a CNS perspective, it can cause confusion, headache, and focal deficits. Heart, it can cause cardiac arrhythmias and sudden cardiac death. And renal, it can cause glomerular damage with a decrease in GFR and proteinuria. So the clinical features, microangiopathic hemolytic anemia can present with jaundice. Thrombocytopenia can present with bleeding at various sites. Fever, usually more than 37.5 degrees Celsius, usually they are low grade. Renal, AK with proteinuria and hematuria. Neurological can manifest as headache, confusion, paralysis, aphasia, dysarthria, visual disturbances, seizure, or coma. Cardiac, they can manifest with chest discomfort, palpitations, or hypotension. And non-specific features can be there like fatigue, arthralgia, myalgia, and abdominal discomfort. So the first five, MAHA, thrombocytopenia, fever, renal dysfunction, and neurological dysfunction contribute to the pentad. So the basic lab investigations that need to be done are complete blood count with the peripheral smear, lactic count, which is usually raised, haptoglobin level, which is markedly reduced, LDH is elevated, direct antiglobulin test, which is negative, clotting screen is normal, RFT is impaired, then cardiac biomarkers, ECG and echo to assess for cardiac involvement, calcium, which may reduce with plex, urine analysis for proteins and hematuria assessment, CT or MRI brain to assess for neurological involvement if clinical features are suggestive, to look for other possible etiologies, serology to exclude any underlying viral etiology, and coagulation parameters which are usually normal in TTP. So coming to the etiological evaluation, TTP, HUS, and secondary TMS usually present in a similar fashion. So it is ideal to work up in detail for the pathology. So thyroid function test to exclude Graves' disease, autoantibody screening to exclude autoimmune diseases, stool culture for pathogenic E. coli if diarrhea is being present, CT chest, abdomen, and pelvis with or without tumor markers to look for underlying malignancy. So coming to the diagnosis, Adam TS13 is the most important testing that needs to be done. So it includes Adam TS13 activity and anti-Adam TS13 IgG levels, that is inhibitor levels. So it is important to note that you should not wait for the results before starting treatment in suspected cases. So the approach to interpretation based on Adam TS13 assay is MAHA with thrombocytopenia of unknown etiology. If it is associated with the diarrhea and sugar toxin producing E. coli is present, then it is STHUS. Whereas if the Adam TS activity is less than 10%, then you have to check if it is inhibitor, that is antibodies is present or not. If it is not present and activity is less than 10%, then it is congenital TTP. Whereas if the activity is less than 10% and inhibitor is positive, then it is acquired TTP, that is antibody mediated. Whereas if the ADAMTS13 activity is more than 10%, then you see if there are complement factor abnormalities present. If it is so, then it is complement mediated TMS. If not, then you have to assess for any presence of underlying condition like malignant hypertension or malignancy or any kind of viral infections. In those kind of scenario, there is a possibility of secondary TMS. So in most cases, ADAM-TS13 assay testing may not be available. So if the clinical suspicion is very high, either plasmic score or French score can be used to predict the likelihood of severe ADAM-TS deficiency in a suspected PTP. So plasmic score goes by platelet count of less than 30,000, creatinine level less than 2, hemolysis which can be manifested with indirect bilirubin more than 2, retic count more than 2.5 or low or undetected haptoglobin. Then next criteria is no active cancer in the previous year, no history of solid organ and hematopoietic transplantation, INR less than 1.5 and MCV less than 90. So each carries around 1 point. So if it is 0 to 4, then the likelihood is 0 to 4%. Whereas if it is 6 to 7 points, then the likelihood is 62 to 82% likelihood for TTP. So it has a good specific sensitivity, but the specificity is very, very poor. So a condensed version of the plasmic score is the French score. So it includes the platelet count, creatinine levels, and no active cancer or transplant, either solid organ or hematopoietic. So we have each carries 1 point. So if 1 point alone is there, it is 2% likelihood, 2.70% and 3.94% likelihood of PTP. So coming to the differentials, autoimmune hemolysis or Evan syndrome is one thing you can consider. BAC, pregnancy-associated TMS like HELP syndrome or preeclampsia, drugs like quinine, simvastatin or calcineurin inhibitors, infections, HUS, malignancy, autoimmune states like SLE, catastrophic Apla syndrome. Coming to the treatment, you can classify it into 4 parts. First event, relapse, exacerbation, and refractory disease. So the first event, treatment is plasma exchange plus steroids plus rituximab plus or minus caplacizumab. For this relapse, it is defined as clinical or lab deterioration following remission. So return of disease after 30 days after stopping plasma exchange. So here it is similar to the first event, but here you have to give caplacizumab also. So exacerbations is recurrence of thrombocytopenia without any other cause following a response, but within 30 days. So that is the difference between relapse and exacerbation. After stopping TPE or anti-von Willebrand factor therapy, that is caplacizumab. For refractory disease, lack of clinical response to initial treatment with the lack of alternate diagnosis to explain findings. So therapeutic plasma exchange is the mainstay of therapy. So all patients with the presumed diagnosis of TTP or confirmed diagnosis based on RMTS assay are treated with plasmapheresis till the platelet count recovers or alternate diagnosis is established. Should be started with 1.5 plasma volume using solvent detergent plasma, which is usually the ideal one. If it is not available, then fresh frozen plasma itself can be given and can be reduced to 1 plasma volume when the clinical condition stabilizes. So the daily TP should be continued for a minimum of 2 days after the platelet count has been increased to 1,50,000 and then stop. So if you're preparing for plasma exchange, then you need to know what's the formula for circulating plasma volume. It is the body weight into 70 into 1 minus hematocrit by 100. So steroids are used in addition to plasma exchange in suspected or confirmed cases of TTP. So it acts by reducing the production of ADAMTS inhibitor, that's autoantibody, plus decrease cytokine production and decrease autoantibody mediated clearance of ADAMTS13. So IV prednisolone is given as pulse for 3 days and gradually tapered over 3 to 5 days, then switched over to oral prednisolone therapy. So it is tapered once the ADAMTS activity is more than 20% over 3 weeks. Then coming to rituximab, it is added to the initial regimen only after RMPS deficiency is confirmed. So it is a monoclonal antibody that binds to the cell surface protein, which is expressed on the B cells. So it binds to CD20 and eliminates B cells through three mechanisms. One is antibody-mediated cellular toxicity. Here, Ritux binds to the CD20, forming an antigen-antibody complex. So that is identified by the natural killer cells and it destroys it. The second is direct apoptosis by binding to the CD20 cell surface and complement-mediated cytotoxicity. So the dose is 375 milligram per meter square IV once a week for 4 weeks after therapeutic plasma exchange. It is important to be given only after plasma exchange, as plasma exchange usually clears rituximab from the system. Then coming to the next treatment modality is caplacizumab. It is a von Willebrand factor directed monoclonal antibody which targets the A1 domain. So why that is significant is it blocks the von Willebrand interaction with the platelet glycoprotein, decreasing the formation of microthrombi. So the first day dose is 11 milligrams IV, at least 15 minutes prior to plasmapheresis. Following that, it is given 15 milligrams subcutaneously post TP. Thereafter, it is given 11 milligrams subcutaneously for a period of 30 days from the last plasma exchange. So it is only indicated in TP with severe manifestations, either neurological or cardiac involvement, or TTP that does not improve with 2 to 3 sessions of plasma exchange and steroids. So that is where caplacizumab has a role. So the mechanism of action of rituximab, like I mentioned, antibody-dependent cellular toxicity, direct cytotoxic activity, and complement-dependent cytotoxicity. So the mainstay of management of therapeutic interventions, plasma exchange, it helps to replenish the ADAM-TS stores. So ADAM-TS autoantibodies can be removed by use of steroids or rituximab. Then von Willebrand factor MAB is caplacizumab. It acts by inhibition of the von Willebrand platelet interactions. So with regard to treatment of exacerbation, plasma exchange with intensification of dose and frequency, with increased dose of steroids plus rituximab, and you will have to add cyclosporin or cyclophosphamide. And as a last resort, splenectomy can be done. It helps to reduce the autoantibodies and the relapse-free survival is around 70%. So with regard to treatment, supportive management, platelet transfusion is indicated only if there is clinically important bleeding or those who require invasive procedures. And thromboprophylaxis, here thrombocytopenia is not protective against thrombosis. So pharmacological thromboprophylaxis can be initiated if platelet is more than 50,000 and mechanical if platelet is less than 50,000. RBC transfusions usually go with the restrictive strategy. And management of complications related to plasma exchange can be fluid shifts, electrolyte imbalances, catheter-related complications and infections. And consultations, if manifestations are present, usually a neurologist consultation and a cardiologist consultation is needed. So this is just an overview of the modalities of treatment and the mechanism of actions. So coming to hemolytic uremic syndrome, is the last part of my talk. So originally TMA syndromes associated with AK are mostly recognized in children. So the most common etiology in children are enteric infection caused by Shiga toxin producing bacteria like Shigella dysentery and some strains of E. coli. The clinical presentation characteristically begins with several days of severe abdominal pain and diarrhea, which becomes overtly bloody. As diarrhea decreases, up to 15% develop AK. So this was known as HUS, also causes Shiga toxin mediated HUS. However, after the initial description of HUS, some patients were described as having HUS without diarrhea. So with persistent or recurrent disease or a family history of HUS. So they were described as atypical HUS. So the definition is STHUS is reserved for disease caused by Shiga toxin. So the use of sugar toxin HUS implies that recovery will occur spontaneously. Complement-mediated HUS is a term used for TMA with inherited pathogenic variants in complement genes or acquired antibodies against certain complement proteins. So it is also called as complement-mediated HUS or previously called as atypical HUS. So the main etiology is Shiga toxin vira, also called as virotoxin or virocytotoxin produced by Shigella or E. coli. So they bind to the glycolipid layer, that is a globotriacyl ceramide, which is expressed in the kidney cells and produce injury. With regard to complement mediated TMA, it can be because of pathogenic gene variants in complement factor, that is BHI, or membrane cofactor protein, or complement factor 3. This needs to be by-hearted for the exam because if HUS is asked, then you will have to know about this. So either it can be because of pathogenic variants or because of autoantibodies against complement factor H. So just to know about the complement factor, you have a classical pathway, the mannose binding lectin pathway, and the alternate pathway. So here C1, C4, C2, here MBL, C4 and C2, and here C3, B and D are the complements. So the ultimately these all come into active once they are activated, they aid in the conversion of C3 to C3A and C3B. So C3B helps in the conversion of C5 to C5A and C5B. Now C5A and C5B are important because the C5B is the one which causes the membrane attack complex activation. So that subsequently stimulates C5B 6, 7, 8, and 9, which leads to the action of complements on various sites. So coming to the pathophysiology, Shiga toxin mediated HUS causes release of Shiga toxin, which bind to the glycolipid layer in the kidney cells, leads to endothelial injury and activation, inhibits ADAM-TS13 activity, leading to increased von Willebrand factor multimers. On the other side, the complement activation of the complement system, that is the classical pathway, alternate pathway, and the mannose binding lectin pathway, lead to the formation of the membrane attack complex by activating complement factor 5A. So that causes an activation of factors from 5B to C9. Sorry, 5B to C9. And there's also inhibition or downregulation of CD59 on endothelial cells, which normally suppress membrane attack complex via inhibition of the C9. So this C9, C59 suppression leads to unregulated complement activation. Coming to complement mediated HUS, in order to achieve immune surveillance, the alternate pathway of the complement system is constitutively active and inducible. So that is a feature that allows rapid amplification of necessary functions in an event of a foreign body entering the body and causing problems. This reactivity necessitates precise regulation in order to limit inadvertent tissue injury. So the complement regulatory proteins include complement factor H, complement factor I, complement factor B, and MCP. That is the membrane cofactor protein, also called CD46. So preventing these regulatory proteins prevent excessive and inappropriate activation of complements in host cells. So complement-mediated TMA occurs because of inherent pathogenic variants in this complement genes or because of autoantibodies targeted against complement factor, especially complement factor H, leading to widespread membrane attack complex formation. So this membrane attack complex formation ultimately leads to platelet aggregation and formation of thrombus, which leads to uncontrolled platelet activation consumption, leading to thrombocytopenia, reduced clotting ability, and porphyria. On the other side, it can cause widespread microthrombi occluding blood vessels, causing tissue damage and necrosis. And on the other side, it causes formation of fibrin stans, which causes cellular damage from the fibrin deposits, leading to MAHA. So clinical evaluation, the predominant manifestations in these scenarios are MAHA with thrombocytopenia. If S2HOS is there, usually AK is associated. With regard to complement-mediated TMAs, usually there is a family history of TMA, unexplained renal failure, or death during pregnancy. So other manifestations that need to be looked into are cardiac, neurological, and endocrine. So cardiac myocarditis can be that, neuro altered mental status, trauma, stroke can be that because of microvascular thrombosis, and endocrine that can be impaired glucose tolerance. So diagnosis, basic workup is the same as for PTP. So additional testing, you'll have to go with ADAM-TS13. Activity more than 10% goes in favor of a CM or a typical HUS. Testing for sugar toxin producing organisms. So usually you need to do stool cultures for isolating E. coli or Shigella species, or Shigella toxin assay, or PCR testing. So CDC recommends stool culture and sugar toxin assay. So complement testing is important in the setting of MAHA and thrombocytopenia with no other alternate explanation for a diagnosis. It is important because it confirms a diagnosis and facilitates testing of family members. So you need to test for anti-complement factor H antibodies, and gene variants that need to be checked for are complement factor H, D, I, MCF, and C3. And kidney biopsy may be performed in the evaluation of unexplained AK, may confirm the presence of TMA, but it does not help to identify the specific type of TMA. It is usually used to assess the severity of ischemic injury and facilitate decision making. That is use of anti-complement therapy. So treatment, supportive measures is usually the mainstay of treatment in STHOS, and it is part of the treatment in complement-mediated HOS. So hydration, antibiotics mainly for infections suspected at other sites than kidney, avoidance of NSAIDs, blood transfusions, you go with a restricted strategy, platelet transfusions if it is less than 50,000 with clinical evident bleed, and dialysis if there is refractory hyperkalemia, oliguric or anuric volume overload, uremic complications, and severe metabolic acidosis. With regard to therapeutic plasma exchange in STHUS, there is no role. Whereas for complement-mediated TMA, it helps in resolution of extrarenal manifestations, that is MAHA and thrombocytopenia. Renal resolution is very less likely to be that. Renal recovery is less likely to be that just with plex. So the main management specific to complement-mediated TMA is eculizumab. So it's a map directed against C5 complement component, which inhibits the membrane attack complex. The dose is an induction of 900 milligrams once weekly for 4 doses. Then the maintenance is 1200 milligrams at week 5, and thereafter 1200 milligrams every 2 weeks. Then, similar to eculizumab, we have something called ravulizumab. So that is also directed against C5 complement component, and the induction dose is 2700. That is almost 3 times the eculizumab dose. And the maintenance is 3300 given every 8 weeks, starting 2 weeks after the induction dose. So this is about ravulizumab. So patients treated with eculizumab and ravulizumab must be vaccinated against encapsulated organisms. This is very important and needs to be kept in mind. If MABs are used during plasma exchange, doses should be repeated after plasma exchange because there is going to be a very increased chances of elimination. Thank you.
Thanks, Srihari.
That's fine.
So sorry guys, I think we are a little late. So two more topic, very important topic. One is HLH and the other is tumor lysis syndrome. So mostly I might take half an hour to 40 minutes. So first topic would be your HLH. So your hemophagocytosis, lymphohistiocytosis. Very important questions, both theoretically as well as practically. So this is one of the rare fatal disorder where you'll be able to see a hypercytokinemia. Okay, so what is this hypercytokinemia? This is nothing but a cytokine storm where there is a dysregulated activation of cytotoxic T lymphocytes, the natural killer cells, and the macrophages. So here there will be a immune mediated injury of multiple organ systems. So this HLH is divided into a primary HLH where the cause would be a genetic cause, and a secondary HLH, which is usually triggered by an underlying disease process. Examples of secondary HLH includes if there is an underlying cancer or if there is a therapy like your bone marrow transplantation, hematopoietic or a solid organ transplantation, CAR T cell therapy, or if there is presence of any infections as we all see in our ICUs, infection related HLH, and rheumatological diseases. Any underlying rheumatological disease can also lead to HLH, which is known as your macrophage activating syndrome, or in some cases, the trigger could be unknown. Okay, so this is a classification of HLH. Now, as I told, primary HLH, also known as familial HLH, and it is usually associated with some immunodeficiency disorders. So, there could be gene mutations in a homozygous or a compound heterozygous pattern, and these mutations are usually known as disruptive mutations. Because of these disruptive mutations, there is a fully elimination of the function of the cytotoxic C cells and also your NK cells. So the common mutations which are seen in your primary HLH are your PRF1 mutations, the UNC13D mutations, and your STX11 mutations. So usually the diagnosis occurs in the first year of life in 70 to 80% cases. More than 1 year, also the diagnosis can happen. Now coming to the secondary. As I told, secondary, it is also known as acquired. So the external triggers include infection, malignancy, rheumatological diseases, post-allogenic stem cell transplantation, or any drug hypersensitivity. As in autoimmune cases, it is known as macrophage activation syndrome. And what is MALS? It is macrophage activating syndrome like LSS syndrome. Okay, so MALS like syndrome, that is known as MALS. Okay, so here usually there is hyperferritinemia syndrome, viral associated hemophagocytic syndrome, and sepsis HLH overlap syndrome. Okay, now coming to the secondary causes. Okay, so I told infections. So all the viruses can cause, bacteria can cause, parasites and fungi. All these results in infection related HLH. In autoimmune disorders, your systemic onset juvenile idiopathic arthritis, your adult onset Still's disease, SLE, and all the types of vasculitis can lead to HLH. Transplant associated HLH is because of your graft versus host disease or immunological reaction at engraftment, and drugs include carbamazepine, phenobarbital, sulfamethoxazole, cancer immunotherapy drugs. All these are implicated in the development of HLH. Now, what is the pathophysiology? So, what happens if there is an underlying risk factor? So, an underlying defect in the NK cells and your cytotoxic T lymphocytes on the background of any pre existing susceptibility, like your sepsis or your cancer or anything, it leads to failure to clear any antigen from the infected tumor or autoimmune cells and the antigen presenting dendritic cells. This leads to uncontrolled immune stimulation with activation and proliferation of your macrophages as well as your cytotoxic T lymphocytes in a self-perpetuating fashion. That is very, very important. So because of this, there is a cytochrome storm resulting in hyperinflammation, end organ damage, and hemophagocytosis. And if your negative inhibition loop fails, ideally here your body should act, but because of so much of cytokine storm, your body will not be able to have that negative feedback loop. Hence, It is a vicious cycle which continuously happens. Now coming to the clinical features. So in the clinical features, the most cardinal sign is your fever. So almost always, most of the patients have high grade fever. Compared to organomegaly, there could be some lymphadenopathy or underlying splenomegaly or hepatomegaly. Now coming to organ dysfunction. So this is very, very important, especially in sepsis related HLH. So you could have pulmonary manifestations like severe ARDS. You can have cardiovascular dysfunctions in the form of mild to profound shock, renal impairment in the form of your AKI, neurological dysfunction in the form of mild cognitive impairment to delirium, seizures, and even coma, and skin manifestations like erythroderma, petechiae, and generalized purpura. So these are the organ manifestations of HLH. Your pulmonary manifestations and neurological manifestations actually are associated with poorer prognosis. Now coming to the laboratory. So laboratory, you have a group of laboratory tests that you need to send apart from your routine laboratory. So routine laboratory we are not going to discuss here. So all the infectious workup. So when send your tropical, the other blood cultures, everything, you need to have a HIV and hepatitis screen. If your basic infection panel has come negative, then screen for EBV, CMV, and parvovirus B19 serology. Have to send a parasitology for toxoplasma and leishmaniasis or malaria. Tuberculosis workup should also be sent. Additionally, you need to send workup for your malignancy, autoimmune workup, and in certain cases, you might even do a MRI brain or a PET scan. Okay. Now coming to the important one, the diagnostic score. Okay, so what is the diagnostic score that is used for the diagnosis of HLH? So initially it was known as HLH 2000 score. Okay, so this was usually derived from HLH 94 score, and this was given by the Histiocyte Society. But recently this has been changed as a H score. So this H score, it is a web-based online calculator. Okay, it has 9 criteria and each criterion is assigned a value which is based on logistic regression, and a total score ranges from 0 to 337. Okay, higher the score, higher the probability of the patient having a HLH. And the optimal cutoff is around 169, which corresponds to a sensitivity of around 93% and a specificity of 86% of having HLH. Okay, it is better than your HLH 2004, and the sensitivity is even better in pediatric population. Okay, so diagnostic score, just mention both, but nowadays we are going to use the H score. Okay, so I think still we practice this HLH 2000 criteria, where the parameters include fever, splenomegaly, any two cytopenias, anemia, hypertriglyceridemia or hypofibringemia, fasting triglyceride levels, hemophagocytosis demonstration in bone marrow, spleen or lymph node, low or absent NK cell activity, serum ferritin levels more than 500, and your soluble CD25 levels. So diagnosis of HLH is confirmed if more than or equal to 5 out of 8 criteria positive. Okay, so all carries 1 mark. Now coming to the H score. Okay, so here you will have that online calculator, you need to put it. Okay, so see, if the temperature is less than 38.4, grading is 0. If it is between 38 to 39, it is 33 points. So it is an online calculator. So what does it see? It see about the fever, same. Organomegaly. So here it was only splenomegaly, but here they are seeing even both splenomegaly as well as hepatomegaly. Okay, the number of cytopenias involved. Here they told any more than or equal to 2. Here they have delineated. Okay, then the triglyceride levels, fibrinogen, hemophagocytosis on bone marrow, ferritin levels. Okay, so here just they have told more than 500 is the diagnosis, but if you see here, usually it is too high levels of ferritin that is required for HLH diagnosis. And additionally, your serum aspartate aminotransferase levels are included in this, and presence or absence of immunosuppression is very important. Okay, so this is your H score. Okay, so if someone asks how do you calculate, it should be the H score. But you have to remember the components of even your 2004 criterias. So now coming to the treatment. So what are your goals of treatment? First, important, you need to diagnose early. So early diagnosis, supportive care and multiple organ support, rapid initiation of the specific HLH therapy to control the cytokine storm, identification and treatment of any underlying trigger, and early involvement of a HLH expert or a HLH multidisciplinary team. So these are the goals of management. Now, what is the treatment protocol? So here also we have two treatment protocols, a older one and a newer one. Okay, so the older one is known as HLH 1994 protocol. Okay, so it was the first international treatment protocol for HLH. So this was also given by your Histiocyte Society in 1994. By using this protocol, the survival rate was around 55% with a median follow-up up to 3.1 years. So here it had an induction therapy and a continuation therapy. So the induction therapy was for 8 weeks. And in these 8 weeks, you were giving dexamethasone, etoposide, and intrathecal methotrexate. So 3 drugs in the induction therapy for 8 weeks. Okay, so the principal goal of induction therapy is to suppress the life-threatening inflammatory process that is nothing but your cytokine storm. So at the end of 8 weeks, patients are either weaned off the therapy or they are transitioned to the continuation therapy, which is intended only as a bridge to your stem cell transplantation. So your continuation therapy is initiated only as a bridge to transplantation. Otherwise, if after at the end of 8 weeks, if patient is better, you are going to stop the treatment. This was your HLH 1994 protocol, 3 drugs, 8 weeks induction phase. Okay, so this is given in a diagrammatic form. So dexamethasone, so for 8 weeks, this is 0 to 8 weeks. Okay, so every 2 weeks, you're going to decrease the doses, tapering doses. So 10, 5, 2.5 and 1.25 mg per meter square. Now coming to the etoposide. So etoposide also first 2 weeks, you're going to give it alternately. And then from second to the next 8 weeks, it will be every weekly 1 dose. So the dose of etoposide is 150 mg per meter square per dose. Okay, and if the patient has a CNS symptoms only, then you're going to give your intrathecal methotrexate and a hydrocortisone combination. Okay, so this is usually given at second, third, fourth and fifth week, single dose intrathecal, only if the patient has a CNS symptoms. Okay, so this was the older one. Now, what is the difference between the HLH 2004 and your HLH 94 treatment protocol? So here additionally there was one more drug. What is that? Your cyclosporin A. So initiation of cyclosporin A at the beginning of the initial phase of treatment to oppose the action of your interferon C and achieve increased immunosuppression. Okay, and it proposes, this is very, very important, performing hematopoietic stem cell transplantation on patients as soon as a donor is available. But in the older protocol, you have to complete your induction therapy and then assess the patient for your stem cell transplantation. But here, even in the induction therapy, if you are getting a donor, do a HSCT. Okay, administrating intrathecal prednisone in addition to intrathecal methotrexate for HLH causing progressive neurological symptoms. Okay, And if you see, by using this new protocol, there was a decrease in the mortality from 27% to nearly 19% with the new protocol. Okay, so the mortality is actually reduced. But they saw that there was no mortality benefit at 5 years overall. Okay. So this is the treatment protocol, HLH 2004 protocol. Okay. So initial therapy and continuation therapy. So initial therapy, dexamethasone same, decreasing doses. And in the continuation therapy, they have used dexamethasone in pulse dose. Okay. So your VP16 is nothing but your etoposide. The dose is the same. Your CSA is your cyclosporin A. Okay, so cyclosporin A, usually they tell that you have to start at week 9. They are telling in the continuation phase or possibly earlier, but not earlier than week 3. Okay, so better to start at third week. If you see here, they've started nearly at third week of the therapy. Okay, and IT therapy if the patient has, intrathecal therapy if the patient has CNS symptoms. Okay, so this is the new protocol. Now, coming to the salvage therapy or relapsed and refractory HLH. So, you have given all this, but patient has relapsed or the therapy has been failed. The final therapy would be a stem cell transplantation. But before that, if any other drugs are available, yes, there are some drugs. So, chemotherapeutic agents such as your cyclophosphamide, doxorubicin, vincristine, and prednisolone, your CHOP regime, along with your etoposide can be used. Or there are newer drugs, your anti-CD52 antibodies, the alemtuzumab, that is one option that is available. You can even do some cytokine adsorption techniques using some filters or plasma exchange. There is some off-label treatment with JAK2 inhibitor, your ruxolitinib, anti-interferon C antibodies, and finally, wherever possible, give a best option is your allogenic hematopoietic stem cell transplantation. Okay. Now coming to the poor prognostic factors. So worst prognosis is with malignancy associated HLH. So the mortality is around 80%. For ICU HLH, the mortality is around 52 to 68%. And those patients who are not able to achieve a stable or even a partial response at the treatment at the end of 8 weeks, these are the patients who are at poor prognosis. And the other factors would be HLH due to EBV, age greater than 45 years, hyperferritinemia, and associated thrombocytopenia might also lead to poor prognosis in these patients. Okay, so this completes your HLH. Now coming to the last topic, the tumor lysis syndrome. I think most of you all know about tumor lysis. So we'll just go like an express now. So what is TLS? It is an oncological emergency which results from metabolic derangements arising from breakdown of malignant cells either spontaneously or after initiation of treatment for malignancy. So basically, you need to write three important things. One, it is an oncological emergency. Second, what happens here? There is metabolic derangements which arise from the breakdown of the malignant cells. And this can happen either spontaneously or after initiation of the treatment for malignancy. So three important points in the definition. Okay, it is usually associated with high morbidity and mortality, especially if the diagnosis is delayed and treatment measures are not instituted promptly. Okay, so our important step, rather than treating the TLS, we need to identify those patients who are at risk for TLS. So as I told, it can occur either spontaneously or after anti-neoplastic therapy, such as your chemotherapy, post-steroids also, post-molecular targeted therapy, immunotherapy, and even it can be seen after radiotherapy and chemoembolization also. Any anti-neoplastic therapy can lead to TLS. Okay. Now, coming to the definition and classification, definition we have discussed. Now, classification is very, very important. So, we all know Hande and Garrow has classified TLS into two categories, that is laboratory and the clinical TLS. This was earlier, okay, before your Cairo and Bishop criteria has come. So, the first one is being given by your Hande and Garrow. But Cairo and Bishop has modified it in 2004. So what modification was done is, basically Cairo and Bishop even included spontaneous TLS, whereas Hande and Garrow didn't include this spontaneous TLS. Okay. So the laboratory TLS and the clinical TLS. So laboratory TLS is nothing but modification of at least two parameters within 24 hours. Okay. So what are the parameters? Uric acid more than 8, potassium more than or equal to 6, phosphates more than or equal to 4.5, or a 25% increase from the baseline. The fourth component is your calcium less than or equal to 7 or a 25% decrease. Okay, so this is the laboratory TLS. Now coming to the clinical TLS, laboratory TLS plus there should be one organ dysfunction or death. So only laboratory TLS is not sufficient. There should be one organ involvement like renal dysfunction, cardiac involvement, neurological involvement, or even death. All this occurring within 3 to 7 days after chemotherapy initiation or even spontaneously. Okay, so please remember the components. Now, after this Cairo and Bishop 2004 definition, there are some modifications that is being made by Howard and colleagues in 2011. So, what are those? So, changes of the laboratory parameters must be simultaneous within 24 hours. Okay, so all the parameters should occur simultaneously. Okay, because some of the parameters could be due to other causes also. Okay, so any two changes which are in the laboratory which happens, it should be two parameters change, it should be simultaneous occurring within 24 hours. Second is symptomatic hypocalcemia has to be a criterion for clinical TLS even when the decrease in calcium level is less than 25% of baseline, because calcium can be decreased in sepsis or any other causes, but it should be a symptomatic hypocalcemia. And the third is a 25% variation of the parameter is significant for the diagnosis only if it causes symptoms or if the value is not within the normal range. So basically, whatever the decrease or increase that is present, it should cause symptomatology. Otherwise, you can't tell, just seeing the values, you can't tell that this patient fits into the TLS criteria. So these are the modifications which have been made. Now coming to the pathophysiology. So we all know that tumor cell, when it lyses, it releases your calcium, phosphorus, your nucleic acids, and some inflammatory mediators. So the important one is your nucleic acid. So from the nucleic acids, your uric acid comes. So there is increased levels of uric acid which may form uric acid crystals and may get precipitated in renal tubules causing AKI, or it may be converted to a soluble form, okay, which causes injury which is independent of the crystal precipitation. So this soluble form can lead to vasoconstriction, free radical formation, inflammation leading to AKI. And apart from this, as I told, there is release of some inflammatory mediators like cytokines, which also causes AKI, and your calcium and phosphorus. So both of them combine to form your calcium phosphate, which actually get precipitated in the renal tubules leading to AKI. So the final involvement or crust goes for your kidney. Okay. So one important thing, this is just a point which I need you to remember. So there is something known as calcium into phosphate product. Okay. So when the calcium and the phosphate product is higher than 60 mg per dl, there is an increased risk of calcium phosphate precipitation in the renal tubules, leading to AKI. But if your calcium into phosphate product is over 70, it is an indication for dialysis. So why I'm telling this, usually we don't measure this product, right? So this is one of the new thing that they have seen. So any patient with TLS, try to measure this calcium into phosphate product and see whether this patient is at a risk for developing AKI, and if developing AKI also, whether this patient needs dialysis. Okay, so this is one of the early indicator of dialysis in your TLS patients. Okay, now coming to the risk factors. So this risk factors can be divided into two: tumor related risk factors and patient related risk factors. Tumor related risk factors includes what is the type of tumor that is present, what is the tumor size, the volume of the tumor. Tumors greater than 10 centimeters have a higher risk for TLS, and whether there is any evidence of metastatic disease, and tumor growth rate, how fast is the tumor growing, and how can we know that? By doing the LDH levels. So LDH levels more than 2 times the normal value indicates that the tumor is growing faster rate. Then what is the level of leukocytosis and the sensitivity to chemotherapy? Chemosensitive tumors like your germ cell tumors, small cell lung cancer, all these have a high risk for TLS. This is about tumor risk factors. Now coming to the patient risk factors. Males are a higher risk for TLS, age more than 65 years. If the underlying or the baseline serum creatinine is more than 1.4 mg per dl, if there is an underlying renal obstruction, your pre-treatment uric acid levels are more than 7.5, and any associated conditions like underlying hypotension, hypovolemia, use of any nephrotoxic drugs, or a CKD patient, all these patients are at a risk of developing TLS. Okay, so tumor related factors, patient related factors. Coming to the type of tumor, I have not discussed it. So type of tumors, you have two types. One is your solid tumors, which is associated with TLS. Most common are your germ cell tumors, neuro and medulloblastomas, small cell carcinoma and other lung tumors, breast, ovarian and vulval neoplasms, hepatoblastoma and HCCs, colorectal and gastric carcinomas, melanoma and sarcoma. Very, very high risk. All these are associated with TLS. And in hematopoietic cancers, it is acute leukemias and your non-Hodgkin's lymphoma. Okay, these are about the types of tumors. So this is just the risk stratification of the tumors. So high risk tumors are those which have greater than 5% risk of developing TLS. So in this, the most common are your Burkitt's leukemia and lymphoma. Okay, and your diffuse B cell. In that, you have your diffuse large B cell, peripheral T cell, and mantle cell. Okay, now coming to the intermediate risk, 1 to 5% risk of developing TLS. Okay, so here you have your Burkitt's lymphoma. Okay, and your lymphoblastic lymphoma. Whereas in low risk, less than 1%, you have your AML, you have CLL, your multiple myeloma, CML, all comes in the low risk. Okay, so coming to the management. So management should basically focus on identifying the patients who are at high risk to develop TLS, and important is prompt prophylaxis. There is no use of treating the patient once the patient has developed TLS, because prevention is in our hands. So try to prevent the development of TLS. So prophylaxis is more important than treatment in cases of TLS. So the key of prophylaxis is to maintain adequate urine output and to decrease the blood levels of your uric acid, potassium and phosphate. So how to monitor and when to monitor these parameters? So the monitoring of biological values are recommended to be done with the following frequency. What is that? For patients at high risk, I told no high risk tumors. So you have to monitor every 4 to 6 hours after your initiation of your anti-cancer therapy. For intermediate risk patient, it is 8 to 12 hours monitoring. Whereas for low risk patients, you can monitor once the levels of all these uh, parameters like your phosphate, calcium, uric acid, um, uh, creatinine, everything can be monitored daily. And try to avoid nephrotoxic drugs wherever possible. Okay. So the first part in prophylaxis is your volume expansion. This is all what I'm dealing is with prophylaxis. There is only one treatment slide, that's it. So everything is prophylaxis here. So volume expansion, the first one is. So crystalloid solutions are the preferred solutions because they increase the urine output and hence it increases the elimination of your phosphate, potassium and uric acid. Also, your volume expansion or IV hydration, it decreases your urinary calcium into phosphate product. Hence, it prevents precipitation of the crystals. So, how much of volume expansion to be given? So, they tell that 2.5 to 3 liters per day to adults, either by mouth or IV, for 2 to 3 days before chemotherapy. Just remember, this is the prophylaxis which we are telling of. So, before chemotherapy, 2 to 3 days before, you need to give this hydration. How much? 2.5 to 3 liters minimum per day. And you need to maintain a urine output of around 70 to 100 ml per meter square per hour. So how to calculate that meter square? I have just given the formula here. So you need to calculate this and then you have to maintain the urine output. Or approximately you should get 2.5 to 3 liters per day. That is the target urine output in these patients. Okay. Second one. Is there a role of diuretics? They are not routinely recommended because they induce volume depletion, thus compromising the renal hemodynamics and leading to further worsening of your AKI. So diuretics are only indicated in case of your symptomatic hypervolemia. And when you're using the diuretics, loop diuretics are the preferred diuretics because they increase the urinary flow plus they increase the potassium secretion. Thiazides are contraindicated because indirectly they increase the blood levels of the uric acid. Okay, so this is the role of diuretics. Now, second, role of urine alkalinization. So, initially we were using urine alkalinization in the fact that when you alkalinize the urine, so it is converted to the urate, which is easily excreted. That was the thing. But there are a lot of side effects by doing a urinary alkalinization. What are those? First, it decreases your calcium phosphate solubility and favors crystallization or precipitation in the renal tubules and other soft tissues. So your calcium phosphate is deposited everywhere. Second, when you do urine alkalinization, the alkalosis which is present, it increases the amount of calcium that is bound to albumin. So alkalosis will increase the binding of calcium to albumin. So what happens? Already there is a hypocalcemia that is present, and when you do a urinary alkalinization, you are actually further worsening your hypocalcemia. So that may lead to your arrhythmias and tetany. So because of a lot of complications that is being seen and there is no benefit as such, and there are other ways of actually preventing the TLS. Presently, urine alkalinization is not recommended and even they tell it is dangerous. Okay, so no role of urine alkalinization in TLS. Next comes your calcium supplementation. So routinely it is not recommended. Only if there is symptomatic hypocalcemia, then you can do your calcium supplementation. Okay, otherwise it's not required. Now coming to hyperkalemia. Okay, because hyperkalemia causes life-threatening arrhythmias, you should have a proper cardiac monitoring and treat it medically as soon as possible. So what are the drugs, how to treat? I think you people know it. I don't want to discuss it more. But if your hyperkalemia exceeds more than 7 millimole per liter, then I think dialysis is recommended. And you have to keep in mind that drugs which may increase the potassium, I mean, in your, I mean, example, if your feed also contains high potassium, okay, so just see wherever if you find that potassium is a source, so try to cut down that source, or drugs that might cause increase in potassium levels, that has to be stopped. Now, next, coming to your hypouricemic treatments. So we all know purine catabolism will lead to the development or formation of hypoxanthine. This hypoxanthine is converted to xanthine with the help of your xanthine oxidase. And this xanthine is further converted to uric acid with the same enzyme, the xanthine oxidase. And this uric acid is has a low solubility, and it is converted to your allantoin, which is high solubility, with the help of your rasburicase. And what does your allopurinol do? Your allopurinol inhibits your xanthine oxidase enzyme. So there is no development of xanthine, or from xanthine the uric acid. Okay, so finally your uric acid is not formed. Okay, now coming to the first drug, allopurinol. So allopurinol is a purine analog and is the isomer of hypoxanthine. So it is metabolized by xanthine oxidase to the active form of allopurinol. What is that? Oxypurinol. This oxypurinol is a competitive inhibitor of xanthine oxidase. Okay, it is not the allopurinol. Allopurinol is converted to oxypurinol. Oxypurinol is a competitive inhibitor of xanthine oxidase. Okay. So this oxypurinol, as I told, it decreases the production of uric acid from xanthine, but it has no effect on the uric acid that has already been synthesized. So this leads to a weak response to treatment in patients with TLS and severe hyperuricemia. In other words, use allopurinol only in low to medium risk patients for prophylaxis. Don't use allopurinol for the treatment of TLS nor for patients with high risk TLS. I hope you people understood. Okay, not used for treatment, not used for high risk TLS, for prophylaxis also. Okay, that is one important thing that you need to remember. Therefore, it is recommended to use allopurinol as a prophylactic treatment and not in a established TLS, where it can be used only in the cases of established TLS if the patient is allergic to rasburicase or if the patient has an underlying G6PD deficiency. Only in these cases you can use it for the treatment. Otherwise, it is only the rasburicase which is used for treatment of TLS. Okay. Now coming to the dose. So for the adults, it is 200 to 400 microgram per meter square per day. Okay, which is divided in 1 to 3 doses, and the maximum is 800 mg per day. And it has to be adjusted for the renal clearance. Okay. So that is one disadvantage of allopurinol. So if the patient has underlying AKI or CKD, you need to adjust the dose. So allopurinol, as I told, hypoxanthine to xanthine, xanthine to uric acid. But once whatever the uric acid is formed, it can't act on that. So as I told, this is used for prophylaxis, right? So when to start this prophylaxis? So this prophylactic therapy must begin at least 24 hours prior to chemotherapy initiation, and it should be continued for at least 7 days after initiation. Okay, so you're initiating tomorrow, so 24 hours before you need to start allopurinol and continue up to 7 days post chemotherapy. Okay, the disadvantages of allopurinol as it has a lot of drug-drug interactions. Okay, so you need to be very careful. Okay, even it interacts with thiazides, other chemotherapeutic drugs, some antibiotics like ampicillin and amoxicillin. So a lot of drug-drug interactions are present with allopurinol. And the side effects could be rare, but if present, they are very life-threatening. So what are the common side effects? One is Steven-Johnson syndrome. Up to tens it may go to. Liver involvement, toxic hepatitis it might cause, small vessel vasculitis, bone marrow aplasia, DRESS syndrome. So it has all life-threatening complications that can occur. Okay, so lot of side effects, lot of problems, lot of drug-drug interactions are present with allopurinol. Hence, there is a new drug that has come. We use febuxostat for just gout or increased uric acid levels. So this is one of the new inhibitor of xanthine oxidase. And what are the advantages compared to your allopurinol? There is no hypersensitivity reaction and there is no need for any dose adjustment for underlying renal disease. So the trial which has tested the efficacy of this febuxostat is the Florence trial. So this study shows that, but remember the dose of febuxostat here, a single daily dose of 120 mg per day, it is not 40 mg OD, it is 120 mg OD, was more efficient in preventing the TLS. So the dose is on the higher side. Okay, so instead of allopurinol, you can even use your febuxostat. Now next comes the most important drug for us, rasburicase. So rasburicase, it is a recombinant variant of uric oxidase. So this uric oxidase is the one which converts your uric acid to allantoin. So this is derived from our favorite fungus, Aspergillus flavus. Okay. So this was approved by FDA for pediatric patients with hematological malignancies undergoing chemotherapy in 2002, and for patients who developed TLS, this has been approved in 2009. So as I told, rasburicase should be used to prevent TLS in high-risk patients and for the treatment of already constituted TLS. So this is clear. When to use allopurinol, when to use febuxostat, when to use rasburicase. You should be clear about these. Okay. So as I told, rasburicase, it converts uric acid into allantoin, carbon dioxide and hydrogen peroxide. Why is this important for us? We thought it only converts it into allantoin, but there are two other metabolites. Okay, one is your carbon dioxide and hydrogen peroxide. Why is it important for us? Accumulation of hydrogen peroxide in patients with G6PD deficiency leads to methemoglobin accumulation leading to hemolytic anemia. That is why we are worried about rasburicase. Okay, so rasburicase, when it converts to hydrogen peroxide in G6PD deficiency, this hydrogen peroxide will not be eliminated. It gets accumulated, leading to your hemolytic anemia. Hence, they tell that before starting rasburicase, please check the patient whether the patient has a G6PD deficiency. Okay. Now, what is the dose? So, those patients where this testing for G6PD is not available, you can give a lower dose, that is 0.05 mg per kg. But the guidelines recommend that you should test for G6PD deficiency, and if it is negative, then the dose is a single dose of 3 mg. Okay, and 0.2 mg per kg for children. And the dose can be repeated daily for 5 to 7 days when necessary. What is when necessary? There is lack of response or increase in uric acid level even with the first dose. So OD dose 3 mg, seeing the uric acid levels and the response you can give for the next 5 to 7 days. Okay, clear? Now compared to allopurinol, the advantages is that it has a very few side effects, very less drug-drug interactions, and it has a very rapid effects. How rapid it is? It will lower your uric acid level within 4 hours of administration. Okay, that fast. Rarely you can see some rash, fever, headache, nausea, vomiting or hepatic cytolysis. And importantly, it is contraindicated in pregnancy, lactating women and patients with G6PD deficiency. One more important thing you should keep in mind about rasburicase is it continues to be active ex vivo. What does that mean? So even when you're taking the blood samples, so if you want to check the uric acid levels basically, so after giving rasburicase, okay, so when you delay the transportation of this blood sample, this RAS uricase will be continuously acting in the blood sample also. So there will be actually false low values of your uric acid. So how to prevent this? So as I told, it acts ex vivo, thus leading to false decreased values of uric acid if the blood sample is not immediately delivered to the laboratory in ice recipients in order to be processed in no more than 4 hours after the blood collection. Okay, so immediately tell them to process the sample. Otherwise, you will get actually low values and you will be more happy that yes, patient has responded to RAS uricase. But in fact, it is not. Okay, that is very important. Now, this is about the prophylaxis. There are future perspective. What is it? One is you can prevent through chemotherapy modulation. What do you mean by chemotherapy modulation? So, you are going to choose some less aggressive chemotherapy regimens in order to slowly reduce the tumor burden, allowing enough time for the compensatory kidney mechanisms to remove the products which are derived from the tumor lysis. Okay, less aggressive chemotherapy but efficient chemotherapy. So that is known as chemotherapy modulation. Second, other enzyme replacement therapies. Now, urate oxide, that is one. The other thing is oral recombinant urate oxidase is present. Okay, so what we are using is RAS uricase. This is usually RAS uricase will get metabolized. I mean, basically causes decrease in uric acid in the kidney. But there is one more recombinant oral uric oxidase which usually targets the intestinal degradation of urate. So small amount of urate is also degraded in the intestines. So targeting this urate is the one. So the drug is ALLN 346, it is known as. Okay, and in the pre-trials it has showed a significant reduction by around 44%. Your uric acid levels is reduced by 44% and there is normalization of uricosuriya. The other drug is your pegloticase. Basically, this pegloticase is used as a third line drug for your treatment of gout. Okay. Now, this they're also trying. It is in phase 4 clinical trial. They're also trying whether it will reduce uric acid levels in TLS. Okay. So, these are your future perspectives. Now comes your treatment. So, this is all whatever we discussed was about the prevention. Now, treatment. So, treatment, it necessitates a multidisciplinary approach and a careful monitoring. Same, you need to maintain a urine output of at least 100 ml per meter square per hour. Urine alkalization is not recommended and RAS uricase. Okay, see the dose. 3 mg as a single dose or 0.05 if there is no G6PD testing. But the dose for the treatment is different, RAS uricase. It is 0.2 mg per kg per day. Okay, but it can be given for 3 to 7 days, but not more than 7 days. So please remember the doses. It's not same. We all are in the phase that yes, the dose of RAS uricase is 0.2 mg per kg per day. It is different for prophylaxis. That too for prophylaxis, if there is testing availability or testing is not availability, and treatment. 3 doses to be kept in mind. Okay, and RRT is indicated when kidney dysfunction is aggravating despite all the medical management that is present. So this is your treatment part. Okay. So this completes your TLS. We are sorry, we are 1 hour late. So I hope you people have understood. Any doubts? Okay. If there are no doubts, so shall we end the session? So tomorrow again we will meet at 3 o'clock with some new topics. Okay. Chalo. Thank you. Good night.